بعض من وقتكم الثمين لحضوركم المؤتمر السنوي التاسع، والذي يحظى بمشاركة واسعة من نخبة من الأطباء والمختصين والأطباء والاستشاريين من داخل المملكة وخارجها، مما يسهم في إثرائه بكل جديد ومفيد. كما تقدم لكم بجزيل الشكر إلى رئيسة الجمعية الدكتورة حنان الرئيس، وإلى مجلس الإدارة الموقر، وإلى جميع المنظمين في المؤتمر من اللجان العلمية والمنظمة، وإلى كذلك جميع من شارك معنا في إنجاح هذا المؤتمر. أما الآن وبحول الله تعالى فسوف نبدأ معكم بافتتاح المؤتمر مع أولى الجلسات العلمية.
شكرا دكتور فهيد العنزي. السادة والسيدات، بسم الله وعلى بركة الله ننطلق معكم إلى جدول أعمال المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم، بالجلسة الأولى التي يرأسها كل من الدكتور رامز السويلم استشاري روماتيزم، ودكتور منصور العازمي استشاري روماتيزم ونائب رئيس الجمعية السعودية لأمراض الروماتيزم. دكتور رامز، الحديث إليك الآن.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to chair the first session of the 9th annual meeting. And time passes very fast. I still remember the first annual meeting, which was organized by Dr. Hanan and myself and the rest of the board. And during this 10 years, we have noticed and witnessed great advances in the not only in the annual meeting, but in the whole activity of the society. And during this time, Dr. Hanan was the center core and the main drive of the society. So thank you very much, Dr. Hanan. Our first session is on spondyloarthropathy. It's my pleasure to introduce Professor Suzanne Attar. She is a professor of medicine and rheumatology at King Abdulaziz University, Jeddah. She is board certified at the Royal College of Physicians and Surgeons of Canada and fellow of the American College of Rheumatology. She is a member of Ziadi Chair of Research in Rheumatic Disease and Saudi Society of Rheumatology. She is editor and published in multiple national and international journals, including the Journal of Rheumatology, European Journal of Rheumatology, and Annals of Rheumatic Diseases. She will talk about challenges in the management of psoriatic arthritis. So please, Professor.
The Vision 2030 for Saudi Arabia is to open the eye and to make it one of the wonders around the world. And upon that, the theme of this conference, as our chairman said, it's going to be the challenges in the management of rheumatological disease in general, and I'm going to focus on psoriatic arthritis in particular. So I'm going to go ahead over the case presentation, followed by the guidelines both for the EULAR as well as the GRABA and for any updates. Then the residual unmet needs, followed by the challenges in the management. And finally, I'm going to go over an update from both the ACR and the EULAR abstracts. So first of all, I would like to thank this case in the courtesy of Dr. Yusuf Narman, and I would like to thank him for sharing the management of this patient with me. This is a 56-year-old gentleman who was actually a pilot and who have been suffering from severe skin psoriasis over the past 30 years. It was so debilitating to the extent that he cannot perform his job very well. And at that time, we're talking about almost more than 30 years ago, he was managed with local treatment in addition to the oral DMARDs. Unfortunately, his skin did not improve, and at that time, he was started on in 1997 on an infliximab. He felt perfect. Wow, I have the wonder drug. And believe it or not, he was the first patient in Saudi Arabia to start infliximab infusion at that time. Then, within the second dose, he developed a severe allergic reaction in which he was managed. Despite that, they re-challenged him because it was the only medicine available at that time, and it was a good hope for him. And unfortunately, it didn't work out. Etanercept came on board, and it was started. And unfortunately, the patient did not get any benefit. Adalimumab, he did notice that his joint improved, but there was no effect on the skin. Ustekinumab was given for him for 1 year, and it worked in the beginning, but unfortunately, he developed secondary failure. All 17, both have been tried. They're available in the market. In the beginning, he felt, wow, I feel the best. I'm doing very good. Unfortunately, he developed secondary failure. Tofacitinib, JAK inhibitor, was introduced to him, giving a hope that it may help both the skin and the joint. And unfortunately, only the joint improved, but neither the skin. Unfortunately, because of the severity of his disease, he had to apply for early retirement, and he quit the job of his life that he likes. Risankizumab have been introduced, and in which he noticed that there was improvement in both the skin and the joint. And this is the picture for him before and after. And hopefully, let's cross our fingers that he's not going to get neither any secondary failure nor an allergic reaction. So when we talk about the prevalence of the domain in psoriatic arthritis, if you look at multiple studies, each one of them will give you different domains. But I like to look at one overall study or one overall real-world experience. I know better than the core Avesta registry, formerly called the Corona, in which it involved more than 19,000 study visits, almost 5,000 patients, and more than 600 rheumatologists. And you could see that both the skin as well as the joint, they are compatible to each other. Now let's look at the PSA recommendation. When I teach my resident and the fellow, I tell them there's the ACR, the EULAR, and the GRABA guideline. But the one that I really like, and I teach my trainee, is to look at the GRABA guideline. For one simple approach, it's a domain predominant. And it has been updated from 2015 up to date, and it published. What's unique about the GRABA, different from the ACR, different from the EULAR, it's a domain predominant. And it leaves the decision to the treating physician, taking in consideration the comorbidities in addition to the associated conditions shown in orange, the far right side, and to individualize the treatment. Now, when you look, in each box, there are many options with no special order. It's up to you, the treating physician, and to put in consideration what the patient fits in order to decide. So let's go over some of these. Now, when we talk about the joint, we know that all the biological therapy, they were applicable and they were approachable to the standard of care, that is the adalimumab. With the exception of the guselkumab and the risankizumab, in which both of them are comparable to the placebo. We don't have up to the standard of care yet. So where is the difference? Since all of them is almost similar within the joint, it's in the domain. And that's what you have to look for in the patients. So for instance, in axial disease, up to my knowledge and up to now, the Maximize trial is the one and only study that showed that there is an efficacy within the axial PSA compared to the placebo. We know that there have been a study, which was a failure study, for the IL-12/23 inhibitor for ankylosing spondylitis. Based on that, the FDA did not approve any of the medication that contain or inhibit the IL-23 until there's a specific study in which the primary endpoint is the axial involvement. And if you would like to learn more about the Maximize trial and the Cosentyx, please join me for today at 2 p.m. for the Satellite Symposium. Let's talk about the residual unmet need. We all know, despite all the medication that we have that have been introduced since '99 in Saudi Arabia and in the Arab world, there's still unmet need for the patient. As such a patient, they don't meet full remission. We know it's very difficult to be achieved. Even low disease activity, it's hard to achieve. But I would like to look at one point. Look at the references. The maximum reference over there for any study about the residual unmet need, it was published in 2019.
which means, look at the timeline. That's the line when the ALT-17 have been introduced, and it was still intravenous. We didn't use it much at that time. Then we went through the COVID pandemic. Actually, the ALT-17 and the rest of the medication came widely to the world after the COVID pandemic. So right now, we have more than 10 biological therapy for psoriatic arthritis. So we need a new study depending on the new availability of the medication. The second unmet need, despite what we do for treatment, still the patient, they are complaining from pain, almost 90%. And that have been shown in the registry. We'll talk about it later on. Is it related for the disease or something else, or is it even fibromyalgia? The third unmet need, which we all see in the clinic, is the needle phobia, in which the patient, they preferred oral medication, and even more infrequent route of administration. But again, if you look for the frequency of the route of administration, it was at that time every 1 month, and there isn't yet every 2 to 3 months. So let's go over the first challenge. It's the personalization of choice of therapy in psoriatic arthritis patient, and what I call it as precision medicine. This is what we all do in the clinic. Whenever you have any patient in front of you, you will take into consideration the comorbidities, the associated condition, and the patient preference, and then what you actually have and the safety in your hospital. This table is to help you. It was published actually in 2020 based on the EULAR guidelines. Come on, it's 2 years ago, almost 3 years. We have more medicine since then. So let's update it, and actually there haven't been one. With the help of the medical team from AbbVie, as well as from Janssen and from Novartis, I created this table. Please feel free to take a screenshot from it. So the first challenge is to know. طبعاً الجهل عدو الإنسان, and we have to increase our knowledge in order to know how to help our medicine. And if you could see in the first 2 lines that the TNF inhibitor, in addition to the ALT-17, they lie with the same lines that they treat all the domain and cover them. Of course, you could see with the exception of the etanercept for the associated condition. We talked already about the AL23 and the AL1223 inhibitor, that there is no recommendation for the axial PSA. So I'm going to go over a case with you that I saw a couple of months ago. He was a 19-year-old boy, so he's not a boy, he's a man. But he came to the clinic with his mother because he developed a viral encephalitis just a couple of years ago that unfortunately left him a bit of mental retard. So in other words, he's almost like a pediatric patient. And we are all blessed, honestly, as an adult rheumatologist, we're not like our pediatric colleagues in which they have to deal with the patient and the parents. So this is one of the challenges in such a patient, that you have to deal with the parents as well. So his story was the following. He was having a joint, he was having skin, as well as axial disease. And he was on TNF inhibitor, but it wasn't doing a great job. But that was as good as it gets. That was what we had at that time. So when the AL-17 were available in the market, it was rechanged. And he said that his skin totally improved, and he felt very good with regard to the joint. On follow-up visit to his rheumatologist, they noticed that he was having enthesitis of the Achilles tendon, and it was ultrasound confirmed. And they decided to change it to the AL-12 and 23 inhibitor. So his mom, she came to me for the consultation, tell me, what should I do? He's having a severe back pain, an MRI, and it was confirmed that he's having the sacroiliitis, which is active. So let's apply this, and she was requesting to go back on the Cosentyx. Let's apply this patient to the table. So this patient, his domain are the following. And with regard to the AL-12 and the 23, there's no recommendation, and as we said, it was a failure study with regards to the axial PSA. When we talk about the precision medicine, this is a not new concept. This concept has been going on over the past couple of years. And whenever I go to the American College of Rheumatology, I know the Japanese people, they have a special interest in that. And they have been doing multiple flow cytometry tests. And I presented this in all my lectures within the update in the ACR. Now this year, they upgraded their study. In addition to the flow cytometry, looking at the T helper cell 1 as well as 70, they actually divide them into two groups, the standard of care in addition to the precision and medicine. Is it a surprise that the patient with the precision medicine, based on the flow cytometry, they did better with regard to the ACR improvement? Perhaps not in the skin, but yes, indeed, in the ACR improvement. The problem of this, it was randomized. The two arms were not equal, and it was a small study. That's why keep your eyes open for the next EULAR, for the optimized trial, in which patients with PSA have been randomized with flow cytometry to receive either treatment, the TNF inhibitor as well as IL-17, and perhaps more cytokines and more treatment option. This go with the concept of precision medicine, predictors of response. This is we have been going on and searching over the past 10 years. Why? In order to prevent the restarting of medicine, the recycling of medicine in the patient, and perhaps they will get morbidities from it. The second challenge is the management of the associated comorbidities or conditions. Now, we know from previous cohorts, such as the CATCH, that patients, PSA patients with comorbidity, they have a worse outcome. What does that mean? They do not respond to medication beautifully as we intended. And the GRABA, as well as the EULAR, have been recommended to treat the comorbidities and refer the patient to the proper specialty accordingly. Now, this table, it presents the comorbidities that the GRABA and the EULAR, they requested to look for, specifically heart disease, liver disease, and no wonder, depression and central desensitization syndrome. So let's go over a couple of examples. Now remember, this table is opinion-based. It's not based on systematic literature review. The first table of the GRABA, it was based on the systematic literature review, but this is not. It was opinion-based, and I know that a couple of you may have a problem with it and may disagree. So let's go over a couple of examples. For instance, they state here that the DMARD in the form of the methotrexate as well as leflunomide is contraindicated and to be avoided in patients with fatty liver. We do have a couple of us fatty liver patients in which they were started on such a treatment, and with the follow-up with the hepatologist and doing the proper screening and the follow-up, they're in a great condition. Number two, we know that the TNF inhibitor, they're associated with high signals of TB, and we're taking the precaution of that. Studies have not been shown that the IL-17, the IL-12-23, or the IL-23 are associated with increased risk of TB. You know something? We're in an endemic country, we still take precaution, and they did label it based on the Saudi FDA approval that take the precaution for the TB. The TNF inhibitor have been stated to be avoided in patients with CHF as well as with demyelinating syndrome. And finally, there's the JAK inhibitor, the era of the treatment, in which because of increase, there's a perhaps increase of the risk of the DVT-PE. Based on the USA, it have to be given after the TNF inhibitor inadequate response, but in the UE, after the convention, no, DMARD, excuse me, inadequate response, putting in consideration the risk factors. Number three, treatment sequences and combination. Do we know what's the best sequence to start in such a patient? Unfortunately, no. We go based on the trials that we know, based on that you have to start TNF inhibitor first and then the treatment. It's not evidence-based. It's not systematic literature review-based. It's based on the randomized trial, and because we know how to deal with TNF inhibitors because they have been in the market almost for 15 years. So what about the combination? Actually, the combination of the biological therapy, it's not a new concept. For those who have been in the 90s, late 90s, early 2000, they know it's not a new concept. It has been tried in the past with etanercept anakinra in addition to the TNF inhibitor and abatacept. And there was increase in the risk of infection with no much improvement, about the double, 3 to 6% increase in risk of infection. You will say in your mind, well, 6% is not a lot if the patient was getting better. But given the fact the patient did not get better, they consider it as no, and nobody talked about it. Over the past couple of years, people have been digging their toes. They have been sneaking in and looking into that. And you know what? Our colleagues from dermatology as well as GI, they have been doing a better job than us because they have a very devastating patient who have severe IBD with a spa involvement, axial or joint. They used combination therapy in the form of the guselkumab and the golimumab in the Vega trial that have been presented in the ECHO meeting last year and the year before. And you could see the results. The combination therapy did better. What about the side effect? That's what I care. The side effects of infection, actually, it wasn't that much higher. So this is something to look into. Now, in Spain, they have been doing a small studies last year and this year. They have been looking at the combination therapy. Remember, the targeted treatment, the more specific, we hope the less likely that the patient will have side effects. So those IBD with SPA patient, severe cases, and the number of the cases, they were actually a bit higher than the authors. And they used multiple regimens, IL-17, IL-23, IL-17, IL-12-23, and IL-17, in addition, or TNF inhibitor and the targeted synthetic DMARD. Third of the patient improved, third of the patient actually minimum, and actually third did not get worse as well. The side effect, only 2 patients, in which one of them, they have severe chest infection, and the other one is bacteremia. There's an ongoing trials, and you could look at it in clinicaltrial.gov. It's called the Affinity for the combination of golimumab and guselkumab in patients with PSA. The fourth challenge, pain in PSA. Is it fibromyalgia or enthesitis? Please do not over-diagnose your PSA patient with fibromyalgia unless you examine the enthesial point. I have been talking to many MSK radiologists around the world, people from the SAS, people from the EULAR and the GRABA. I tell them, listen, I'm not talking about the large enthesitis, the Achilles tendonitis, the plantar fasciitis, which is easily to be diagnosed. I'm talking about the small body enthesitis that even if you went to the best MSK radiologist, he will tell you it's hard to be diagnosed. I cannot detect it by an ultrasound or even an MRI. So keep it in your mind. Because enthesitis, it's the phase before the joint involvement. And we all have in our practice, many patients have been misdiagnosed with fibromyalgia, and then they turn to have a severe PSA. So what I teach my fellow always, well, if you have an enthesitis, this means that your response will be less. And please look for the enthesial point as well as the fibromyalgia point. And keep it as a high index of suspicion. Challenge number 5, can we stop medication? I will just share with you one of my patients. Actually, she came for a second opinion, a young lady who had been on DMARD, did not improve, switched for TNF inhibitor, improved, stop. Went to another TNF inhibitor, adalimumab first, then etanercept, improved after 1 year, stop. It failed. Right now she's on Cimzia. And she came to me and she told me, Doctora, what should I do? I remembered immediately that PSA patient, the recommendation have been stated, if you stop them, there's 50 to 100% flare up. So per the GRABA guidelines, you have to be very careful when you taper such medication, and it's a patient-physician shared decision. I'm just going to go over updates quickly from the ACR and the EULAR. I'm not going to go into detail, just the thing, practice changing. You know something? Across the world, even in the UK, there's still a delay in the diagnosis of PSA. There's underuse of the DMARD. And what not better than telling our colleagues from different specialty use a screening method in which one of them is the past. They will tell us, well, we're a busy clinic. I say, it's fine. If you have one patient with high risk to develop PSA, it's going to be your obese patient. Choose from all the 20 in your clinic, just the obese, and screen them for past. We always have been looking if there's any way for a patient with severe PSA that we could prevent PSO, that we could prevent PSA, and we couldn't. But actually, please pay attention. There's an oncoming trial called the PAMPA trial in the next EULAR, in which patients with severe PSO have been giving TNF inhibitors or biologic, and they got better. What about cycling versus switching? Which one is better? There wasn't much difference between either. But when you look at the retention rate for different mechanism of action, it did better. And the IL-23 was not better than the IL-17. Because of our patient do have many comorbidities and cardiovascular risk factors, so you wonder, what about if I did, like for an example, if my patient has severe PSA, they will have cardiovascular disease. In Toronto, Canada, they applied the cardiovascular risk estimate, including all the PSA domain, and actually it did not make any difference. So the take home, do a cardiovascular assessment on your regular basis, like what you exactly do in internal medicine. Nothing is specific, and your patient will be fine. Now, the last thing is with regard to the risankizumab. The risankizumab, actually, there have been post-hoc analysis with regard MTX inhibitor, is it better versus not? If they were in methotrexate, long-standing disease, and the subgroup analysis didn't show any different, so it could be a monotherapy, early versus late disease. And I would like to ask you to join us on Friday for the satellite symposium, and it's going to be a unique one, because they're going to be one of my colleagues that I'm proud to present with from dermatology from King Saud University, and we will have a shared physician decision. So let's go back to our patient. What happened to him? Unfortunately, he started to have renal impairment, and actually he was diagnosed by nephrology to have IgA nephropathy, and unfortunately he ended up in dialysis. Myself and the nephrologist, by systematic literature review, actually, the multiple biological treatment have been associated with many morbidities, in which one of them is renal failure that is severe to end up in dialysis. And I'm proud to say that we had a meeting yesterday in the SSR committee, and we are conducting a study for patients who receive multiple biological failure to look at their outcome for the morbidities in particular. So in summary, PSA management, it has to be per recommendation, and the best is domain approach, whether it was the GRABA or the EULAR or the ACR. Consider, please, the related condition as well as more comorbidities, and be aware, the best treatment, be aware of the evidence, be aware of the specific involvement and the specific domain, because as you also know, that the IL-17 and the TNF inhibitor, they lie in line with the same table. Please avoid overtreatment in our patient in order to prevent morbidities. Thank you so much for your attention.
Thank you, Prof. Suzanne. As usual, nice presentation. دائما يقال ختامها مسك لكن لا الحمد اليوم من البداية مسك. Now it's my pleasure to introduce the second speaker, Dr. Ibtisam Al-Mghisi. She's a gastroenterologist consultant, head of the division at Prince Sultan Military Medical City, director of adult gastroenterology fellowship. Dr. Ibtisam, you are welcome.
لا اي بس بغير سلايد. I will stay here بس شلون بغير سلايد next slide. اغير هنا. Okay, I'll go back شلون كذا. Okay, yeah. Okay. بسم الله الرحمن الرحيم. Good morning, and I would like to thank Dr. Hanan Reyes, the organizing committee, Dr. Fahid Al-Anizi, and Rheumatology Society, Saudi Society of Rheumatology, for inviting me to give this talk as a bridge between gastroenterology and rheumatology. And I hope you enjoy it. So today I was given the task to talk about the screening of inflammatory bowel disease and spondyloarthritis for patients between rheumatology and gastroenterology. So to attract everyone's attention, we would like to start with an interesting case from a gastroenterology clinic. A 33-year-old woman with 8 years history of Crohn's disease. She has 2 young children, toddler and baby. She has noticed increased morning back pain, which is causing poor quality of life, and mild increase in her GI symptoms. Her GI symptoms include 3 semi-solid bowel movement with no bleeding or abdominal pain. She has been on Imuran 100 milligram per day for the last 5 years for Crohn's disease, and she has previous exposure for 5-aminosalicylic acid, and she received a course of a steroid in the past prior to starting Imuran. With no hospitalization, no perianal disease, and no skin or eye manifestation. So what we will do next? So before we decide what we'll do for this patient, let's go over the objective of my lecture today. We'll go over overview of inflammatory bowel disease, what are the types, pathogenesis, signs, epidemiology, diagnosis, and later we'll talk about extraintestinal manifestation of inflammatory bowel disease, and we'll talk about the relation between inflammatory bowel disease and spondyloarthropathy, and when to suspect inflammatory bowel disease in spondyloarthritis patient, and the opposite, when to suspect spondyloarthropathy in IBD patient. And at the end, we talk about the treatment of spondyloarthropathy and inflammatory bowel disease, and I'm sure you know most of you, they know that we share most of the medicine and biological together as gastroenterology and biological and rheumatology. So what is inflammatory bowel disease? As with the autoimmune rheumatological disease, it's chronic, relapsing, and remitting inflammatory status in the gut that gastroenterologists usually, generally, they divide it into 2 main categories: ulcerative colitis and the Crohn's disease. Ulcerative colitis is primarily affect the colon and the rectum with diffuse inflammation and shallow erosion, and the Crohn's disease affect any portion of the GI with more of a transmural aggressive involvement. And there are other minor categories like intermediate colitis and microscopic colitis, but usually you cannot differentiate between Crohn's and ulcerative colitis. So what are the difference? As you see in the first endoscopic picture, I don't know whether I can point. The first endoscopic picture, you see the colonoscopic view of Crohn's disease, where there's transmural ulcer. And the second one, you can see the ulcerative colitis with more diffuse ulcers, small ulcers in the colon. So what is the difference between Crohn's and ulcerative? Mainly the distribution of the disease and the pathology of the disease. As we mentioned, this is more of the ulcerative colitis affect the mucosa and submucosa. Crohn's more affect the transmural of the wall. So what are the clinical symptoms, the difference between Crohn's disease and ulcerative colitis? In ulcerative colitis, it's mostly bloody diarrhea. So you keep it in your mind, it's mostly bloody diarrhea. And the Crohn's, there's no blood in the stool, most of the cases, only diarrhea. In the ulcerative colitis, there's urgency. Urgency, it means they patient cannot hold to go to the bathroom. They sometimes have like incontinence. And also they have lower abdominal pain and anemia. In the Crohn's disease, they have more aggressive symptoms like weight loss, anemia, malabsorption, nutrition, perianal disease, fistula, fever, perianal infection, abdominal mass. So Crohn's disease is a more aggressive form of inflammatory bowel disease. So again, as we mentioned before, we have more fistulas, more of deep fissure, perianal involvement with the Crohn's disease. So what are the pathogenesis of inflammatory bowel disease? That pathogenesis we share mostly with other autoimmune, whether it's rheumatological disease or neurological disease, and it's constellation of factor: genetic, environmental, intestinal barrier, and immune response. In genetics, we have 300 candidate genes that identified to increase susceptibility in ulcerative colitis and Crohn's disease, or both. Estimated around 20 to 25% of genetic risk. There's certain gene called NODS2, increased risk of Crohn's disease, and not only Crohn's disease, increased risk of complication of Crohn's disease. This is the genetic part. The environmental part, this is, we always talk about smoking, and interesting about smoking, that smoking increase risk of Crohn's, but decrease the risk of ulcerative. And even sometimes patients with ulcerative colitis who failed all type of medicine, they tried by themselves to take a nicotine patch, which is interesting finding. Also diet, and I'm going to talk about this diet later, medication, microbiota, and also change of immune response like innate response, cytokines, effector cell, regulatory cell, and change also in intestinal barrier like increased permeability, change of goblet cell, autophagy, and dysbiosis. And by dysbiosis, we mean imbalance of bacterial flora that usually occur in the gut. Other miscellaneous causes like stress, and interestingly, and maybe you noticed also with rheumatological disease that the first presentation of inflammatory bowel disease, it happened after a major stress that patient go through. Also, breastfeeding. Breastfeeding, usually it's a protective factor, although it's a weak, but still it's a protective factor from inflammatory bowel disease. So just a few more words about genetics susceptibility. Patient with family history of IBD, the risk increase 5-fold. The risk will be 5 to 15%. Family history, it's almost, it's more common in Crohn's than ulcerative colitis. Clinical pattern of disease also increased by family history. They follow the family history pattern of the disease. And also, interestingly, they found not only the family history increased risk of inflammatory bowel disease, but also increased intestinal permeability in the first degree relative. The risk is 2 to 5% in the sibling, and parent 1 to 5%. If one parent is affected, the risk is 1 to 4%. If two parents is affected, 36%. And interestingly, the risk is higher from the mother. If the mother has inflammatory bowel disease, especially in Crohn's disease, the risk is higher than if the father has Crohn's disease. And also, a twin study in IBD found the risk is higher in Crohn's disease, where you can see it's 58%. I don't know how can I point this? Can I point? Yeah. So as you see in identical twin, the risk is 58% for Crohn's disease. So the risk is much less in ulcerative colitis. And as we know, Ashkenazi, they have the higher risk, is 8 to 9%. And prevalence varies in population, according to the population. So what about the diet? As with the globalization, modernization, not only we adapted the Western lifestyle and the diet, we also adapted their disease as well. So with Western diet, which is high in fat, low fiber diet, high fat protein, and omega-3, omega-6 polyunsaturated fat and sugar, the risk increased in inflammatory bowel disease, where the healthy diet, the risk is less. Healthy diet, we call it Mediterranean diet, which is high in fiber, high in fruit, high in vitamins, and especially vitamin D. So as you see with the Western diet, we have destruction of mucosal barrier and increased mucosal permeability, and I will talk about this later. What about global incidence of IBD? As you see the northern globe, you will have higher risk in in Canada, in USA, in Northern Europe, and also New Zealand, they have the highest risk. We are still in the medium risk, but as with other autoimmune disease, you see that we have increasing number in all autoimmune disease, including inflammatory bowel disease. So we are still in low, but I'm sure we'll be in the medium soon because we are seeing double the cases that was seen a few years ago for IBD. But unfortunately, we do not have registry, national registry as well. So the risk overall for IBD, it's 35 to 100 per 100,000 for UC, and 10 to 100 per 100,000 for ulcerative colitis. Sorry, the opposite. For the Crohn's is 10 to 100, and for the UC is 35 to 100. Peak age of incidence, we have two incidents. Peak, the first one is 15 to 25 years old, and the second peak is 60 to 70 years, and same with other autoimmune, I think, with disease. The mortality is a little bit higher for inflammatory bowel disease, and risk of also colorectal cancer is higher in inflammatory bowel disease. What about IBD in Saudi Arabia? We have interesting study published from King Faisal Specialist Hospital in 2012. They compared the referral for IBD in their center before 1980 and up till 2008. And as you see, the number is coming up every year. Every 10 years, the number is doubling, both for UC and Crohn's disease as well. So how we can evaluate and diagnose IBD once we suspect it? We have to go over the history, evaluate family history, and then we do lab tests for serology, we do antibody, we do fecal calprotectin, and we have to exclude, of course, other disease that mimic IBD, like infection, and assess for GI inflammation. And then we go for endoscopy. We have two types of endoscopy. We can do the regular upper and lower endoscopy. And we go with upper because, as we mentioned, the Crohn's can affect upper GI endoscopy, upper GI. So we do upper and lower. And we can do also capsule endoscopy, which is a new form of endoscopy. It is good for diagnosis of IBD, but you cannot take biopsy with it. And also it's contraindicated if you suspect stricture or perforation. After that, we go for radiology to assess the small bowel. We have MRI, we have CT, and also we have a new modality, which is ultrasound, endoscopic ultrasound, to assess for disease activity in IBD. So here I was invited to talk about the extraintestinal manifestation of IBD, which is the most interesting part for you, which is that IBD can affect other systems, not only the GI. We have eye involvement, lung involvement, skin involvement. We have uveitis, pneumonitis. In dermatology, we can affect aphthous stomatitis, bioderma gangrenosum, erythema nodosum. Also, it can affect the liver, primary sclerosing cholangitis, and it can also cause thromboembolism, and it can cause spondyloarthritis, which can be axial or peripheral. So about 25% of patients with IBD can have extraintestinal manifestation. We have group 1 of extraintestinal manifestation, which is either divided to that extraintestinal manifestation that parallel disease activity, or extraintestinal manifestation that does not parallel disease activity. In other words, extraintestinal manifestation that got active when the disease is active, the bowel disease is active, or that does not parallel, and it can even precede the diagnosis of inflammatory bowel disease. The extraintestinal manifestation that parallel disease activity are type 1, peripheral arthritis, erythema nodosum, aphthous stomatitis, and episcleritis. And those usually respond to the treatment of the bowel. So whatever you are going to treat the bowel, these extraintestinal manifestation, they will respond to it. The other category that of extraintestinal manifestation that does not parallel the disease, the bowel activity, are bioderma gangrenosum, uveitis, axial arthritis, and primary sclerosing cholangitis. And usually these, they have to consider different treatment. And as I mentioned, these or extraintestinal manifestation can precede the diagnosis of inflammatory bowel disease itself. What about complication? IBD can present with complication, like with rheumatological disease, like malnutrition, and this is more common in Crohn's disease, osteoporosis, osteonecrosis, renal like nephrolithiasis, obstructive uropathy, secondary amyloidosis, hematological disease, thromboembolic, pulmonary chronic bronchitis, bronchiectasis. So how common is arthritis in inflammatory bowel disease? Arthritis occur in 15 to 20% in Crohn's disease and 10% in ulcerative colitis. Male and female, they have equal risk. Usually asymmetrical migratory large joint arthritis affect the knees and ankles. Symmetrical, this is the interesting information, that symmetrical polyarthritis occur in a few IBD patients, and which is the type of arthritis happen in rheumatoid arthritis. Ankylosing spondylitis affect 1 to 6% of IBD patients. Cartilage and bone destruction that happen in rheumatological disease is rare in this case. So we have two types of peripheral arthritis, bossy and polyarticular arthritis. And the first one, the bossy articular, usually parallel the disease activity. The polyarticular, it's persistent symptoms of a median of 3 years, independent of disease activity. And for polyarticular, usually increased risk of uveitis. So as you see, the classification of arthritis and IBD, we have arthralgia, axial arthropathy, dactylitis, and enthesitis. And I will cover this later, so I will move. So the roots of arthritis in IBD patient. Usually arthritis in IBD patient is seronegative spondyloarthropathy. That means there's no antibody in those cases. And researchers suspect that IBD may be due to genetic predisposition and exposure to luminal bacteria. Ankylosing spondylitis associated usually with HLA-B27. And this allele is less common in patients with IBD. And peripheral arthritis in IBD has a strong association with HLA-DR107, 103, which is present in 35% of patients with large joint arthritis, and up to 65% of the patient who have more than one episode of large joint arthritis. Spondyloarthropathy is the most frequent extra-intestinal manifestation. This is very important, the most frequent extra-intestinal manifestation by far, and occurring up to 10 to 39% of patients with IBD. Symptomatic IBD, the opposite, symptomatic IBD occur only in 6 to 14% of patients with a spondyloarthropathy. And there is a category called silent IBD, which is microscopic inflammation of the intestine, but there's no clinical manifestation of IBD. It occurs, it's very common, up to 60% of spondyloarthropathy. But despite this information, we should not screen all patients for IBD. It's not necessary to do for all patients with spondyloarthropathy colonoscopy or ileocolonoscopy. You don't have to screen every patient. I have 5 minutes, please. I'm still, but treatment, I have to cover treatment, okay. So I have to move on. Maybe then I have to skip some of these. Okay. So just one word about ankylosing spondylitis and IBD that, as we mentioned, it is HLA-B27 is less common. And this is very interesting study from Taiwan. They studied the risk of IBD in ankylosing spondylitis patient, and they found the IBD in ankylosing spondylitis patient is less common than non-ankylosing spondylitis control group, which is very interesting because they studied 12,000 control patients and 3,000 patients with ankylosing spondylitis. I will have to skip this. So what are the red flags when you refer patient to rheumatologist and when you refer patient to a gastroenterologist? The red flags for IBD in spondyloarthropathy, including abdominal pain, chronic diarrhea, and usually it should be more than 3 months, more than a 3 months period, rectal bleeding, family history of IBD, persistent fever, anemia, weight loss, and history of perianal disease. And when to refer patient to rheumatologist, those who have IBD, if there's back pain that's worsened with rest and get better with exercise, and dactylitis or enthesitis. And there are similar Spanish and Italian recent studies, all they confirm the same red flags. I have to move here. We have to consider this because there's usual delay in diagnosis of ankylosing spondylitis patient about 7 to 8 years, which is a long history of delay before the patient is diagnosed. And if you consider, and I'm not going to sit here and lecture you about how to diagnose spondyloarthropathy, but the MRI is the best modality and the gold standard. Just a quick word about treatment that we share with rheumatologists. Methotrexate and sulfasalazine that works for rheumatoid arthritis and IBD does not work in spondyloarthropathy and mainly in ankylosing spondylitis. Non-steroidal anti-inflammatory drugs, it has good role in treatment for ankylosing spondylitis and IBD. Usually there is inherited risk of a scare about non-steroidal that can flare the IBD symptoms. But interestingly, the two recent randomized control trials confirmed there's no increased risk of a flare in patients who receive non-steroidal drugs. So COX-2 inhibitor is good first-line treatment for those patients. So this is good, comforting data. What about TNF blocker? We have TNF that we share with rheumatology. I have to go here quickly. Including infliximab, adalimumab, golimumab, and Cimzia. They all work in both IBD and gastroenterology, inflammatory bowel disease. Those who had good indication, Remicade and adalimumab. Otherwise, the etanercept, which is Enable, is not effective in IBD. It is effective in AS, so you should not consider it in patients with IBD. And you should avoid it in patients with IBD. And also interleukin-17 inhibitor. It's well-recognized treatment for ankylosing spondylitis, but it will exacerbate IBD, especially Crohn's disease. So you should avoid it. And quick word about ustekinumab, Stelara. It might be effective for ankylosing spondylitis and spondyloarthropathy, and it is approved for both ulcerative colitis and the Crohn's disease. Vedolizumab, which is the gut-selective adhesion molecule inhibitor, it works very well in ulcerative colitis, and also it was given approval for Crohn's disease, but it does not work in arthritis, and it has even minimal effect on extraintestinal manifestation IBD. JAK inhibitor, I know that it's newly approved for ankylosing spondylitis 2021. It was approved for UC, and we have the obaticetinib recently also. It works in rheumatoid, it works in ankylosing spondylitis, and it works also in ulcerative colitis. It does not work in UC, and Crohn's disease. It's not approved. One interesting information, the last I will close with it, from Dr. She mentioned, Prof, I forget the name. She mentioned earlier about combination of biological therapy. And as we know that combining biological is a focus now of a new clinical trial, I know from rheumatology data there's a lot of toxicity, talk about toxicity. It works very well in gastroenterology so far. And we have anecdotal experience combining vedolizumab and other biological, whether it's anti-TNF or ustekinumab, or even with the tofacitinib. It works very well tolerated in gastroenterology so far and inflammatory bowel disease. So just to take a look at the end picture here, that medication that works for both spondyloarthropathy, biological, and IBD, including anti-TNF, tofacitinib, which is JAK inhibitor. So I will conclude in summary that rheumatologists need to suspect inflammatory bowel disease to prevent irreversible damage of the bowel early. And we have always to ask, and I know it's difficult sometimes, but try to ask in your clinic about bowel symptoms, especially if it's persistent and more than 3 months. Identifying the risk for IBD and spondyloarthropathy, clinical and lab. In the future, we have to talk more about elucidating the complex interaction between microbiome in the gut, as well as the, what we call intestinal leak, which release the inflammatory toxin into the bloodstream. And maybe we have to consider looking at interleukin 23 specifically, that works in both IBD and rheumatological ankylosing spondylitis and spondyloarthritis, and JAK-STAT inhibitor. Thank you very much.
Our next speaker is Dr. Proton Rahman. He's a practicing rheumatologist and a university research professor at Memorial University. His clinical and research interest in spondyloarthritis, his research expertise in genetic epidemiology, and his original contribution include identification of novel candidate gene structural variants, and more recently pharmacogenomics in rheumatic diseases. He is one of the original founder of the Spondylitis Consortium of Canada and associate editor for the Journal of Rheumatology Spondylitis section. So please, Dr. Porter.
Good morning, everyone. It is an absolute pleasure here to be in the Kingdom. I'd like to thank Dr. El-Rayes and also Dr. Al-Azani for the very kind invitation to present here, the chairpersons, and thank you again for coming. So the task that I was actually given, thank you. The task that I was actually given was to give you an update regarding the 2022 guidelines, the management guidelines for axial spondyloarthritis. These are my relevant disclosures. So my objectives are twofold. First of all, discuss what's new about the 2022 guidelines and how it can actually help us manage patients with axial spondyloarthritis. And secondly, and respectfully, I'd like to clear up some of the confusion regarding the first treat-to-target study in axial spondyloarthritis, because it did not meet its primary outcome, and I think it has to be put in proper context. So those are the two things I'd like to do over the next 20 minutes. So just a case to ground us, and just for the sake of time, this is a 32-year-old lady that's got non-radiographic axial spondyloarthritis. She's got inflammatory back pain. It's affecting her function, and she's having difficulty at home as well as working as a nurse. She's B27 negative. CRP is normal. Pelvic radiograph does not show sacroiliitis, but thankfully, her MRI showed active bilateral sacroiliitis. So there's a suggestion that this is axial spondyloarthritis. She was initiated on adalimumab, and she's got a partial response. She feels better, is able to move a little bit better, is sleeping a little bit better, but is still having issues in terms of functioning. When she did her ASDAS score prior to initiation of biologics, it was 3.3. A repeat ASDAS at reevaluation at 4 months was decreased by 1 point, so it was 2.3. So the question is, can the present guidelines help guide us in terms of what to do? Do we switch therapies? Do we continue with the adalimumab? Do we potentially increase the dose of the adalimumab? So let's look at the guidelines to see if there is any help that we can actually get. So the first thing regarding the ASAS-ULI recommendations regarding management is that this is an update. As you may be aware, it was initially conceived in 2006. It was refreshed in 2010, And in the most recent, prior to this particular update, the most recent one was in 2016. Lots happened between 2016 and now in terms of emergence of new classes of therapy, as well as change some of the construct in how we actually think about axial spondyloarthritis. So it was very timely to have an update and discuss what's new. So when you actually do a management guideline, what's there are 5 overarching principles which have not changed at all. We'll just touch on it based on one slide, because if it gives you a general sense of what it is that you actually want to do when you are managing axial spondyloarthritis. In total, there are 15 recommendations, 8 of which have not changed, 3 had minor changes, 2 had relevant updates, and we're going to look at these a little bit more, and 2 had new recommendations, and we'll certainly touch on those. So in terms of methodology, just very quickly, they followed the EULAR standard operating procedures, which were developed in 2014. So they did 2 systemic literature reviews. One looked at the efficacy and safety of non-pharmacological as well as non-biological interventions, and the other regarding the efficacy and safety of biologic DMARDs. There was a task force meeting that occurred virtually over a day, and the level of evidence and the grade recommendations were reported according to the Oxford Evidence-Based Medicine. And based on the experts, they looked at the level of agreement from 0 to 10 and the percentage that had at least 8 out of 10 improvement. So these are very standard. What were the overarching principles? So it's nice to go over it again, that for axial spondyloarthritis, it is a systemic disease. There are multiple disciplines that are involved. And we should have a multidisciplinary management that's coordinated by the rheumatologist. You don't have to do everything, but it's nice to have a team around you to actually look after these patients. Not only are we interested in signs and symptoms, but we also want normalization in terms of function and social participation, both at home and at work. We should think about management globally, non-pharmacological as well as pharmacological treatment. It's important to get the patient's perspective. So this issue of shared decision-making, as it was noted by Dr. Attar, is very, very important. And finally, unlike the ACR guidelines, the medical as well as societal costs were put into perspective. So this is not solely about the patient. This is about the global or societal good as well, and that was considered in some of their decision-making. So it's a difference in terms of some of the 2 different guidelines that are the most commonly cited. So when you actually look at the table, what I'm going to do is just look at this in slightly more detail, but I want you to respectfully make you familiar with the table. And the thing to get from this particular table is that there are 3 phases that are there in terms of the management recommendations. So what's the first phase? The first thing to remember, we certainly have classification criteria for axial spondyloarthritis developed by the ASAS group. But please remember, these are classification criteria for putting patients into clinical trials. You are the gold standard when it comes to making the diagnosis. Axial spondyloarthritis is a clinical diagnosis determined by the rheumatologist. If you make the diagnosis, it's proper to tell the patient this is what they have, because the more the patients know about what they have, the more empowered they'll be, and the more educated the patient is. That is really what provides the best outcome in terms of patient. Second thing is to make sure that they have regular exercise and they improve their lifestyle, particularly in terms of non-smoking. One of the minor changes that has occurred is that previously physical therapy was encouraged. It is still encouraged, but some people misused physical therapy as knife treatment or needle treatment and all sorts of alternatives. And they wanted to specifically state what they meant, which was physiotherapy. So the term physical therapy is now changed to physiotherapy, and this was done by design. So if you have axial spondyloarthritis and you're symptomatic, you try anti-inflammatories initially on a PRN basis. If you continue to have symptoms, you increase the dose and take it on a regular basis. If it hasn't worked for a couple of weeks, you can try another anti-inflammatory agent. So that's typically what we do. So what happens when you continue to have symptoms despite 4 weeks of NSAID management? Then you look at the patient critically and you ask yourself, do you have an elevated CRP, or do you have an MRI that shows inflammation? Why are they looking at this? Because these are predictors of good biological response. And historically, they've also looked at radiographic sacroiliitis. Even though this is not necessarily a predictor of good response, this is maintained in terms of things that you actually look for prior to initiation of biologic therapy. How high does your disease activity have to be? Previously, we used a BASDAI score of 4 or greater. Another change that's occurred now is instead of the BASDAI, they would prefer to use the ASDAS of 2.1 and greater. Why the ASDAS? Because it does have an objective measure of inflammation, which is the CRP. Also, the ASDAS better correlates with syndesmophyte formation or radiographic damage. So they feel that the ASDAS is superior to the BASDAI, and they have made that change of ASDAS greater than or equal to 2.1. But still, there's a fair bit of patient input in terms of the ASDAS, so you have to interpret the ASDAS in the context of the patient and making sure they don't have, for instance, concomitant chronic pain, which may actually alter how you interpret the ASDAS. So in the context of someone that actually has ASDAS greater than 2.1, has some objective sign of inflammation, the first thing to ask is is this primarily a peripheral joint involvement? And if it is, if it's oligoarthritis, you may want to inject, for instance, with glucocorticoids those joints, or if you have a polyarticular disease, you may want to initiate sulfasalazine. If it's primary axial, then you consider using biologic agent. So what is it they're saying in terms of initiation of biologic agent? So one small caveat is that if you cannot do the ASDAS because you don't have the CRP at hand, then you can still use the BASDAI of 4 or greater. Because there's no randomized controlled trial, according to the ASAS group, between TNFs, IL-17s, and the JAK inhibitors in terms of the 3 classes that were actually on the market now for treatment of axial spondyloarthritis, they're saying that you can use any of these. However, there's a caveat, and the caveat is that there's a long-standing practice, and the usual practice is to use TNF inhibition or IL-17 over JAKs, primarily because of the duration of use, our experience, and more recently because of the oral surveillance study with some of the adverse events related to JAK inhibition. A new recommendation is this, and that is regarding extramusculoskeletal manifestation. Previously, we used to call it extra-articular manifestation. They've actually removed that term. The reason being is some people confuse comorbidities, such as cardiovascular disease or depressive symptoms, into the extramusculoskeletal manifestations, which were uveitis, IBD, and psoriasis. Because these have direct treatment implications, they wanted to separate comorbidities from these organ manifestations. So nowadays, these are called extramusculoskeletal manifestations. If you have recurrent uveitis, they're suggesting monoclonal antibodies targeting TNFs. If you have active IBD, they're again suggesting TNF monoclonal antibodies. And if you have psoriasis, strong consideration should be given to IL-17 therapy, and that's because of the 2 head-to-head randomized controlled trials showing that the composite score of IL-17 was superior to TNF agents. So what happens in terms of reassessing these patients? They're suggesting, please wait at least 12 weeks before you see them. Secondly, you have to assess disease activity, and the minimum improvement that they're actually looking for is an ASDAS improvement of 1.1 or greater. And again, you actually have to interpret the improvement in the context of the patient. Okay, and it's also your gut feeling along with the score that actually will determine a go or no-go regarding potential change in therapy. So, and again, there's a little caveat in terms of if you can't do the ASDAS, then what you're actually looking for is a BASDAI change of 2 or greater. So, if you actually need a biologic agent, just make sure, please, that you've actually reached an ASDAS score or a BASDAI. So what happens in the setting where your ASDAS score is less than 1.1? And this recommendation is going to be new, which is recommendation number 11. As confident as you are, to be quite honest, sometimes we're not quite sure, particularly in terms of non-radiographic axial spondyloarthritis. So what they're actually suggesting is please re-evaluate your diagnosis just to make sure you think it's actually correct, because these diseases respond so well to biologic agents. If you're not a non-responder, think again that you actually have the right diagnosis. Secondly, think if there's any other contextual factors that may be throwing you off. And so you need to consider this before jumping to changing therapy, whether adding some sort of NSAIDs or changing biologic therapy altogether. So, if the patient continues to have active inflammation, and you think that this is due to active spondyloarthritis, what is it that you do? Again, in the absence of head-to-head studies in terms of a switch, you can consider TNF agents. In other words, you can switch within class, you can switch outside of class, and it's open to TNF inhibition, IL-17A, or JAK inhibition. Again, with the caveat that with JAK inhibition, be a little bit careful because of the adverse event profile, and the current practice is to actually use TNF or IL-17A, but all options are on the table. What happens if the patient has done really well? Then you can consider tapering. When to taper is really your decision. There's no firm guidelines, but you want to make sure that the patient is actually in remission. There's no clear criteria for remission, but you should at least reach low disease activity for at least about 6 months. We usually do it a little bit longer. So if you have reached remission without any clear criteria, for that period of time, you shouldn't just stop the biologic agent, because that's likely going to cause a flare. What they're suggesting is a taper. Okay, you increase the dosing interval. Once you've increased the dosing interval, please reassess the patient. If they seem to be doing well, you may further increase it. And at some point in time, you may discontinue, but just not discontinue just because they have reached low disease activity over a 6-month period. So what these guidelines have done is that they've given you a fair amount of leeway, because at initiation of biologics, they've given you the opportunity to use any of them in the proper context. If they fail therapy, again, in terms of biologic switch, they've given you a fair bit of leeway so that you can put it into context of your particular setting. So it's quite reasonable, and I think some of the changes really are logical. So I'm just going to switch gears just for 1 second and talk about the TICO-SPA study. So this was the first, and it's the only, treat-to-target study in axial spondyloarthritis. We all understand the concept of treat-to-target because of rheumatoid, as well as to some extent psoriatic arthritis. Really, the target in terms of remission is not doable given our response rates, because we're going to actually switch therapies too often. I think a more realistic target is persistent low disease activity. And so they did a pragmatic, prospective, sort of cluster randomized study, and it was open and it was a controlled study. It was primarily European countries, so France, Belgium, and I think Netherlands that were used. So the treat-to-target arm, you're actually seeing them every month, and the target that they picked was an ASDAS score of less than 2.1. The control arm you would see every 3 months, and the physicians would treat them according to how they felt the management should be. The only caveat here is that these were highly trained physicians in terms of their management, and they may have had some bias in terms of being very up to date in how they treat the patients. The outcome that they were actually looking for is at least a 30% improvement in the ASAS Health Index, which is a questionnaire of 17 questions that you ask that takes about 2 minutes to fill out. They also looked at other relevant outcomes, such as secondary outcomes, adverse events, and health economic evaluation. So they had 9 centers in each of the groups. So you would randomize the center, not so much the patients, because within each center you want to treat the patients the same. They had about 80 patients in each group. They looked at the results a year later, and what you find is that there's no statistical difference, even when you actually adjust for cluster randomization, but there is a numerical difference. In other words, treat to target did better numerically, 47% versus usual care, which is 36%, but not statistically. So to say that there is absolute evidence that treat to target is helpful, it's not there, but there's certainly a trend. In terms of other outcomes, you used more biologics if you did treat to target. It was similar in terms of side effects. The biologics have become safer and safer in our hands and how we use them. Interestingly, in terms of a health economic analysis, because of indirect cost, it was the treat to target arm that was found to be more cost effective from a societal perspective. 2 things to think about, however, and this is a sub-analysis that was presented by Martin Rudwright in the last ACR, and this is looking at studies that were done some time ago with certolizumab, and that when you look at objective measures in terms of CRP or inflammation as characterized by the MRI in the spine or the SI joints, you have more than a 50% improvement, which is in the blue, or more than 75% improvement in the gray, when you're actually looking at the CRP or the MRI score. So there's great improvement in terms of our objective score. When you look at clinical disease measures, okay, there's still a large number of patients that are not receiving over 50% of the improvement. So why the discordance? So one of the things to actually think about is these contextual factors. So there's a really nice study here that looked at depression based on the HADS, a depression scale, and if you have even mild and moderate to severe depression, your odds of reaching a BASDAI less than 4 or an ASDAS less than 2.1 are quite a bit less, and your survival is a lot less if you have mild, and even more if you have moderate depression. So we certainly don't want to take away therapy if, for instance, through behavioral modification, you can actually treat depression, because you don't want to cycle meds too quickly. So we are very good at looking at axial disease, looking at peripheral disease, looking at extra-articular manifestations. We really have to train ourselves and to help coordinate a team to look at what's in the left-hand side, depressive symptoms, fatigue, and if needed, look at the social context of the patient. So just coming back to the patient, what was actually going on with this 32-year-old nurse? What was happening is that the father passed away. She was looking after her mother. Her mom was incontinent. She was up a fair bit of the night changing her bed sheets. We called the family physician. She decided to put urinary catheterization for the mom. The patient was sleeping better. She did really well. And so it really, in terms of her inability to function at work, had very little to do with her active disease, and had to do with the social context of a mom that she was looking after at night. So please consider not just the disease, but other things that can potentially be happening with the patient. So finally, there are still things that the guideline unfortunately does not address, but it's not an issue with the guidelines. It's just that we're missing certain key data attributes. It'd be really nice to have, as you initiate biologic agents, head-to-head studies in between the treatment options in terms of what to choose first. If you were to fail the first biologic therapy, it'd be nice to know what to do next. I think we need more clarity in terms of JAK inhibition and inhibition in terms of IL-17 regarding extra musculoskeletal manifestations such as uveitis. The impact of comorbidities in terms of treating these medications are important. But the biggest challenge that we actually face is when you have concomitant fibromyalgia or chronic pain, how do you assess disease activity? Because all of a sudden what we're asked to do in terms of looking at the ASDAS or even the change in VASDAI score, we're sort of guessing and using our own gestalt then looking at the score. And it'd be nice to have a more objective measure. Thank you so much for your time.
Thank you very much. May I ask all the speakers to become on board?
Yeah. Now, because of the time, we will take 2 or 3 questions. You can use the mic, Dr. Mason.
والله انت توني شفت اسمك. ايوه تفضل.
I have a question. إذا ما في أحد.
In your practice, Prof, did you try the combination of biologic in patient with the psoriatic arthritis? And other question for Dr. Rahman, if the patient initially responded to non-steroidal, so for how long you will keep him and how will you taper the non-steroidal?
Thank you so much for the great question, and I think this is an error that's coming so. No, actually, I did not, because it's not approved yet, so I'm waiting for the trials. Thank you.
Sorry, I sincerely apologize. I couldn't hear the question.
If the patient improved initially on non-steroidal, so you tried him non-steroidal, he is doing fine, there is no pain. For how long you will keep him in non-steroidal and how you will taper that?
Sorry, is the question if the patient is improving with non-steroidals, how long do you keep them?
Yes. How long you will keep him on non-steroidal and how you will taper that?
If the patient is actually doing with non-steroidals in a continuous basis, you tell them that they can actually take it as they need it, and it's purely symptomatic control. This idea of potential radiographic inhibition with chronic NSAID use is so controversial, and there are side effects related to NSAID use, persistent NSAID use, that I think what's recommended is PRN use, and you just control the symptoms, and you keep them as long as they're doing, and if they find that days that they're not taking the anti-inflammatory, they do just as well, you can also taper totally, and then restart when they have the symptoms.
Actually, I have a question for our colleague from gastroenterology. Now, as a rheumatologist, we always face the problem of diagnosing IBD. Well, I'm sure that you're facing this problem 10 times. So for us, what do? First of all, we just ask general questions. We don't have any specific. So if there's any specific screening questionnaire, like the PEST for the dermatology, that we could apply and teach our resident and trainee, as well as for ourselves, this is one. Now, the other thing is, one of the tests that we do screening is the stool calprotectin. Now, I know, unfortunately, it's not specific, and there have been some false negative results, i.e., they're not that much, but still you get it. And I did have a patient myself in which the stool calprotectin was negative, and actually he had a very bad UC. Thank you.
Yeah. Thank you, Prof, for the question. So if you have short time in the clinic and you want to ask 3 questions, just ask about chronic diarrhea. This is very important, and usually it is bloody in ulcerative colitis and non-bloody in Crohn's. Abdominal pain, that's with weight loss. This is very important. Weight loss is very important also. And if you want to check for something, like check for anemia, which is not explained by your medication or whatever history of the patient. Patient has no menorrhagia, no other explaining factor, just unexplained iron deficiency anemia. Just this is another alarming sign. So 3 questions: diarrhea, abdominal pain, and weight loss. And also check for anemia. Yes, this is very interesting about the fecal calprotectin. Very excellent question. Usually the trick that fecal calprotectin can be elevated in other conditions, like just simple infection, gastroenteritis, polyp. But the cut line usually 300. So after 300, you have to check with colonoscopy, especially if the symptom is chronic. So with 1 or 2 weeks history of acute diarrhea, we don't do colonoscopy. But if the patient has persistent diarrhea and fecal calprotectin above 250 to 300, you have to refer him to colonoscopy.
Thank you.
Okay, thank you.
Any question? Any more question?
Yes, I have 2 questions for one Dr. Obtisam and for Dr. Proton. For Dr. Obtisam, there's how do we know it's safe to use NSAIDs in patients with IBD? We have patients who are in remission, they have ulcerative colitis or Crohn's disease and are in remission, and we would like sometimes to use NSAIDs for mild back pain or joints pain. How do we know it's safe or not to use it? And for Dr. Proton, is COX-2 inhibitor better than NSAIDs in treating axial SpA? And do you prefer to use continuous or as needed NSAIDs in patients with ankylosing spondylitis?
So the question is when to use non-steroidal in IBD or?
Yes, asymptomatic, yeah.
When the patient has asymptomatic inflammatory bowel disease?
Yes.
Yeah, this is, as I mentioned, in spondyloarthritis, 60% of the patient, they have what's called silent IBD or microscopic inflammation. So usually, according to the literature and the studies that were done there, it's not mandatory to do screening colonoscopy. So if the patient has no clinical symptoms, has no diarrhea, no malnutrition, no anemia, no need for screening. But if the patient started to have diarrhea and you suspect inflammatory bowel disease, then you have to work on it. So microscopic or silent inflammatory bowel disease does not mandate screening because it will not progress. It will stay like it is. Not necessarily the 60% will change to IBD. Can I?
Sorry, what I mean that patient with IBD, can we use NSAIDs?
Okay, NSAIDs,
Yes.
okay. So before we usually inform our resident and fellow, this is, I mean, just general speaking, don't use non-steroidal. And even I'll tell my patient, if the rheumatologist give you non-steroidal, don't use it. You have to ask me first. This is general speaking. But as I mentioned, studies are coming more and more about COX-2 inhibitor, that it's safe in IBD and does not increase the risk. But still, generally speaking, the classical non-steroidal is forbidden. But COX-2, yes, you have exception with COX-2 with monitoring. So if the patient, you know him, he's a stable condition, he's not in flare, you can try non-steroidal, COX-2 inhibitor, and monitor. If the patient condition does not worsen, or fecal calprotectin, usually we monitor with serology like fecal calprotectin, ESR, CRP, and with the frequent imaging and endoscopy. If there's no worsening, he can continue on it. With BBI, I usually cover him with BBI as well, proton pump inhibitor.
Okay. We'll take more question, the last question. There is no question through the message.
Thank you. My question to the professor, you mentioned the conventional therapy in spondyloarthropathy, especially ankylosing spondylitis. I want to mention ankylosing spondylitis per se. Do you really recommend still using conventional therapy? Because in some conferences like this and ULR, it was mentioned that it's almost useless and a loss of time and money. And if you still recommend using laxalazepine or methotrexate for how long? And because we know that it takes some time to start this action from 8 weeks to 12 weeks. But the point is still you recommend to use conventional therapy in ankylosing spondylitis?
Excuse me, I didn't hear it very well. Did you measure what, please? Could you repeat your question?
Professor, the Canadian doctor, I didn't quote his name yet. Professor.
Again, I sincerely apologize. There's a lot of echo, and I just
Yeah, you mentioned salazopyrene in spondyloarthropathy, arthropathy, especially ankylosing spondylitis. Salazopyrene, you mentioned that you treat patients with conventional therapy. To my knowledge, in certain conferences, it was mentioned that it's loss of time and money, and that doesn't stop the progression of the disease. So will you elaborate that point, please?
Thank you for that question. So sulfasalazine is there in the guidelines. The effect size of using sulfasalazine is really small. I think part of the reason they actually included sulfasalazine is that if you have a mild peripheral arthritis without prominent axial symptoms, depending on which part of the world that you are, from a cost effectiveness perspective, you may try to use sulfasalazine to control your symptoms. If it does, that's fine, because the issue of disease modification in terms of ankylosing spondylitis, unlike psoriatic or rheumatoid, really has not been clearly shown unless you have prolonged use. And so it's for that caveat that they're suggesting, yeah, fair enough, you can use sulfasalazine for about 3 months just to see if there is a response. But it says that if you're intolerant to sulfasalazine, if it's not working, or if there's any contraindication, even with peripheral dominant spondyloarthritis, you can proceed to a biologic therapy. So, but it was just done for, I think, from economic reasons, suggesting that if you have peripheral involvement, a trial of sulfasalazine was reasonable.
Thank you so much for Prof. Okay.
Okay, I'd like to thank you for the nice talk, Prof. Suzanne, Prof. Proton. I just need to elaborate more about the axial psoriatic or axial psoriatic spondylitis, which is already always, there is a hot topic regarding the interleukin 23 data. What do you think about the 2 years data already presented in last Canadian rheumatology meeting with daftaglanman cohort that patients with axial psoriatic spondylitis get profit from gozelkumab 2 years continuous use?
Dr. Abdelgoma, if I get the question right, it's regarding axial spondyloarthritis with potential use in gozelkumab?
The axial psoriatic spondylitis.
Axial psoriatic arthritis, yes, yeah. So in terms of the only specific study, as Dr. Attar mentioned, was with respect to the MAXIMIZE study that specifically looked at a subtype with radiographic imaging along with back pain to look at the response a priori in terms of a primary outcome. However, if you do a subset analysis in terms of DISCOVER study with all the caveats regarding a subset analysis, and you were to look at in terms of BASDI, spinal pain, BASDI with question number 3, which is peripheral joints involved, or the ASDAS, there appears to be improvement versus placebo, but there's no clear way of saying it actually works without a proper clinical trial. But there is a suggestion, and I think we're going to talk about it in the symposium, that the phenotypes regarding axial PSA is different from angspon from a clinical and a genetic perspective, also from potentially a molecular perspective, but how that relates to treatment is not clear, and it's not really going to be resolved until the STAR study is read out.
Okay, thank you.
Okay. Thank you for all. Now.
شكرا جزيلا. Thank you for your presentations. Now, please stay on stage. Please stay on stage for the awards. ندعو الدكتورة حنان الرئيس لتكريم السادة رؤساء الجلسة والمتحدثين فيها. البداية مع الدكتور رامز السويلم. دكتور رامز. منصور العازمي. ثم الدكتورة أو البروفيسورة سوزان عطار. ثم الدكتورة ابتسام المغيسي. and Dr. بروتر رحمن. دكتور رامز، صورة جماعية بس لكل المشاركين في هذه الجلسة. شكرا جزيلا. Now we will move to slide symposium by Janssen Company.
Ladies and gentlemen, please. We will present satellite symposium. We would like to ask you to stay in the hall. Just one moment, we will present satellite symposium by Dr. Proton Rahman, consultant rheumatologist, Memorial University of Newfoundland, Canada.
Waiting for 1 second for the slides to be put up. So maybe in the sake of time, I'll start just in terms of what it is that we're actually trying to do in this symposium. So there are A couple of things in terms of objectives. We critically want to look at the role of IL-23 in terms of pathogenesis of psoriatic disease, and then take one particular IL-23 molecule in terms of gozulcamab and look at it in terms of what the disease outcome measures that are of relevance. Oh, sorry, my slides are up, so maybe we'll just start. So thank you again for giving me the opportunity to present. I'd like to thank Janssen for bringing me here as well. And it's a great honor once again to present to everyone here. So my title of my talk is regarding psoriatic arthritis, look at it from pathophysiology to treatment in the lens of IL-23 inhibition. And there's one particular IL-23 that we'll be focusing on in this symposium, which is on gozulcamab. These are the relevant disclosures, the most important of which is that I am getting an honorarium from Janssen for this presentation. So what I'd like to do is to highlight the importance of IL-23 in terms of the pathophysiology of psoriatic arthritis, look at the key efficacy outcome measures, and try to link it to the pathophysiology whenever possible. Try to understand where it actually fits in the treatment armamentarium of psoriatic disease, recognizing that there's no head-to-head study. So to the best of our abilities, to a certain extent, this is going to be opinion-based, and I'd love to have the discussion, especially if it's not something you agree with, because I don't think there's any clear consensus. And then look at the safety and long-term outcome, which appears to be one of the key attributes of IL-23 inhibition. So just a case to ground us again, and this is someone that had early onset of psoriasis at the age of 15. 6 years later, they get inflammatory arthritis, so they have psoriatic arthritis. They tend to be overweight in terms of our patients. So if you look at patients entering psoriatic arthritis studies as compared to rheumatoid arthritis, they're often 10 kilos, about 22 pounds heavier. That's because there's some thought and that being overweight, and not even being overweight, but specifically if you look at Ian McInnes's work, hypertriglyceridemia, that is actually linked with initiating psoriasis and subsequently psoriatic arthritis. Based on being overweight, they were type 2 diabetic, and they also had a sister with Crohn's disease. There are certain diseases, such as uveitis, along with Crohn's disease, that tends to cluster in families with spondyloarthritis. So they were initially given adalimumab, had a great response, and then they started to lose the response in terms of the joints. Given etanercept, and what happened is the skin flared, the joints came back, and not only did they have joint pain, they also had some axial symptoms. So in the context of what we heard from Dr. Attar, suggesting that the only real randomized controlled study, which was the maximized study showing that it's helpful for axial disease, is secukinumab. The question is, what is the role of other biologic therapies? This is what we would like to discuss in this presentation. So what's the pathophysiology in terms of psoriatic arthritis, and what's IL-23 so important? So one of the key issues in terms of any spondyloarthritis, but particularly ankylosing spondylitis or axial spondyloarthritis and psoriatic arthritis, is the strong genetic component as determined by the lambda S, or the heritability among siblings. So there's clearly many genetic factors that are important, but genetic factors are not by itself enough because it's a multifactorial disease. In other words, you must have environmental trigger. The environment, as we discussed, could be being overweight, it could be smoking, it could be infections as well, it could be trauma. But one of the key environmental factors, we believe, is likely microbial in terms of what's actually triggering it. So when you actually have environmental stimulus on top of someone that is genetically predisposed, then you get a break in terms of your epithelium, okay? So whether it's the skin, usually for psoriatic arthritis, or occasionally the gut. So what happens if there's an insult in terms of the epithelial barrier? In terms of the skin, it's sensed by the dendritic cell. Subsequently, you secrete IL-23. IL-23 then goes to the sentinel cells, These are resident T cells that actually exist in small amounts. When it senses the IL-23, it'll cause amplification of enhancers, which are the Th17 cells that release IL-17. This really amplifies the immune response. It triggers the effector cells and cytokines, such as TNF, which then go to the target organ to give us our various manifestations, whether it's the gut, the entheseum, the synovium, or whether it's the skin. Sorry, I'm just having trouble changing the slides. So this is a very useful review that just came out last year. So York Shedd, Ian McInnes, myself, and Chris Richland got together and said how best to understand the cytokines. And what we're actually proposing is to look at where the various cytokines are acting in terms of the immune system. So if it's very close to the initiation of the epithelial break, we're actually calling those inducers. If it's actually amplifying the immune response, those are enhancers. Those would be something like IL-17A inhibition or cytokines. And then if it's actually the cytokines that are causing insult to the end organs, these are effector cytokines. Why think about inducers, enhancers, and effectors? If you have an inducer cytokine, sometimes it takes a little while for it to work. If you think about abatacept in rheumatoid, if you think about rituximab in terms of B-cell disease, it doesn't work right away. You give it a little bit of time, you get a very good response. The effector cytokines, on the other hand, tend to be a little bit more rapid in terms of the results, taking account the pharmacokinetics of each of the products. If, on the other hand, you were to taper or discontinue these treatments, it takes a longer time for the inducers to wear off, and it actually takes a shorter time for the effectors to wear off. And so we really need to consider where it is in your immune system to work, because there's certain medications in terms of their kinetics that's going to take a little bit longer for it to work. So what are the IL-23s that are actually out there in terms of the market? There are two of them right now, risankizumab, as well as gozulkamab, both of which have phenomenal response when it comes to the skin and very good response when it comes to the joint. Are they the same? From a molecular perspective, the answer is no. So risankizumab is humanized, where gozulkamab is fully human. We're not really sure of the clinical significance of that. But a bigger difference is I believe that when they developed risankizumab, they were thinking that maybe antibody-dependent cytotoxicity is going to be an issue when the FC receptor binds to a macrophage and causes inflammation. So what they did on purpose is to put something called a LALA mutation in the FC receptor. But a consequence of altering the FC receptor is that the FC receptor is not binding the CD64 monocyte. And that ended up being important in psoriatic disease because the CD64 monocyte is an important source of IL-23. So does this actually play out in terms of the hypothesis when you look in the lab? So work from Dan Kua has actually shown that. So what you have here is gozulkamab, and you can see how well it actually binds the CD64 monocytes. However, if you put a LALA mutation in gozulkamab, which is to your far left, there's no binding regarding the CD64. And so the reverse is true in terms of risankizumab, where it's actually not binding the anti-CD64. A more relevant outcome maybe is how well does it capture IL-23. And what you're seeing here in terms of, sorry, the pointer's now working. What you're actually seeing in the bottom slide is the IL-23 capture is a lot greater for gozulkamab than it is for risankizumab. So there is molecular differentiation in terms of gozulkamab versus risankizumab. So we would like to see if there is a clinical difference or not, or what is the clinical implication of this. Everything else is just conjecture, it is opinion. We don't have a direct clinical correlate to this molecular differentiation. In other words, you could see something in the lab and it may have no clinical consequences. All that being said, what's occasionally highlighted is the difference in looking at gozulkamab versus risankizumab. So respectively, the DISCOVER-2 and the KEEPSAKE-1, because these are bio-naive studies, when they do an NRI analysis or a modified NRI analysis, respectively, at 2 years. The ACR scores for gozulkamab, say you pick ACR 50, is 55%. The ACR scores for the KEEPSAKE is 42%. Numerically, it seems higher. However, it's not a head-to-head study. The populations are a little bit different. You got to be really careful in making any interpretation based on this alone. But it is of interest in terms of slight difference, in slight numerical difference in terms of the numbers. So whether this has anything to do at all with the molecular differentiation is a matter of opinion, but I thought I would just bring that out to your attention. So what are the key clinical responses in terms of gozulkamab? So the thing that we're used to looking at, so DISCOVER-2 was their bio-naive study. DISCOVER-1 had a mixed population with 30% of people that had TNF exposure. Is that you get a robust response against placebo, and the numbers are very similar to what you see, for instance, with anti-TNF or anti-IL-17 or even JAK therapies. A 60% ACR20 response, a 30 to 40, almost 40% response in terms of ACR50. So not overwhelming, not underwhelming is what you actually see in other psoriatic diseases. What's a little unusual about gozulkamab, so this is an NRI analysis, so it's accounting for any dropout at any point in time. And so when you start an NRI analysis, which was done after the placebo-controlled trial, in other words, after 24 weeks, is that the drug continues to improve. If the drug continues to improve and you're still accounting for people that have dropped out for any reason, you must be getting better at that particular time. So that, because it's still in the blinded phase there. So that's a little bit unusual, and it's telling you something about the kinetics of the product, and that's beyond 6 months. You continue to improve, and you improve up to 36 months before it actually starts to plateau. So it may be a little slow in terms of how it works, but it continues to work for a little bit longer than other biologics that actually plateau within 24 weeks. This is a really nice way of looking at time to achievement for the individual MDA criteria. So as rheumatologists, we are quite aware that minimal disease activity, there are 7 components which are on the left. It's quite hard to reach an MDA status because only up to a third of our patients reach MDA for any biologic therapy. But when you actually look at the individual elements and the kinetics in terms of those elements, things that we really care about the most, what's happened to the skin, what's happened to the endothelial inflammation, what's happened to swollen joints, those actually resolve quite well. What's really hard to treat, and the reason why we're not reaching MDA, are more patient-derived outcomes, patient pain, patient global, patient function. And when you look at and you analyze this a little bit further, there's actually an association with depressive symptoms and contextual factors that are actually resulting in limitations in achieving these outcomes. So there's actually very good response in more objective measures with these products. What happens if you failed an anti-TNF? That's very important because by habit, often we start TNF inhibition first. So whether you are biologically naive, which is in the right, or to your left, or biologically naive, which is biologically exposed, which is to your right, the numbers look quite comparable. Usually as you switch from anti-TNF, there's about a 5 to 10% drop in terms of response. It holds about the same when you're actually switching mechanism of action. We've also seen this, for instance, with bimekizumab as well as the IL-17 product. So what's going on there where you're not seeing that kind of a drop-off? A really nice sub-analysis of the DISCOVER study is giving us part of the answer. So prior to getting gozulkamab, if you were to look at patients that were previously exposed to a TNF versus those that are TNF naive, what you're seeing in the red circle there is that those that were previously exposed to a TNF agent and failed it actually had higher IL-17A and higher IL-17F concentration in the serum than those that were biologically naive. In other words, part of the reason that they actually fail the TNF is that maybe their disease entity is more IL-17 driven. So this gives a rationale that if you were to fail initial anti-TNF, maybe consider switching class, because they may fall into a subset where they actually have more IL-17 in their serum, and maybe IL-17 inhibition or IL-23 inhibition may actually help that a subset of patients. So this may convince you to switch rather than out of class than within class. It's something to consider anyway. So how effective is gozulcamab as compared to other products? So when we use it initially, it's hard to get a clinical experience by yourself. Often we save newer drugs for people that have failed multiple biologics. Secondly, there is some thought that the gozulcamab is taking a little longer to work. So what is the best evidence that we actually have? It's hard to get, and there is really no randomized controlled trial to guide us. So what can we do? The best thing we can do at the present time, and I think this is going to be more and more important, are these network meta-analysis. So the key feature in a network meta-analysis is what you actually do is look at the placebo group, you do a meta-regression, you look at the variables related to placebo, and you try to standardize things according to the placebo response. Once you have done this meta-regression, then you actually look at the various outcomes in terms of people that have actually gotten active therapy. So when they actually did that, and this is done for the anchor here is gozulcamab, 100 milligrams every 8 weeks, because that's the dose that's actually used in North America, and usually the initial dose. They compared it to all 15 choices that you actually have. So there are 15 targeted therapies and 23 unique treatment doses. And so based on that, you can see why it's so hard to just rely on RCTs to help differentiate it. So this is a pictogram in terms of the network meta-analysis. The circles there are each of the individual studies. The larger the circles, the more the patients that are there. The darker and the more bold the lines, the more studies that are there. And if the two circles are connected, this is when direct doses were compared. So what did they find in terms of their meta-analysis? So when you look at outcomes, and this is the same result for ACR 20 and 70, so just for the sake of time, I'm just looking at the ACR 50 because it's a similar pattern. So when you're looking at a dichotomous trait, what you're actually doing is looking at the relative risk, and does the 95% confidence interval cross one? So just based on this analysis, you can say that gozulcamab is superior to drugs that we don't usually use in rheumatology to treat psoriatic arthritis, say abatacept or apremilast, unless there's a contraindication or a safety issue. And the IV-loaded drugs in terms of infliximab and IV golimumab did a little bit better, but that has to do with the kinetics to a certain extent in terms of the large IV dose. All other medications in terms of IL-17A, the other IL-23, anti-TNFs and JAKs actually cross that threshold of 1. So there's really no statistical difference in terms of how well it's working from the joints from this comparative network meta-analysis. How does it do in terms of radiographic progression? Here, you're actually looking at a mean difference. So when you look at the mean difference, the line that you're trying to cross is 0, and you see that the 95% confidence interval actually crosses 0 for all therapies, except again for those ones that are strongly IV loaded, such as infliximab and IV golimumab. So the inference there is that it's got very good radiographic inhibition, similar to anti-TNFs, which to a certain extent, because of how long we are using them, is sort of considered the gold standard in terms of inhibiting radiographic progression, because we have long-term data for that subset of patients. How well does it do in terms of skin scores as measured by PASI 100? It's outperforming the TNFs, it's outperforming the JAKs from a statistical perspective. It's similar to IL-17A for psoriatic disease when you actually look at the skin, similar to risankizumab, which is the only IL-23 they looked at. So I think this is a very helpful exercise looking at network meta-analysis. And what's this telling us about gozultamab? It's similar in terms of joints to TNFs, to JAKs, to IL-17. It inhibits radiographic progression, and again, similar to anti-TNFs, for instance, and IL-17 products. It's superior in terms of skin, particularly against JAK inhibitors as well as TNF agents. And the safety profile we'll talk about in 1 second. This was mentioned by Dr. Attar, and what you're actually looking at for the key domains in GRAPPA, and I totally agree with their assessment that this is probably the best recommendation and best management guidelines to actually follow, is that IL-23 therapy has got an indication for all the key domains from nail psoriasis, dactylitis, enthesitis, and peripheral arthritis, but there's an absence there, and the absence is for axial disease. Why is there an absence there? And that's because risankizumab, as well as ustekinumab, which is a 12/23 inhibitor, failed to show improvement in terms of signs and symptoms for ankylosing spondylitis. We often look to ankylosing spondylitis thinking that it's going to give us an idea of what happens with inflammatory back pain related to psoriasis or axial PSA. Is that a fair assessment or not? That is what we're considering. Because there's not a specific study, for instance, in TNF or in JAK specifically dedicated, unlike the MAXIMIZE study, for axial PSA, and yet they have gotten indication because they actually work for axial spondyloarthritis. So what's happening here in terms of gozultamab and axial PSA? So I've been just told to just hurry things up a little bit, so I'm just going to go through it a little bit quickly. There were over 1,100 patients in that study. 300 of them actually had radiographic or MRI axial changes, and they had low back pain. When they looked at the key outcomes that I just discussed in the discussion, what you actually find versus placebo is that both doses of gozultamab clearly outperform placebo. And so it appears to work from a clinical perspective, but this was a subset analysis, and this is not something they'll be able to convince the FDA unless do a specific study. What they have noticed, though, and the real question is, does axial PSA differ from AS? Okay, so clinically, as rheumatologists, we know that they're different because axial PSA involves the neck first. You can get low back inflammatory pain without any changes in terms of the SI joints. We also know that the sacroiliitis is often unilateral. The association with sacroiliitis is primarily BO8. Radiographically, they actually look different because the syndesmophytes are bigger and not always at the anterior longitudinal ligament. From a genetics perspective, the HLA associations are quite a bit different. However, the caveat is that may be more related to psoriasis that we're comparing with AS than psoriatic spondyloarthritis. So what I did in my lab is did a full exome of all these patients and showed that if you actually take away the MHC region, take away the genes associated with psoriasis, you still have a different phenotype for axial PSA than AS when you do this principal component analysis. When you look at where the IL-23 is coming from, you could argue that the IL-23 in AS comes from the gut. The IL-23 in the skin is actually coming, IL-23 in psoriatic disease is coming from the skin. It's interesting, when you actually compare IL-17 A and F concentration, if it comes from the gut, you actually have less IL-17 than if it comes from the skin. So maybe the amount of IL-17 and subsequently IL-23 inhibition is different. And finally, is there any reason for this particular product to not work in axial spondyloarthritis? Is this particular study from Janice McGonagall's group that there's one subtype of cell in normal tissue? These people did not have axial inflammation. They just had degenerative disc disease, was going through spinal fusion surgery. They happened to get tissues that this gamma delta T cell was actually independently able to produce IL-17 in the absence of IL-23 stimulation. And so there's a subset of Th17 or IL-17 cytokines that's independent of the adaptive immunity. What role and what percentage that plays in psoriatic arthritis is really not known. We're not really going to know about it till we do the STAR study. The real question is, if you had someone that had inflammatory back pain and peripheral joints, do you want to wait 2 years till the study reads out? Because we're actively recruiting now, but it's going to take a while for this study to be completed and then analyzed. Or for peripheral arthritis with some axial involvement, based on the DISCOVER studies, do you go ahead and use guselkumab? And that's really up to your choice. The last thing is that the safety profile for guselkumab is very good. When you look at it, TNF naive and TNF failures, it's similar to the placebo rate. When you look at it 5 years down the line, in this pooled analysis of all the psoriasis and psoriatic arthritis studies, okay, the event rate for serious infections and IBD are similar to the placebo rate for guselkumab that you noticed at week 24. And in terms of retention, this is just in terms of psoriasis. The guselkumab seems to be very well maintained, then ustekinumab, then IL-17. There's no such real-world studies for IL-23 in psoriatic arthritis, but the IL-17, looking at the French registrar, seems to outperform the TNFs. So returning to the case, yeah, I probably use guselkumab given the DISCOVER study because it's not predominantly axial, but it's really up to you to decide what to do from there. Thank you so much for your attention.
Thank you, Dr. Proton Rahman, for your presentation. Now, to break 10 minutes. استراحة قصيرة لمدة 5 دقائق. يلا استراحة قصيرة لمدة 5 دقائق ثم نعود لنستكمل جلسات المؤتمر. السادة والسيدات، ندعوكم إلى القاعة لاستكمال جلسات المؤتمر. يلا جاهزين؟ الياس يلا بسم الله. سادة والسيدات، نرحب بكم من جديد في المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم. Ladies and gentlemen, let me once again thank our speakers for giving their time and experience today, and I hope all of you enjoy the conference. Our next session will be oral abstract. Please join me welcoming Dr. Ahmed Al-Hazmi and Dr. Suad Hanawi.
Assalamu alaikum wa rahmatullah. Alhamdulillah wa salatu wassalamu ala rasulillah. Thank you for the organizing committee. Thank you so much for inviting us to this wonderful event. And we'll start our session today, inshallah. Me and Dr. Suad will be chairing this session. So our first speaker is going to be Prof. Khalid Al-Naqbi, our colleague from UAE, who is a clinical associate professor on rheumatology and internal medicine in University of UAE University. He's also a consultant rheumatologist and head section of rheumatology at Tawam Hospital in UAE. Dr. Khalid is going to, or Prof. Khalid is going to give us a small capsule with regards to the latest update and a consensus opinion or consensus recommendation about the use of biosimilars in the Gulf area. Dr. Khalid?
Thank you very much for this nice introduction, and good morning, everybody. I'm supposed to have 10 minutes. I will do my best. This was a great effort from many stakeholders in the Gulf about recommendations or consensus recommendations for the use of biosimilars in rheumatic disease. I'd like to thank all the people involved in this great conference for inviting me to give this brief talk about this. It's very unfortunate I cannot see from here. It's really far away from me. But basically, we had a lot of steps, and the methodology was actually robust. And it starts off with the creation of a task force, people who were interested to come up with our guidelines, which we call the Gulf Guideline. Then we defined the scope or the target, and then formulated clinical research questions like PICO, P-I-C-O, patient or population, intervention, C, comparison, and O is outcome. So we tried to ask questions relevant to the Gulf region. After that, there was a systematic literature review by expert people, or SLR we called, and we also registered that in the website called Prospero. It's a free website, but unfortunately you have to wait like a month or two for this to be published, and then generated recommendations and overarching principles. We actually sent it to, after we came up with it, we voted on them using a Delphi method, and then we showed them to external validators or external validation like the payers and regulators. So this is the task force members from each Gulf country, and we have an expert, international expert, Professor Tor Kvin from Norway. He was a non-voting. We elected to make him non-voting because all these matters actually related to the Gulf region. So, but he offered us great guideline. So the first recommendation was published. It's called Consensus-Based Recommendation for the Use of Biosimilars to Treat the Rheumatological Disease by colleagues, international colleagues. Among them is Professor Torkveen. And they had A, B, C, D, E, overarching principles, and 8 recommendations. That's the way they formulated their plan. Then we have a second recommendations, which was actually biosimilars and rheumatology recommendations and regulation and use in the Middle Eastern countries, and they were by Professor Bassel Zirqani, Nizar Al-Ani, Amar Al-Imadi, Jamal Saleh, and other colleagues. I'm sorry, I can't read this from far away. But basically, they came up with this kind of guideline. Their methodology is different than the methodology that we used. So we created PICO questions. I apologize, I cannot read them from here, but we tried to brainstorm and try to have our own observations during the use of the biosimilars in our practice in rheumatology clinics. And we tried also to find some other questions that not necessarily were answered by systematic reviews pertaining to patients in the Gulf or patients in the Arab world, but we tried to do our best. And then SLR, or systematic review, a comprehensive literature review was conducted, and we had a timeline, and then we have eligibility criteria, like inclusion criteria, exclusion criteria. Because of the time, I'm sorry, I don't have time to go through it. But basically, we tried to eliminate pediatric patients, and then try to include some patients. Basically, patients with inflammatory arthritis, like spondyloarthritis, psoriatic arthritis, and rheumatoid arthritis. This is the evidence summary on how we included studies, excluded them, and then generated recommendations and overarching principles. Basically, we were trying to standardize the practice across the Gulf countries. We tried to have agreement among the task force members, more than 70% agreement. That means we will keep those recommendations. And then, as I said here, the level of agreement was more than 70%. Some guidelines in our recommendation around the world elected 80%. We got 70% as a start. And the voting was based on 5-point Likert scale, so 1, 2, 3, 4. And the external validation included payers, regulators, patients, and rheumatologists working in the Gulf region. So the overarching principle, so difficult. Oh, I can read from here. No one told me. Okay, so it's basically rheumatologists, patients, and other stakeholders can benefit from awareness campaigns that educate and update them on the nature, approval processes, safety, and efficacy of biosimilars in comparison to reference products. So the level of evidence was 4, grade of recommendation was D. So basically, you may not see all the recommendations or overarching principles as high level. We basically sometimes need evidence, and be aware that some of the international and recent recommendations did not actually use level of evidence on the overarching principles. So what we did is a mile further, just to give the people the idea where we came from. The overarching principle B, a better understanding of biosimilars can help rheumatologists communicate with the benefits of biosimilars more efficiently with patients, thereby reinforcing positive perceptions towards biosimilars and improving adherence. Rheumatic disease treatment decisions should be made collaboratively by the patient and the rheumatologist, shared decision making, and must be based on available clinical evidence and local healthcare regulatory guidelines or recommendations. D, standardized protocols for collecting real-world data on both biosimilars and reference products must be established across the region. I cannot stress that enough, actually. And finally, E, biosimilars must be made available to all patients and at significantly lower acquisition cost in order to widen access to treatment and by providing more affordable treatment options. And then we come up with the consensus recommendations. So number 1 is based on level of evidence 1A. Biosimilars are comparable to their respective reference products in terms of efficacy, safety, and immunogenicity profiles, and can be considered a treatment alternative when appropriate. This number 2 is level of evidence is 1B, and grade of recommendations A. The formation of anti-drug antibodies is not clinically significant between biosimilars and reference products, and therefore does not need to be measured in clinical practice. 3, rheumatologists must be well informed about the safety, efficacy, and immunogenicity profiles of biosimilars to effectively explain treatment options to patients. This knowledge will help mitigate challenges related to retention rates, nocebo effects, and patient misconceptions regarding biosimilars. 4, switching or transitioning from a reference product to an approved biosimilar should be considered in clinical practice due to comparable efficacy, immunogenicity, and long-term safety outcomes. I understand that many rheumatologists don't prefer to use the biosimilars, but sorry, there is evidence to use it. And this has been used internationally in almost all the countries. And we realize that even some European countries completely removed the bio-originators. Switching or transition between approved biosimilars, so approved biosimilars of the same reference product can be considered in clinical practice due to comparable efficacy and safety outcomes. And also, we did that in our experience, so it actually works. Confirmation of the efficacy and safety of a similar biosimilar in a single indication is sufficient for the extrapolation to other diseases for which the reference product has been approved. And before the last, switching from a reference product to a biosimilar in stable patients should be a shared decision between patients and rheumatologists. We're talking about non-medical switching. Patients should be informed about the comparable efficacy, safety, and cost-saving benefits of biosimilar. And finally, standardized pharmacovigilance initiatives must be established across the region in the Gulf to document post-marketing data and compare the outcomes of biosimilars and their reference product. It's not enough when someone tells us, oh, I gave a patient a drug and biosimilar, it doesn't work, or I have side effects. That's not enough. You need evidence, and the evidence will come from real-world data and pharmacovigilance. National health policies should be developed to adopt prescribing biosimilars. So we developed overarching principles and recommendations taking into account feedback from patients, payers, regulators, and expert rheumatologists practicing in the Gulf region. These are the third overall recommendations being published in the literature and the first GCC recommendations using a robust methodology that is used in international recommendations. Although the intent was to develop GCC-specific statements related to the use of biosimilars in the management of rheumatic disease, these can be generalized to other regions as well due to the heavy dependence on international data and lack of data from the Gulf region. This is why I keep telling my colleagues across the Gulf, please use the biosimilars and let's start working together and have pharmacovigilance data and real-world data. So this guideline or recommendation will be updated in the future once we have more local or regional data. I'm almost done. So the future, scope of future research, understanding the key challenges and opportunities from the perspective of patients when switching patients from a reference product to a biosimilar. That is the research, future research. Identifying the key aspects pertaining to the rationale for use and evidence that should be conveyed to patients when switching them from a reference product to a biosimilar. Developing strategies that can effectively reduce or prevent the nocebo effect pertaining to biosimilar use among patients. And gathering pharmacovigilance data in the Gulf region to evaluate the differences in clinical outcomes between reference products and biosimilars. And lastly, implementing strategies to promote the standardized use of biosimilars across the Gulf region. I'd like to thank my co-authors and co-workers and colleagues whom we worked day and night to come up with these guidelines. It took us almost 2 years to come up with this from different countries. We brought international experts. We brought people from pharmacoeconomic, actually, so that they help us formulate these guidelines. Thank you very much. Yes.
Thank you very much, Dr. Nakbi. All the questions related to the oral abstract session will be taken at the end of the session. Our next speaker will be Dr. Mufaddal Al-Aithan, who is a senior consultant rheumatologist and a senior medical manager at Eli Lilly, who will talk to us about real-world utilization and switching between different JAK inhibitors in patients with RA, with the data taken from Australian OPAL database. Dr. Al-Aithan, please.
Assalamu alaikum. Thank you very much for the kind introduction. So I will briefly present about JAK inhibitors and the utilization or switching of JAK inhibitors in RA patients. So this is data taken from an Australian registry called the OPA registry. And interestingly, in Australia, patients with RA can basically utilize or undergo any kind of treatment that is judged by their rheumatologist to be the best treatment, so there isn't necessarily restriction on choice. So therefore, utilization of the 3 JAKs in that country is quite efficient, I would say. And basically, all 3 JAKs that are available in here were included in that study because they were the same JAKs that were available in Australia. So the main objective of that is to basically describe the switching between the JAKs and also describe the switching between JAKs to other classes and to see whether this is utilized in routine clinical care or not. So the data was collected from the OPA registry, and it included about 112 rheumatologists across Australia, and patients were eligible for enrollment if they were adult patients with RA between 2015 and 2021. And the data was utilized to describe the switching and the duration of therapy or survival. So over 55,000 patients were included, and about 12,000 and more were on biologics, and of them were 5,900 patients were on JAKs, and this included all the JAK inhibitors, all 3 of them. Median persistence ranged from about a bit less than 35 months for tofacitinib and a bit less than 19 months for upadacitinib, and baricitinib was in the middle between the 2. However, keep in mind that tofacitinib was the oldest, about 5 years before UPA being introduced in that particular country. So 50% of all first-line switches happened from JAK inhibitors to a TNF inhibitor, and there was and afterwards, like after a first-line switch, patients were less oftenly switched to a TNF inhibitor, but rather to biologics that are non-TNF biologics. Interestingly, about 30 to 36% of the patients had JAK cycling or JAK inhibitor cycling throughout their therapy. So in later lines of therapy, switching between JAKs and TNFs was less oftenly, let's say, used or practiced among Australian rheumatologists. And interestingly, that patients were more likely to be on a CSD-MARD if they were first-line switchers or first-line users, and they would less oftenly use combination in later switches. And this is interesting, maybe because they did fail CSD-MAD, so maybe the practice is to stop it or not accumulate cost or whatever. So the most common reason for switching would unfortunately be lack of efficacy, and this is what is really known from diverse RA literature. So we look into the characteristics of patients, and we see about 500 to over 1,000 patients on JAK inhibitors, whether first, second, or even third line. And interestingly, on average, these patients had a median age of 60, and majority was, as expected, females with a duration of disease for anywhere between 1 to 7 years, and very high disease activity if they were first-line JAK users, and a bit less disease activity if they were second or third line JAK users. Now, this is the survival of the JAK inhibitors, and you can see that baricitinib and tofacitinib had somewhat comparable survival. Upadacitinib had less survival, but keep in mind it was it came quite late in that country, so this might have affected the time point of collecting data. So as first line, second, and third line use had basically very good persistence for all the JAK inhibitors, and interestingly, first-line users had even better persistence or better longer month of use compared to second and third liners. And switching patterns, basically, as we've discussed, had on average of anywhere between 1 to 4 years of follow-up, and a very good percentage of patients remained on JAK inhibitors even if they were second or third line users of JAK inhibitors. However, about 30 to 40% also switched the treatment, and switching to a JAK inhibitor happened in about 30%, give or take. So a CS-DMARD used during the switch was quite oftenly practiced, and lack of efficacy was the most common reason for switching biologics in RA. So in conclusion, in this large set of database from a registry, it shows that utilization of JAK cycling could perhaps be an effective method for controlling patients. This adds to the data that we have that cycling between JAKs might be an effective method for controlling RA, and it is a little bit different from what we know from TNF inhibitors. However, the limitation of that study is being a retrospective analysis, and this is an open source for bias, as we know. So that was my presentation. Thank you very much. This is the disclosure and funding by Eli Lilly.
Thank you, Dr. Muhaddal. So we move to the next speaker, Dr. Ibrahim Al-Maghlouth, who's a professor of medicine and rheumatology at King Saud University in Riyadh. He's a consultant rheumatologist and director of Medicine Research College at the King Saud University. And he's going to talk about the biologics in lupus, and in particular belimumab, real life or real world data. Please.
Well, thank you so much for this nice introduction. I have to disclose that I'm not yet professor, but thank you, hopefully in the near future. I'm really delighted and thankful for the organizing committee for accepting the this presentation and this work to be presented. On behalf of the authors of this paper, I would like to thank the organizing committee again. So what we're going to present today is the real-world effect of intravenous belimumab on clinical outcome of patients with systemic lupus erythematosus in Saudi Arabia. That's part of the OBSERVE study. OBSERVE study is a sponsored study on the impact that aimed to assess the impact of belimumab on the patient with lupus from Saudi Arabia. And these are the disclosures there listed as you can see. Now, I will tell you one thing before I start the introduction. I suck with presentations, so I don't like to read from presenting slides. So I will try to go over, switch a little bit, and not to be very scientific in the way I present this, but go with the primary reason why this study was done. Primary reason why this study is done, we all know that Benlysta or belimumab is an approved medication for the treatment of lupus as an add-on therapy for both mucocutaneous and musculoskeletal disease, as well as recently for renal disease. But the primary problem that we face in clinical practice is actually, one, getting approval for the medication or accessibility of the medication in the institute, given the potential cost. And the argument is usually, even though this is a phase 3 clinical trial proven medication, still does it work in our population or not? One of and the reason being is that we know that many of the medications has racial differences. So some of the medication may not have the same response that you anticipate within a certain race. And unfortunately, the Saudi population or the Gulf region in general have not been represented in most of these phase 3 clinical trials. So from a regulator, as well as from a physician who usually deal with lupus patient, we don't really know whether this medication works in our patients. That's number one. Number two, we also select for these patients the most difficult patient to treat, people who are not responding to usual treatment. And that means that we are trying to show an efficacy in a very hard to treat patients. So that was the primary reason why this study was conducted, and I really acknowledge and thankful to the company sponsoring such activity to assess the efficacy in an independent scientific way. Now, as you know, belimumab can come in two forms, IV and subcutaneous. This study was restricted to the IV form because of the historical development of the IV first before the subcutaneous, and to ensure that the exposure, which is the treatment of belimumab, is actually assessed in the same way, we restricted the study to the IV form. So that's actually the first part of the rationale of the study. Now, the method, this is a single-arm study where a patient who been decided by the physician to have belimumab as an added-on therapy because of their refractoriness of disease were eligible to be included in this retrospective single-arm study, where the index is the first time they received the IV belimumab, and the time interval that we assess the patient is before the index, 6 months, so assess their disease activity before they receive the treatment, how they were doing, and then 6 months after to see how they were doing after the initiation of treatment. So in this particular design, this patient population serve as the exposure and the control. So they are the one who received the treatment, and they are the one who were not on treatment before. So we're comparing before and after. Now, the eligibility is very important. Two parts of eligibility: the recruitment physicians. So the physicians that were part of this study, it's a multicentric study. The physicians were actually experienced physicians in managing lupus patients. They were required to have at least 10 patients with lupus at the time of the inclusion of study. They need to have 5 years of experience, and they had to have at least 2 or more patients treated with belimumab, and at least 1 patient with belimumab at the inclusion time of the study. Now, what about the patient population that were included? The usual inclusion is essentially patients who fulfill classification criteria of lupus, adult patient 18 and above, receiving IV belimumab. Again, that's from historical component. The studies of switching from IV to subcutaneous was reassuring that they are similar in efficacy, more or less. But because of the study time period, we restricted the exposure to the IV belimumab. In addition, the medical history of the patient was mandated to be present in order for the patient to be included, and that's essentially obvious. The exclusion criteria is those patients who received subcutaneous, patients who were enrolled in other clinical trials, and patients with severe lupus nephritis in which belimumab was used as before the appearance or the presence of the phase 3 trial. And the reason why we are doing that to ensure the homogeneity of the study population. As you know, the initial approval of belimumab was for the refractory lupus without severe lupus nephritis, and that was the rationale why restricted it to that study population. The primary outcome is very important. So the primary outcome that was chosen for this study is the practical outcome that physicians usually do in this situation, which is the physician response, overall physician response, 6 months after the treatment. The reason why 6 months, because that's the average estimated time to have real efficacy assessment, although some of the efficacy of belimumab can appear 2 months from the initiation. The definition of physician response is either worse, the same, or improvement with a certain degrees or margin, low, intermediate, or high. Other outcomes are very important. It's the proportion of disease flare-up after the initiation, and that's very important for us as a clinician. I wouldn't add any further treatment if it will not minimize the number of flare-ups and the severity of the flare-ups. The changes in laboratory markers, the changes in proteinuria, and I want to highlight this as an important outcome because there is a lot of discussion on whether the use of belimumab might modify the natural history of a disease or not. So it will be worth looking at their baseline protein level and the changes, knowing that those patients are not known to have lupus nephritis in general. Okay? And of course, we want to look at the steroid-sparing effect, and that's important for acral damage, and that is a justification for added therapy to start with. So this is the results. The overall response, overall we had 4 physicians, so 4 center enrolling patients, 47 eligible patients, and 44 completed the 6 months follow-up of belimumab, and most of those patients were female, ages 33. The demographics are very similar to what you treat with lupus in general. I want to highlight a very important part, which is the moderate to severe patients at baseline are majority of the patients. So remember, those patients are severe refractory patients. Yet, and the other characteristics are listed here. Now, because of the time, I will try to skip a lot of things, but I will go back here. So this is the results at 6 months post-treatment. You can see that the clinical improvement was achieved in a significant proportion of the patients. In another way, we only had 1 patient who did not have significant improvement. The rest of the patient had improvement, most of which are actually clinically significant, i.e. they have moderate to at least severe, moderate to significantly improved, and about 20 to 40% of improvement was noticed in 8 of the patients. So the medication showed significant efficacy in patients with moderate to severe in majority of them, and that's very important. Now you can see that the pre and post response on the flare-up rate. You can see that pre-index, the flare-up rate was high, but 50% of them had flare-ups, and the proportion of flare-ups reduced significantly post-treatment, so that's the second outcome was achieved. Changes in serology, not much on the, significantly on the double-stranded DNA, and some changes on the CRP. Complements were not dramatically different. But what is more important is also the changes in the proteinuria, and that highlights the potential of this treatment to treat even subclinical disease activity. Now, I have to highlight those patients were not biopsied completely, so we don't know their stats before and after, but by all means, it was a favorable outcome. Now, most important part, and that's the last that I'm going to highlight, is the steroid-sparing effect, and that's paramount on the management of lupus patient and prevention of acral damage. You can see that there has been significant reduction of a steroid use before and after, and that persisted after the treatment. So what I want to conclude with, and this is, I think, the most important part, belimumab is a very interesting medication that has been proven on phase 3 trials on mucocutaneous and arthritis, as well as in lupus nephritis lately, to be an effective added-on therapy for lupus patients. But what is very important, we can see from this study that this medication also works in our population, and it works quite well, even when there is moderate to severe disease activity. And the steroid-sparing effect is clearly demonstrated with this study, highlighting the importance of this medication. Before I leave, you will ask a very important question. What about the comparison between this treatment and a control group that did not receive the treatment, since this is a single-arm study? And what is the cost implication of this medication if you are practicing with the mindset of health economics? And I will answer this soon in the next study. Thank you so much. I would like to thank all the authors and Dr. Saeed, who is the corresponding author of this paper. I would like to thank the company taking the courage to do a study in this population and demonstrate to assess the efficacy of this medication. I encourage all the companies to do similar things in our study population. Thank you. So I think you had enough of me, but apparently I'm presenting another paper. So I will just do a quick introduction. We are so proud of the level of work that the trainees and the future rheumatologists are doing in the field. As I mentioned, one of the very important questions that we had in mind is whether Benlysta or belimumab actually works in comparison to a control group, not only on an individual who are moderate to severe, and how is the implication of cost to regarding the utilization of this medication. So to address this question, we had the opportunity to work with a very good talent. Dr. Abdullah is a medical intern who was part of the group that conducted a very nice retrospective cohort study on the cost consequences analysis of belimumab versus standard of care. And although I'm his supervisor and I'm supposed to present, I think we all believe in the future talent. So he will do the honor of presenting, and I will be here to back him up and answer any further question. Without further ado, please, Dr. Abdullah, proceed.
Assalamu alaikum. Good morning, everyone. Thank you so much for giving me this opportunity to present this case, and this is our research project. Our research titled as the cost consequences analysis of belimumab versus standard of care for the management of SLE in Saudi Arabia, a retrospective cohort study, under the supervision of Dr. Ibrahim al-Maghlout and Dr. Yazid al-Ruteh. So, my outline of the talk today will be introduction, methods, and result and conclusion. I will be brief as the time limited. So SLE is a multisystematic autoimmune disease that carries high mortality and morbidity, and with reduced health-related quality of life. The treatment and the management of SLE has improved in the last decades, and it's now moving from the standard of care treatment such as hydroxychloroquine, the systematic corticosteroids, and conventional immunosuppressive to more targeted therapeutic agents such as the belimumab. Belimumab is the first and the only approved biologic for the management of SLE as an add-on therapy. The use of belimumab in the clinical practice is limited due to high acquisition cost and the uncertainty about the cost effectiveness. As per to our knowledge, there is no study in Saudi Arabia compare the cost effectiveness of belimumab versus standard of care. So our study aimed to compare the cost and the effectiveness of belimumab versus the standard of care for the management of SLE in Saudi Arabia using real data work. So moving on to the methodology, this is a retrospective cohort study that was conducted in King Khalid University Hospital, Riyadh, Saudi Arabia, between the duration of March 2020 to December 21. The data was retrieved from the National SLE Prospective Cohort study in Saudi Arabia. Our inclusion criteria were adult patients above 18 years old diagnosed with SLE, managed with belimumab plus standard of care versus standard of care alone. And they were treated for at least 6 months. Outcome variables were the disease activity reduction using the systematic lupus disease activity index score and overall medical cost. So regarding the statistical analysis, we used the descriptive analysis to assess the mean, standard deviation, and frequencies. We used the interventional analysis such as the BERT, t-test, ANOVA as appropriate. Multiple linear regression was conducted to assess the impact of belimumab versus standard of care regarding the disease activity and also with controlling the confounders. This was approved from the Institution Review Board of King Saud University College of Medicine. Moving on to the results, so 14 patients were assessed and were retrieved from the National Prospective SLE Cohort database. 56 patients were only included in our study. 15 patients were on Molimumab, and 41 patients were in the standard of care treatment with a ratio 1:3, with a 1:3 ratio. So this table shows the baseline characteristics of the patients included in our study. You can see here the mean age was 38 years, and the majority of patients were adult, females, and the mean duration of disease was 13 years, and the mean duration of treatment was 10 months. There was quite similarity between the baseline characteristic of patients who were included in the study in the both columns, but with quite differences, such as the lupus nephritis was found in 50% of patients in standard of care in comparison to 25% of patients in Molimumab. Not surprisingly, that cutaneous lupus was found in 2/3 of patients in Molimumab in comparison to 25% of patients in standard of care. We assessed the baseline disease activity using the systematic lupus erythematosus disease activity index. You can see here that 2/3 of patients in the standard of care were in the no activity or mild activity, where in patients in Molimumab were in the mild to moderate disease activity, which means that patients in Molimumab as a baseline were having higher disease activity. Moving on to assess the impact of Molimumab in the disease activity, we use the multiple regression analysis while controlling the co-founders such as the baseline disease activity, duration of treatment, age, gender, and duration of illness. You can see here with the use of Molimumab, there was a significant reduction in the disease activity with a regression coefficient 3.6 and a statistically significant p-value. Moving on to this figure shows the average cost of Molimumab versus the standard of care. The Molimumab cost an average $8,500 in comparison to standard of care that cost an average $3,200. And just a quick reminder that we assessed only the medical direct cost, that for instance, including the prescribed drugs, lab orders, outpatient visits, etc. For this table, we are assessing the differences in the cost and the disease activity with the use of Molimumab versus standard of care treatment. You can see here the difference in the mean difference in the cost between the Molimumab and the standard of care was $5,300, with the 95 confidence interval to be to fall within this range. We're using the bootstrap analysis with 10,000 replications. Regarding the Molimumab, you can see here that it showed a reduction in the disease activity upon follow-up by 3 points in comparison to standard of care, where they showed no regression or worse outcome. So we can say from this table that for each reduction, for 1 point reduction in the Molimumab, it will cost $1,500. In this bootstrap distribution of the cost effectiveness, we showed that there is a 96 showed that the reduction in the disease activity with the use of Molimumab, but it will be more effective but at a higher cost. And 4% showed that there will be worse outcome with a higher cost. So in conclusion, Molimumab is an effective biologic therapy for the management of SLE and reducing acral damage. Molimumab has demonstrated better effectiveness in combination with the standard of care in comparison to standard of care alone, with a higher upfront direct cost and potentially long-term cost avoidance. For sure, our study has some limitations, such as a very small sample size, a single center. We did not assess the quality of life of patients after the belimumab introduction, and also we assessed only the disease activity using one scale, where there are other scales also. But we believe that we are the first step for full economic evaluation in the future for the belimumab and other biologic, inshallah, in Saudi Arabia and in our region. Thank you so much.
يعطيكم العافية جميعا. My question for Dr. Ibrahim Al-Maghlouth about the abstract regarding real-world effect of the intravenous belimumab.
Thank you so much. That's a wonderful question. So I think if I'm going to recap, the question relates to the prognostic factors that predict a response of belimumab as a treatment option. And you highlighted that PLIS is one of them, of course. Now, in the clinical practice, the things that we measure usually is the serology. So those people, you are right that the people with higher serology tend to have decent response or better response. However, there are a couple of issues that if you look at the trials, patients with even less concordant serological profile can still benefit from belimumab. There is, from a clinical practice, the way I see it is that, of course, those people who tend to have very high serology in concordance with their disease activity are really best suited for both B-cells depleting agents, whether rituximab or belimumab. However, I also understand that in those patients who are persistently active and requires high doses of steroid, even if they are not seroconcordant, a trial of belimumab rather than rituximab is worth it, because the efficacy was also noticed for this medication in patients with less concordant serological profile. I hope that answers the question.
Any more questions to our speakers? Okay, if no more questions, yeah, where? Yes, please.
Thank you. My question to Dr. Mufaddal, and happy to see you again. I saw in your lecture that there is a switch between mainly from the JAK to TNF, isn't it? And I thought that was strange, because I know anti-TNF was initially approved, so I expect patients to be on TNF and they're shifted to JAK. So what's your explanation for this?
Well, this is very interesting, right? Because the study was Australian, so the US label mandates that you fail a TNF before you're eligible for a JAK. But in Australia, you can start a JAK first line. So obviously, there are people that have started JAK as first line. And then after the failure of a JAK as a first line, 50% of them actually switched to a TNF inhibitor after failure of a JAK, whereas those that the others might have switched to other mechanism of action, and 1/3 actually switched to another JAK. So this really describes the fact that cycling JAKs is actually effective, and starting JAKs as first line was actually practiced in a community rheumatology setting. Yeah.
Thank you.
Thank you very much.
Any more questions?
I have a comment, actually. The microphone works. So my comment is actually, I like this study. I paid attention, which is unusual. Usually I play with my iPhone. But your presentation attracted my attention. So my only encouragement for people here listening to us, and obviously from you from Lilly, is to have our own data, our own real world data. Maybe start pushing companies to listen to us. We need our real world data. We need the randomized controlled trial to be conducted in Arabs. Because how can we evolve? How can we become like the Western counterparts? They have their own guidelines. Maybe our population is different. Our genetics are different. Our responses to treatments is maybe different. We don't know that. We just copy the Western data and then talk to each other, and we discuss things, and we find out that, oh, this drug doesn't work here, or that drug doesn't work here. Take HLA-B27, for example. It's not almost non-existent here. It's very low prevalence. So the classification criteria for ASAS doesn't work. So it's the same thing. Always we have to take the context of our own Gulf region in the formula when we treat and care for patients. Yes.
I think for the sake of time, we should stop over here. Thank you very much, Dr. El-Hazmi as a moderator, Dr. Al-Naqbi, Dr. Al-Aithan, Dr. Al-Maghyoud, and Dr. Al-Zaidi for the nice presentations. They'll be around if you have any more questions to them. Thank you very much for all of you.
Thank you, Dr. Suad and Dr. Ahmed. Now please stay on stage for the hours. أدعو الدكتور ماجد البرديسي عضو اللجنة المنظمة لتكريم السادة المتحدثين في هذه الجلسة مع الدكتورة أيضا حنان الرئيس. البداية مع الدكتور أحمد الحازمي. شكرا دكتور أحمد. ثم الدكتورة سعاد هناوي. ثم البروفيسور خالد النقبي. الدكتور مفضل العيثان. ثم الدكتور إبراهيم المغلوث. والشكر موصول للدكتور عبد الله الزايد. صورة جماعية للسادة المتحدثين. عبد الله الزايد تفضل. الله يحييك. صورة بس جماعية. السادة والسيدات، نفيدكم بأن موعد حفل الافتتاح الرسمي سيكون في تمام 1 ظهرا بمشيئة الله، أي بعد 45 دقيقة من الآن. والآن استراحة لصلاة الظهر، وندعوكم باسم المؤتمر إلى طعام الغداء في مطعم 365. سيكون الغداء بعد الافتتاح بإذن الله. أعتذر منكم، سيكون طعام الغداء الآن والافتتاح على موعده في تمام 1 ظهرا بمشيئة الله. آخر كلام الغداء الحين. حياكم الله.
تست.
الإخوة والأخوات، نأمل منكم تكرما إخلاء القاعة لتجهيزها لحفل الافتتاح. يسرنا باسم المؤتمر دعوتكم إلى طعام الغداء في مطعم 365. نعتذر منكم، نأمل إخلاء القاعة بشكل عاجل استعدادا لتجهيزها لحفل الافتتاح الرسمي برعاية من وزارة الصحة. جاهزين؟ السلام الملكي.
استاذ عبد الله رح نمشي فيهم على السريع بس كرمال الوقت.
طيب.
بس رح نفرجي اول مقطع ونكفي على البقوه.
طيب يلا. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. حياكم الله. خير بداية لحفلنا هذا آيات من الذكر الحكيم.
بسم الله الرحمن الرحيم. ألم تر أن الله أنزل من السماء ماء فأخرجنا به ثمرات مختلفا ألوانها ومن الجبال جدد بيض وحمر مختلف ألوانها وغرابيب سود ومن الناس والدواب والأنعام مختلف ألوانه كذلك إنما يخشى الله من عباده العلماء.
العلماء. ضيوفنا الكرام، برعاية كريمة من معالي المهندس فهد بن عبد الرحمن الجلاجل وزير الصحة، وانطلاقا من حرص الجمعية السعودية لأمراض الروماتيزم على تسليط الضوء على أحدث مستجدات أمراض وعلاجات الروماتيزم، تتشرف اللجنة المنظمة للمؤتمر السنوي التاسع أن ترحب بكم في حفل افتتاح المؤتمر لهذا العام 2023 تحت شعار التحديات والتطور العلمي في علاج أمراض الروماتيزم. سادة والسيدات، نشاهد وإياكم الآن عرضا مرئيا عن إنجازات الجمعية السعودية لأمراض الروماتيزم.
الجمعية السعودية لأمراض الروماتيزم. تأسست الجمعية السعودية لأمراض الروماتيزم تحت مظلة الهيئة السعودية للتخصصات الصحية في شهر مايو من العام الميلادي 2010 لتكون جمعية وطنية رائدة في مجال طب أمراض المفاصل والروماتيزم على مستوى المملكة العربية السعودية، وأن يكون لها تأثير إيجابي على الرعاية الطبية المقدمة لمرضى المفاصل والروماتيزم. في العام 2018 بدأنا كتابة رؤية جديدة لتحقيق الأهداف على مستوى الخدمات الطبية والأنشطة العلمية المختلفة، تتمثل في خلق بيئة علمية وصحية تهدف إلى تعزيز مفهوم التثقيف الصحي وتحقيق السلامة لدى كافة أفراد المجتمع. وعملت
السادة والسيدات، الكلمة الآن لسعادة رئيس الجمعية السعودية لأمراض الروماتيزم الدكتورة حنان بنت محمد الرئيس، فلتتفضل مشكورة.
شوفوا الصوت إذا كويس أو لا. كده كويس الصوت؟ أيوة شيلوا كله. بسم الله الرحمن الرحيم. الصوت كده كويس؟ يس. بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. هذا تيست. إحنا قلنا فضل القاعة نسوي تيست. أوكي تمام كده الصوت؟
يس دكتور.
أوكي تمام.
شكرا دكتورة حنان. الكلمة الآن للدكتور فهيد العنزي. شكرا دكتور فهيد. أصحاب السعادة، ضيوفنا الكرام، يسرني الآن أن أدعو سعادة الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات الصحية بوزارة الصحة لإلقاء كلمته بهذه المناسبة. شكرا دكتور طريف. نستأذنكم في البقاء على منصة المؤتمر لبدء تكريم اللجان والجهات الراعية والداعمة. يسرني في البداية أن أدعو أعضاء اللجنة التنظيمية للمؤتمر فليتفضلوا على المنصة لأخذ صورة تذكارية. الدكتور فهيد العنزي، الدكتورة حنان الرئيس، الدكتورة ميسون البلوي، الدكتور ماجد البرديسي، الدكتورة أمل الحارثي، الدكتور عبد اللطيف بن حمد العنزي، والدكتورة لينا بنت فيصل الكيبي ولا الكعبي؟ الكبي.
استاذ عبد الله، نحن اتفقنا نقول الساينتفك والاورجنايزنج مع بعض.
طيب تمام. من هنا العكس.
دكتور حنان. دكتور حنان.
تعال.
بدك
ارسلت لي كذا الكلمه ما ارسلت لي الحين ارسل طبعا هذا حيتحدد خلاص. ارسل لك هذا
اي موجود هنا. في هنا أمل، لينا، ميسون. لا. طيب.
بعدهم احط لك اياه احسن.
تمام.
باقي شيء؟
لا لا خلاص.
هنا تصير هذا شيء هذا شيء هذا شيء هذا شيء.
انا بعت لي اياها
هنا 9 هنا 10 اريد حافظ حطيناه هنا.
اي موجود. لا 11. بعدين ندخل على الرعاة.
لا في واحد هنا تقفل هنا بعد هذا الأعضاء اللي في منصور العزم هنا بحطه هو 10. تمام؟ كده كويس؟
طيب تمام. جبناك لين هنا.
ابغى المقدمه حقتك اللي قلتها قبل شوي اللي فيها اسماء مين بيتكلم مين
معك. طيب حاضر، بس تعطينا نخلص بس البروفا. موجود. اي ميسون البلوي موجود. اي هذه الكلمة اللي عندي نفسها ترسلي لي اياها.
لا مو الكلمه، انا ابي تديني الكلمه حقتها وحقت الدكتور. انا ابي
طيب نكمل يا ريم.
ايه بليز.
انا ابي طيب نكمل بس البروفا.
انت بس تقولهم
كل اللي تبينه عشان ما عندنا وقت.
اوكي انت بس تقولهم كلهم رح تطلع هيدا الشاشه الاورجنايزنج والساينتفك كوميتي.
طيب
فاذا فيك انت عم بتقول انه ندعو انه ننظم والساينتفك مع بعض او شيء.
طيب
بس كمان
طيب قربت. طيب أدعو اللجان التنظيمية والعلمية على المسرح جميعا لأخذ صورة تذكارية. طيب. الأسماء واضحة. والآن تكريم الجهات الراعية والداعمة للمؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم.
في قبل البورد ممبرز.
نكمل هذول؟
ايه ما في قبل يعني في الجهات الساينتفك والاورجنايزنج.
ايوه في الجمعيات. لا عفوا اعضاء مجلس اداره الجمعيه. اي
اوكي نكست.
طيب الجهات الراعيه: الرعاة البلاتينيون، شركه جانسن، شركه GSK، شركة آبفي، ثم الرعاة الذهبيون شركة استرازينيكا، فايزر، نوفارتس، ليلي، بورينجر أنجلم، شركة ساندوز. ثم الرعاة الفضيون شركة نيو بريدج، شركة حكمة، شركة آمجن، وشركة أورجانون. كما يسر اللجنة المنظمة للمؤتمر تكريم جمعية روماتيزم، الجمعيات المتعاونة، الرابطة العربية لجمعيات الروماتيزم، ثم الجمعية السعودية لهشاشة العظام. والآن يسر المؤتمر أن يقدم تكريما لمعالي وزير الصحة يستلمه بالنيابة الدكتور طريف بن يوسف، ثم تكريم لسعادة الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات الصحية. شكرا لحضورك وتشريفك للمؤتمر. ضيوفنا الكرام، ندعوكم الآن إلى أخذ جولة على المعرض المصاحب للمؤتمر، ثم نعود لاستكمال جلسات المؤتمر في تمام الساعة 2 ظهرا. تمام ريم؟
Perfect, thank you.
وياك
ابغى اشوف انا بوزيشن، هل انحني او لا؟ لان صراحه قبل شوي ما ريحني الكلام في شوي.
شوف، هو المايك ياخذ صوتك من كل الجهات، فانت لو تكلمت والتفت يمين او يسار هو ما اخذ صوتك. جرب.
بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين.
الصوت واضح،
ممتاز.
يعلي من عندك.
خلاص ممتاز. ممتاز. سعادة وكيل وزارة الصحة الخارجية الدكتور طريف الأعمى. ممتاز. على بركة الله. شكرا لك، شكرا لك، شكرا لك. أبشر.
شوف هي حذفت الأسماء المكررة. هنا شوف كذا حذفتها.
طيب بقول لك الأسماء قولي بنفس الترتيب. أول شيء حنان الرئيس.
دقيقة هنا حنان الرئيس. أيوه.
منصور العازمي.
كيف ماشي؟
من كذا الترتيب.
طيب دقيقة.
لحظة أنت اللي معك هو الصح. إيش اللي بعد حنان عندك؟
ميسون البلوي. شوفي هو أهم شيء دقيقة، 1 هنا 2 والباقي كله استمر.
قالت لك قولها كذا عادي بالترتيب، احنا قيمتها لنا غير. خلاص؟
أفضل.
أصورها هذه؟
شوفي أقول لك أعطيك إياها تكتبيها.
أنا بتابع. تبي نسخة من هذه؟ إيه عشان أنا بتابع. بتابع مين؟ إيه
طيب كويس.
أنا حرسل وورد أخذها على كذا. طيب
يلا أحسن من التصوير.
يمكن بس أنا بتابعها يعني عشان أكون بالتدقيق. كذا بكتبها يعني. بس
إيه لا هو نفس الترتيب. في عندنا بعد القرآن.
إيه حبيبي تسلم. خلاص أنا بتابع.
طيب الله يسلمك. صح.
إيش عندك دكتورة حنان الرئيس بعدين
فهيد العنزي. ريم. السلام الملكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. ضيوفنا الكرام، السلام عليكم ورحمة الله وبركاته. خير بداية لحفلنا هذا آيات بينات من الذكر الحكيم.
بسم الله الرحمن الرحيم ألم تر أن الله أنزل من السماء ماء فأخرجنا به ثمرات مختلفا ألوانها ومن الجبال جدد بيض وحمر مختلف ألوانها وغرابيب سود ومن الناس والدواب والأنعام مختلف ألوانه كذلك إنما يخشى الله من عباده العلماء إن الله عزيز غفور إن الذين يتلون كتاب الله وأقاموا الصلاة وأنفقوا مما رزقناهم سرا وعلانية يرجون تجارة لن تبور ليوفيهم أجورهم ويزيدهم من فضله إنه غفور شكور والذي أوحينا إليك من الكتاب هو الحق مصدقا لما بين يديه إن الله بعباده لخبير بصير.
مساكم الله بالخير جميعا. سعادة الوكيل، أصحاب السعادة، السيدات والسادة، برعاية كريمة من معالي المهندس فهد بن عبد الرحمن الجلاجل وزير الصحة، وانطلاقا من حرص الجمعية السعودية لأمراض الروماتيزم على تسليط الضوء على أحدث مستجدات أمراض وعلاجات الروماتيزم، تتشرف اللجنة المنظمة للمؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم أن ترحب بكم في حفل افتتاح المؤتمر لهذا العام 2023 تحت شعار التحديات والتطور العلمي في علاج أمراض الروماتيزم. يهدف المؤتمر إلى التركيز على تقدم وتطور الفكر العلمي في مختلف أمراض الروماتيزم وتشجيع وتعزيز تبادل الفكر في مجالاته بين المؤسسات والتخصصات المختلفة، وبمشاركة وحضور نخبة من المختصين والأكاديميين من داخل المملكة وخارجها، ومشاركة جمعيات محلية خليجية وعربية، حيث يضم برنامج المؤتمر 18 ورشة عمل و23 جلسة علمية تتنقل بين طب روماتيزم الكبار والأطفال وندوة خاصة لأطباء الأسرة والباطنة. السادة والسيدات، نشاهد وإياكم الآن عرضاً مرئياً عن إنجازات الجمعية السعودية لأمراض الروماتيزم.
الجمعية السعودية لأمراض الروماتيزم. تأسست الجمعية السعودية لأمراض الروماتيزم تحت مظلة الهيئة السعودية للتخصصات الصحية في شهر مايو من العام الميلادي 2010 لتكون جمعية وطنية رائدة في مجال طب أمراض المفاصل والروماتيزم على مستوى المملكة العربية السعودية، وأن يكون لها تأثير إيجابي على الرعاية الطبية المقدمة لمرضى المفاصل والروماتيزم. في العام 2018 بدأنا كتابة رؤية جديدة لتحقيق الأهداف على مستوى الخدمات الطبية والأنشطة العلمية المختلفة، تتمثل في خلق بيئة علمية وصحية تهدف إلى تعزيز مفهوم التثقيف الصحي وتحقيق السلامة لدى كافة أفراد المجتمع. وعملت الجمعية على وضع خطة متكاملة لتطبيق وتعزيز المفهوم الشامل للتطوير المهني، كانت الطريق إلى إنجازات تم تحقيقها لرفع الكفاءة المهنية والأكاديمية في شتى المجالات العلمية والبحثية، والتي تهدف إلى إيصال المعلومة والمهارة الصحية بشكل سليم وفق أحدث الطرق التدريبية. إنجازات الجمعية السعودية لأمراض الروماتيزم: إنشاء السجل السعودي لأمراض التهابات المفاصل SAR Saudi Arthritis Registry. إصدار البيانات العلمية والأدلة السريرية المختلفة في عدة مجالات، إصدار المجلة العلمية الخاصة بأمراض الروماتيزم والمناعة، وهي الأولى من نوعها في منطقة الخليج والشرق الأوسط التي تخدم البحوث العلمية للمنطقة وعالمياً. التعاون مع جمعيات عالمية ومحلية، ومنها الجمعية الأمريكية للروماتيزم، والرابطة العربية لجمعيات الروماتيزم، والرابطة الآسيوية لأمراض الروماتيزم. الاهتمام بالموقع الإلكتروني الذي يتضمن تعريفاً بالجمعية وجميع المعلومات المتعلقة بها واللوائح والسياسات المتبعة فيها، ويحتوي على العديد من الأنشطة للطبيب والمريض، ومنها بوابة المريض التي تعمل على الاهتمام بتثقيف المرضى والمجتمع من خلال وجود كتيبات عن أمراض الروماتيزم المختلفة وترجمة لكل أدويتها. إصدار مجلة جسور كأول مجلة في المملكة تبني جسرا بين الأطباء والمرضى. إقامة فعاليات الأيام العالمية لتوعية المرضى في كل مدن المملكة. كما حرصت الجمعية على استمرار الأنشطة الأكاديمية بأنواعها من ورش عمل تدريبية ونادي الروماتيزم الشهري وندوات سنوية متخصصة، وذلك في مختلف مناطق المملكة. واليوم وبرؤية جديدة نشهد مع الجمعية السعودية لأمراض الروماتيزم إقامة مؤتمرها السنوي التاسع للعام 2023 برعاية معالي وزير الصحة تحت شعار ويتضمن برنامجا خاصا للروماتيزم الكبار، وبرنامجا خاصا لطب روماتيزم الصغار، وبرنامجا لطب الأسرة والباطنة، وبرنامجا للتمريض، و18 ورشة عمل. المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم.
كل التوفيق للمشاركين في المؤتمر بإذن الله. السادة والسيدات، الكلمة الآن لسعادة رئيس الجمعية السعودية لأمراض الروماتيزم الدكتورة حنان بنت محمد الرئيس.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. سعادة وكيل وزارة الصحة للخدمات العلاجية الدكتور طريف الأعمى، سعادة أعضاء مجلس إدارة الجمعية السعودية لأمراض الروماتيزم، أصحاب السعادة، الضيوف والحضور الكرام، أحييكم من القلب تحية خالصة، تحية يطيب شذاها مسكا وريحانا. أحييكم بتحية الإسلام، السلام عليكم ورحمة الله وبركاته. يسرني في بداية كلمتي أن أتقدم بالشكر إلى سعادة وزير الصحة المهندس فهد الجلاجل بالشكر والتقدير لرعايته الكريمة لمؤتمرنا السنوي التاسع. كما يطيب لي أن أرحب بسعادة وكيل وزارة الصحة الدكتور طريف الأعمى بتشريفنا وافتتاح المؤتمر. أرحب بكم جميعا في اللقاء العلمي المؤتمر الدولي التاسع للجمعية السعودية لأمراض الروماتيزم والذي تنظمه الجمعية. أيها الجمع الحضور، لقد سعت اللجنة العلمية للمؤتمر إلى استقطاب الخبرات العلمية المتميزة من السعودية ومن مختلف دول العالم كي تجتمع تحت مظلة مؤتمر الجمعية وتعمل على إثراء فعالياته، آملين من الله أن يحقق الأهداف التي من أجلها تم انعقاده. صاحب السعادة والجمع الكريم، إننا جميعا نسعى إلى خدمة الإنسانية في كل مكان، وكل منا له طريقته، ولقد أخذنا على أعتاقنا في الجمعية السعودية لأمراض الروماتيزم مهمة البحث في مجال الروماتيزم لإثراء المعارف العلمية، ذلك المجال المتشعب في تخصصاته المحير إلى حد بعيد في أعراضه وتشخيصه وعلاجه. إن الجمعية السعودية لأمراض الروماتيزم كما رأيتم تعمل في سياستها على تأصيل وإثراء معارف البحث العلمي والتشجيع على استمرارية الدراسات العلمية التي هي رافد أساسي لتحسين النتائج السريرية لمختلف الأمراض الروماتيزمية من خلال تطوير الخطط التشخيص العلاج ووضع الأدلة والمبادئ التوجيهية السريرية لعلاج أمراض المناعة والروماتيزم. إن انعقاد هذا المؤتمر تحت شعار التحديات والتطور العلمي في علاج الأمراض الروماتيزمية ليس مجرد شعار نرفقه، بل هو واقع حي في مسيرتنا العلمية، حيث أن البحث العلمي هو أساس كل تقدم وازدهار، والتي تسعى الجمعية السعودية لأمراض الروماتيزم إلى تطويره تماشيا مع رؤية المملكة 2030 في التطوير. هذه السنة الرابعة التي نحتفل فيها بالسجل السعودي لأمراض الروماتيزم وأبحاث الأطباء الشباب في طب روماتيزم الكبار والصغار. تلقينا 56 بحث، تم قبول 29 بحث للعرض، وسوف نعلن عن أفضل 3 بحوث أثناء حفل الختام يوم السبت بإذن الله الساعة 2 ظهرا. أيها الجمع الكريم، إن لوزارة الصحة دور حقيقي وفعال في الحفاظ على مستوى مقدمي الخدمات الصحية بالمملكة، حيث أنها البوابة الرئيسية لتحقيق الجودة والخدمة المقدمة من خلال القطاع الصحي، إلى جانب دورها البارز والملموس في دعم الأدلة السريرية لعلاج الأمراض المزمنة ومجاراة كل جديد على ساحة البحث الغنية بالتطور والمتتابع والمستمر. صاحب السعادة الضيوف الكرام، اسمحوا لي أن أرحب بضيوف المؤتمر من مختلف دول الخليج وأنحاء العالم والسعودية، ولا يسعني في هذا الحفل إلا أن أتوجه إليهم بالشكر والتقدير على تكبدهم عناء الانتقال من بلدانهم للمشاركة في المؤتمر. كما يسعدني أن أرحب برئيسة الجمعية العربية الدكتورة فاطمة بوطيبان، ورؤساء الجمعيات الخليجية أو من ينوب عنهم الكويت وقطر والإمارات المتحدة والبحرين، وبضيوف المؤتمر الذين حرصوا على حضور الفعاليات والمشاركة في تحقيق أهدافه. وأتوجه بالشكر والامتنان إلى جميع أعضاء اللجنة المنظمة واللجنة العلمية، وعلى رأسهم الدكتور فهد العنزي، الذين لم يدخروا وسعا خلال فترة الإعداد إلا وعملوه وعلى ما بذلوه من جهد ليخرج هذا الحدث العلمي الضخم على هذا الشكل الذي ندعو الله سبحانه وتعالى أن يؤتي ثماره. كما أتقدم بالشكر لشركاء النجاح الشركات الداعمة، وأخص الدعم البلاتيني شركة جانسون وشركة أفي وشركة JSK وجميع الداعمين الذهبي والفضي، وجميع الجمعيات المشاركة، الرابطة العربية لأمراض الروماتيزم، جمعية هشاشة العظام، والجمعية الخيرية لأمراض الروماتيزم. أشكركم لحضوركم، وأتمنى أن يكون المؤتمر على المستوى والفائدة التي جئتم من أجلها. في نهاية حديثي أدعو الله مخلصة أن يتكلل هذا العمل بالنجاح، وأن يحقق الأهداف التي من أجلها تم انعقاده، وأن يعيننا على خدمة المرضى في مملكتنا الحبيبة وفي كل مكان. والسلام عليكم ورحمة الله وبركاته.
شكرا دكتورة حنان. الكلمة التالية مع رئيس المؤتمر الدكتور فهد العنزي.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. سعادة وكيل وزارة الصحة للخدمات العلاجية الدكتور طريف الأعمى، رئيسة الجمعية السعودية لأمراض الروماتيزم الدكتورة حنان ريس، الزملاء والزميلات الكرام كل باسمه ولقبه، السلام عليكم ورحمة الله وبركاته. أيها الحضور الكريم، إنه من دواعي سروري أن أرحب بكم جميعا في المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم، والذي ينطلق معكم تحت عنوان التحديات والتطور العلمي في علاج أمراض الروماتيزم. يأتي المؤتمر انطلاقا من مبدأ تحقيق رؤية المملكة 2030 في القطاع الصحي، ليكون نظاما صحيا شاملا ومتكاملا يقوم على صحة الفرد والمجتمع على حد سواء. وتفعيلا لذلك أقامت الجمعية هذه الفعاليات الصحية الهامة، واليوم نجتمع معكم ولمدة 4 أيام في مؤتمرها التاسع للمناقشة والاطلاع على كل ما هو جديد عن أمراض الروماتيزم. أيها الحفل الكريم، يعتبر المؤتمر في نسخته التاسعة حدثاً علمياً دولياً ينطلق إلى آفاق واسعة وطموحات عالية تحاكي أحدث التطورات في مجال أمراض الروماتيزم برعاية كريمة من معالي وزير الصحة الأستاذ فهد الجلاجل، وبحضور كريم من سعادة وكيل وزارة الصحة للخدمات العلاجية الدكتور طريف الأعمى. كما يشارك معنا في مختلف البرامج العلمية نخبة من الأطباء والمختصين والأكاديميين من داخل المملكة وخارجها، حيث يضم 90 متحدثاً و40 محاوراً في الجلسات العلمية، ويناقش قرابة 29 ملخصاً بحثياً تم اختيارها بعناية مهنية من بين العشرات من الأبحاث العلمية التي تقدمت للمؤتمر. كما أن المؤتمر يصاحبه المعرض الموجود في القاعة الأخرى، والذي يضم شركاء النجاح الداعم الكبير والمساند المستمر لهذا المؤتمر، وهم الرعاة الرسميين والشركاء من مختلف الهيئات والجمعيات والمنظمات في القطاعين العام والخاص. يضاف إلى ذلك أن المؤتمر قد حظي باعتماد الهيئة السعودية للتخصصات الصحية بواقع 40 ساعة تعليم طبي مستمر للمشاركين فيه في مختلف البرامج العلمية. أيها السيدات والسادة، بحول الله وبعد أيام قليلة سوف تحل علينا المناسبة الوطنية السعيدة، وهي يوم التأسيس، والذي نستذكر فيه امتداد الدولة السعودية من 3 قرون، والذي تجلى من خلاله العمق التاريخي والحضاري والاحتفاء بتنوع الإرث الثقافي، ووفاء لمن أسهم في خدمة الوطن من الملوك والأئمة والمواطنين. ومن هنا أرفع لمقام مولاي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز حفظه الله، ولسمو سيدي ولي العهد الأمير محمد بن سلمان حفظه الله، وللشعب السعودي ولجميع الأمم العربية والإسلامية والصديقة أصدق التهاني وخالص التبريكات بهذه المناسبة، سائلا المولى عز وجل أن يعيد هذه المناسبة الكريمة علينا باليمن والبركات والأمن والأمان. ختاما، أتمنى لنا ولكم النجاح والتوفيق في أعمال هذا المؤتمر، والذي نرجو أن تصبو أهدافه للإسهام في دفع حركة التقدم العلمي والمهني ورفع الوعي الصحي في مجال أمراض الروماتيزم. والسلام عليكم ورحمة الله وبركاته.
شكرا دكتور فهد العنزي. أصحاب السعادة السيدات والسادة، يسرني الآن أن أدعو سعادة الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات الصحية بوزارة الصحة لإلقاء كلمته بهذه المناسبة.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد وعلى صحبه أجمعين. الحضور الكرام، الزميلات والزملاء، يسرني في البداية أن أرحب بكم في هذا اليوم المبارك، ويسعدني بالنيابة عن معالي وزير الصحة معالي المهندس فهد بن عبد الرحمن الجلاجل أن أرحب بكم وأن أشارك معكم في افتتاح المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم تحت شعار التحديات والتطور العلمي في علاج أمراض الروماتيزم، والذي يحظى بمشاركة واسعة من الأطباء والخبراء والمختصين لتقديم منصة إثرائية غنية بكل جديد ومفيد في أمراض الروماتيزم. أيها السيدات والسادة، كما تعلمون فإن الدراسات العلمية كشفت عن وجود ما يزيد عن 140 نوعا من أمراض الروماتيزم، والتي لها تأثير مباشر على حياة الفرد والعائلة. ومن هنا تأتي أهمية إقامة مثل هذه المؤتمرات للمناقشة وإبداء الرأي والاطلاع بين الاستشاريين والأطباء والمختصين حول آخر ما توصل إليه العلم من طرق التشخيص لأمراض الروماتيزم وعلاجها بالأدلة المبنية على البراهين المستندة على الدراسات الإكلينيكية. كما يتضمن المؤتمر العديد من الجلسات العلمية والمحاضرات والندوات الطبية وورش العمل، بالإضافة إلى وجود المعرض المصاحب للمؤتمر. أيها الزميلات والزملاء، في الختام لا يسعني إلا أن أتقدم بالشكر الجزيل لمقام خادم الحرمين حفظه الله وسمو ولي عهده الأمين حفظه الله على الدعم المتواصل والمتابعة الدؤوبة للقطاع الصحي لرفع مستوى الأداء وتجويد الخدمات الصحية. كما أن الشكر موصول لفريق العمل في الجمعية السعودية لأمراض الروماتيزم واللجنة العلمية واللجنة المنظمة وجميع المتحدثين والمشاركين، متمنيا لكم التوفيق والسداد، وأن يخرج المؤتمر بتوصيات تسهم في إيجاد الحلول العلاجية والوقائية للحد من مضاعفات أمراض الروماتيزم لدى الأطفال والكبار. والسلام عليكم ورحمة الله وبركاته.
شكرا دكتور طريف. نستأذنكم في تكريم الجهات الراعية والداعمة واللجان التنظيمية والعلمية والسادة أعضاء مجلس إدارة الجمعية. البداية أدعو أعضاء اللجان التنظيمية والعلمية والسادة أعضاء مجلس إدارة الجمعية السعودية لأمراض الروماتيزم: الدكتورة حنان بنت محمد الرئيس، الدكتور فهيد العنزي، الدكتورة ميسون البلوي، الدكتور ماجد البرديسي، الدكتورة أمل الحارثي، الدكتور عبد اللطيف بن حمد العنزي، الدكتورة لينا فيصل الكبي، الدكتور حسين حلبي، البروفيسور سليمان المعيوف، الدكتور موسى العباس، الدكتور يوسف العماري، الدكتور وليد عبد الرب حافظ، الدكتور نايف الغانم، الدكتورة سلطانة بنت عبد العزيز، والدكتورة ريما بكري، والدكتورة لجين أكبر، والدكتور منصور العازمي، والدكتور منصور صويملي، والدكتورة خولة الغانم، والدكتورة فهيدة العنزي. أدعوهم جميعا إلى المنصة من أجل صورة جماعية. شكرا جزيلا، ونسأل الله أن يبارك في جهودكم جميعا. أما الآن فمع تكريم الجهات الراعية والداعمة للمؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم: الرعاة البلاتينيون شركة جانسن، ثم شركة GSK، أيضا من الرعاة البلاتينيين شركة AbbVie. الرعاة الذهبيون استرازينيكا. من الرعاة الذهبيين أيضا فايزر. ثم شركة نوفارتس. ليلي. شركة بورينجر انجلم. أيضا من الرعاة الذهبيين شركة ساندوز. وإلى الرعاة الفضيين شركة نيو بريدج. طيب شركة حكمة. طيب شركة حكمة، شركة آمجن. ثم شركة أورجانون. كما يسر اللجنة المنظمة للمؤتمر تكريم الجمعيات المتعاونة وهم جمعية روماتيزم. ثم الجمعية السعودية لهشاشة العظام. ختاما سعادة الوكيل، يسر المؤتمر أن يقدم هدية لمعالي المهندس فهد بن عبد الرحمن الجلاجل، يستلمها بالنيابة عنه الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات الصحية. كما يسر المؤتمر أيضا أن يقدم تكريما لسعادة الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات الصحية لحضوره وتشريفه لافتتاح المؤتمر. شكرا جزيلا سعادة الوكيل. طيب. أما الآن بحضور الدكتور طريف بن يوسف الأعمى وندعوكم جميعا إلى أخذ جولة على المعرض المصاحب للمؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم. السادة والسيدات، نلتقي مرة أخرى هنا في هذه القاعة في تمام الساعة 2 لاستكمال جدول أعمال المؤتمر، أي بعد 20 دقيقة من الآن نلتقي في هذه القاعة لاستكمال جدول أعمال وجلسات المؤتمر.
2022, the Saudi Society for Rheumatology has been published guideline recommendations for rheumatoid arthritis management by a group of 19 members panel, 14 rheumatologists from most of the Kingdom region, 2 from the ACR members, and 2 policymakers from Ministry of Health, 1 pharmacist, 1 patient representative, and 3 methodologists and epidemiologists. My name is Dr. Hanan Al-Rais. I'm a rheumatologist and the president of Saudi Society for Rheumatology. Today, I'm going to talk about the Saudi recommendations for rheumatoid arthritis management. As you know, the global prevalence of rheumatoid arthritis is estimated to be 460 per 100,000 persons. It remains a significant cause of disability and reduced quality of life globally and in Saudi Arabia. Treatment guidelines for rheumatoid arthritis have been developed by many societies and many well-established societies such as American College of Rheumatology and EULAR, which is European League Against Rheumatism. The Saudi Society for Rheumatology was established in 2010 to improve education, research, and patient care in rheumatology. On a national level, this guideline was a collaborative effort between the Saudi Society for Rheumatology and the American College of Rheumatology. With this national recommendation, the rheumatologist practicing in Saudi Arabia can use this 2022 SSR guideline, which was generated by adaptation of 2021 American College of Rheumatology guideline with considering 5 adopted recommendations. First, let's highlight on some guideline principles. Treatment decisions should follow a shared decision-making process and be re-evaluated within a minimum of 3 months based on efficacy and tolerability of the disease-modifying rheumatic drugs, which is chosen by the primary physician. A treat-to-target approach is strongly recommended over usual care for rheumatoid arthritis patients. Treat-to-target refers to a systemic approach involving frequent monitoring of disease activity using validated instruments and modification of the treatment to minimize disease activity with the goal of reaching remission or low disease activity as a target. Let's see how we can manage our rheumatoid arthritis patients based on this first Saudi guideline. The Saudi panel has been agreed on the total of 39 out of 44 of the American College of Rheumatology recommendations with a development of 5 recommendations. So, for the patient with low disease activity, the Saudi panel suggests using hydroxychloroquine over other conventional DMARD. And this is the same like the ACR. Then, using methotrexate over sulfasalazine in disease as a disease-modifying agent for those who failed the hydroxychloroquine. In a DMARD-naive patients with moderate to high disease activity, the Saudi panel strongly recommended methotrexate over other conventional DMARD. Also, they suggest initiating conventional synthetic disease medication with short course of less than 3 months of glucocorticoids. If patients fail to reach target within 3 to 6 months on conventional DMARD, additional of biological DMARD or targeted synthetic DMARD, including JAK inhibitors, is conditionally recommended over triple therapy for patients taking maximum tolerated dose of methotrexate. For patients taking biologic DMARDs or targeted synthetic DMARDs who are not at a target, the Saudi panel suggests switching to biological DMARDs or targeted synthetic DMARDs of a different class as a conditional recommendation over switching to a biological DMARD or targeted synthetic DMARDs belong to the same class. Addition or switching to disease-modifying anti-rheumatic medication is conditionally recommended over continuation of glucocorticoid for patient taking glucocorticoid to remain at a target. For patient achieving remission, the Saudi panel suggests gradual discontinuation of methotrexate over gradual discontinuation of biological DMARD or targeted synthetic DMARDs. At the end, on behalf of Saudi Society for Rheumatology, I would like to encourage all rheumatologists in Saudi Arabia to follow this national guideline to help advancing the standard of care for our rheumatoid arthritis patients in Saudi Arabia.
السادة والسيدات، ندعوكم إلى القاعة الرئيسية لاستكمال جدول أعمال المؤتمر.
السلام عليكم. تفضل. يلا.
انت عندك البرزنتيشن؟ اوكي طيب. بسم الله. سادة والسيدات، نرحب بكم من جديد في المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم. Ladies and gentlemen, let's move to Satellite Symposium sponsored by Novartis. Please join me welcoming Professor سعاد عطار. سوزان عطار عفوا.
بسم الله والصلاة والسلام على رسول الله سيدنا محمد أشرف الأنبياء والمرسلين. It's always my pleasure to introduce any medication or talk about any scientific part or any scientific content with the conferences in general and especially within the Saudi Society of Rheumatology. لا زال أذكر أول مؤتمر للجمعية كان يوميها في الرياض، دكتور رامز السويلم ودكتورة حنان الريس كانت النائبة، وأنا كنت لسه دوبي جاية من كندا. أول محاضرة ادوني هي عن فيتامين دي، ماني عارفة ليش. ماني عارفة ليش. Right now كنا بنعمل التور، okay, and we were shocked. ما شاء الله كل ما لها عدد الشركات بتزيد، عدد الأدوية بتزيد. It's always never enough. It's always not wrong. لأنه المرضى they have high demands right now. Our patients are becoming more complex. They require more needs. ما صار فقط اللي هم عايزينه إنه to relieve their pain. They want more. And you know something? You became smarter. بسبب المؤتمرات والتوعيات والمحاضرات you became smarter and you start to take care of your patient better and more than before. And that's the aim for what I'm going to present right now. In my first lecture, I talked about the PSA challenge. And in this one, I'm going to talk about one of the medication that cover all the domains. And that's what's called all-in-one relief. I'll go over a case presentation, then the guidelines. It's never enough to go over just a few lines of the guidelines and how the head-to-head trials and the manifestation, how to be covered. So first of all, this is a real patient of mine. He's a 30-year-old gentleman who came with a skin psoriasis, and he have been treated locally and with DMARDs for many years. He started to develop symptoms suggestive of PSA, and there was a significant extensor tenosynovitis in his hand. So you look, he didn't have any axial, nail, IBD or uveitis, but he was fatigued and depressed. بيقول لي يا دكتور أنا ما عندي energy إني أشتغل في الجامعة مو زي زمان. Although he's young, he's 32. So when he was started on methotrexate, now this is more than almost 10 years ago. When he was started on methotrexate, he developed abnormal LFT. And right now we have the multidisciplinary approach. By consultation, he turned half fatty liver, and after treatment, returned back to normal. So polyarthritis, enthesitis, skin, and dactylitis. Started on Cosentyx, and actually on follow-up, his arthritis improved, the hack improved, and his LFT start normal. And in addition, not on any methotrexate, it's a monotherapy. I'm following him up almost right now for 6 years. He's doing perfectly fine. He's just coming to renew his medication. And when I told him about the associated comorbidities and fatty liver and how does that decrease the mortality according to the recent guideline, he started to lose the belly fat in order to improve his fatty liver. So let's talk about all-in-one relief, the AL-17. This have been produced, this imbalance. When we talk about the tissue in the body involved in the spa, we divide them into two. On the right side, there's a sterile part. On the left side, there's the unsterile part. This study have been published by Ian McInnes and colleagues, in which they came up according to the trial. In other words, it's not an animal model. It's not a histopathological diagnosis. They knew that certain patients, they do improve, and accordingly, they decided the cytokine. If you look for the current management, the GRABA, the ACR, the ULR, they all have one thing in common: treat to target approach. Possibly remission, but if not, go with low disease activity. I presented earlier about the GRABA, the good and the beauty about it, especially even in the updated one, it's a domain predominant. In the first 5, or the 6, there are the domain predominant, and then you have the associated condition shown in orange. If you look at the IL-17, they lie in the same line. All the biologic, there's no specific order. It's up to you, the physician, to decide which drug to be started by you according to the associated comorbidities and comorbid illnesses and the patient preference. According to the core Evesta, which is formerly called the Corona, still, the skin, in addition to the polyarthritis, the commonest. Before, when you look at the different trial, they say the nail, the skin, dactylitis, but no, I like to look at one registry that combine all of them, and still the skin and the rheumatology, they're the highest. So looking at the head-to-head trial for the Cosentyx, that is the EXCEED, this is the important study, and it was the first and only double-blinded monotherapy head-to-head trial against the standard of care, which is the adalimumab, and it was for biological naive patient. The primary endpoint was the ACR20. We all know that. I study the primary endpoint is the ACR20 because that's what the FDA needs. Now, you know, it's not a good indices or an endpoint for a patient with PSA because we just said it's a multi-domain disease. So the secondary endpoint was the PASI 90, in addition to the ACR50. Us, the rheumatologists, احنا طماعين. We hope for 90 and even the ACR 100. That is remission for the patient. Changing the hack and the resolution of the enthesitis. Despite that the picture over here, it showed Achilles tendonitis, but always please, when you assess the enthesitis in any study, don't look only on the big enthesitis. Look assessment by the score, i.e. the lead enthesitis index and the other score. So if you look at the results, actually the Cosentyx showed a similar, almost similar, versus the adalimumab based on the ACR20 at 52 weeks, and it did not reach statistical significance. So they're all the same with regard to the joint. So where is the difference? It's actually in the domain. So the skin did better, and that's what's in the EULAR, that's what's in the ACR. They say if you have a skin predominant disease, go either for the IL-17 or IL-23 and 12-23 inhibitor. The Kaplan-Meier curve showed that the retention rate by week 52, the patient who discontinued treatment was less with the Cosentyx compared to the adalimumab. Let's look at the all-in-one relief. We have many trials. There are 6 clinical trials, the pivot trial for the future, in which each one will give you a message. لا تخافوا أنا ما حروح عليها كلها. We don't have time. And you know something? I like to give you the spot on, the important message. So first of all, from the future one, we know that the ACR response was fast and sustained in the time curve. Whenever there's a time curve in any study, I want you to look at 2 things. First of all, how fast, so you could see that the patient improved within 1 week. And number 2, the sustained. And over here, up to 5 years is sustained. Remember, those patients haven't been taken any DMARD agent. In other words, you look for immunogenicity. In other words, if the patients start to lose a response of time, it could be an immunogenicity and antibodies problem. Number 2, looking at the ACR50, that's in the future too, looking to more stringent type of approach in the responders percent. Again, it's higher than the placebo in patient with and without methotrexate. I would love to look at radiographic progression, and يهمني مو بس subjective, tender, swollen joint. I want objective finding. Give me X-ray, give me MRI, and here is the X-ray for you, which show that there is an inhibition and less radiographic damage compared to the placebo, whatever dose you use, whether they use the 300 on the top or the 150 at the lower bottom. Remember, in PSA, with no much skin improvement, the 300 milligram, it's almost similar to the 150. The complex patient, the inadequate response, they are the one that we go on more skin involvement, we go with a higher dose. Resolution of enthesitis, dactylitis, and nail. You could see clearly, your smart audience, it's higher within the Cosentyx than the placebo. But you know something? this is not the only message I want to show you from here. This is a patient of mine who has severe nail psoriasis, and she came to me for a second opinion. She was started on Cosentyx, and you know what? After 3 months with this picture, the rheumatologist decide to change the Cosentyx to another IL-17 inhibitor. Look at the curve, the future one, the nail, the napsa. Where do you see the maximum? By 52 weeks. If we said, okay, it's going to be within 32 to 40 weeks. When I spoke with the dermatologist, I told them, when do you decide that nail psoriasis, the treatment I'm giving, is not good enough for the patient? Nail psoriasis is one of the difficult to be treated because it needs at least 6 months for the growth of the nail bed. So you have to wait at least 6 months before you decide to change the therapy. Now, the primary endpoint, as we said in the morning, if you look at the axial PSA, the one and only study yet what the FDA mandated in any drug in order to approve for axial PSA is the Maximize trial. Now, I'm not talking about the Maximus, which is in Gladiator. واللي عندهم بنات بيتفرجوا معاهم أفلام كرتون or Disney. I'm not talking about the Maximus, الحصان الأليف. Actually, it's the Maximize trial for axial involvement in PSA patient. And you could clearly see that there's an improvement in the axial in compared to the placebo. And if you remember the patient that I presented, which was switched to an IL-12/23 inhibitor, and the patient was already on Cosentyx, they came requesting to go back in the IL-17, stated that they felt better, much better, with no much back pain on the IL-17. Please feel free to take a picture of this. This is a table that I created myself. It's from different studies that I show you, all the future trial, and showing you the percentage in the exceed as well as within the future trial. So let's look at the real-world experience. The trial gives us a stringent type of patient with no more comorbid illnesses. But the real-world experience, they show us the patient that I deal and you deal yourself with. So in the real-world experience in the Serena registry, it showed that actually the retention rate for 2 years, you could see for the AS as well as the PSA patient, it's high. And in the morning, I showed you an abstract that was just presented at the ACR 2022, that the retention rate compared to the TNF inhibitor was higher for the IL-17 as well as the IL-23. And there's no much difference between the above two. Safety. أنا دائما أقول مو بس أبغى الدواء إنه يشتغل كويس، أبغى to be sure that my patient is doing fine. My patient is not developing any side effect. And the safety within the real-world experience, actually, it was consistent profile with the trials. The one I would like to pay your attention with, the one I would like to pay your attention is the following, is the Candida infection. It has been reported that such a patient may have a Candida infection in the whole body. Remember, they have skin psoriasis, or they may have Candida infection in the nail. Simply interrupt the treatment, refer them to the proper service, start antifungal agent, and then restart the treatment. What about the IBD in the form of ulcerative colitis and Crohn's? Less than 1% incidence rate of IBD within the expected background incidence rate. Which means, yes, indeed, we don't give it for IBD patient, but it doesn't lead to the occurrence of new IBD patient. And as we said in the morning, we still have to screen the PSA patient by specific questionnaire and by doing the proper measure, for an example, the stool calprotectin. And finally, looking at the long-term safety real-world experience in 12 RCT trial, there's no trend in increasing the mortality specifically from MACE IBD over time. And again, it's less than 1% incidence rate of IBD. Now, I'm very glad to announce it's not only the good thing about it, it's all in one injection. The good news is, previously, I used to tell my patient who used to take Cosentyx, take 2 injections, 150, and just shot it in each thigh. You know something? I'm glad to announce that right now we have 1 injection that is registered right now in Saudi Arabia, and inshallah, it lists misery to the patient. So in summary, exceeds the first double-blinded placebo-controlled trial, head-to-head trial versus the adalimumab that showed a similar efficacy for the ACR. The maximized complete the efficacy for the axial PSA compared to the placebo. And if you see that the safety trial was comparable, even the real-world experience, but still, we have to follow up our patient closely. And the message I always tell my patient, PSA is different from RA. If you look, everything is longer in PSA than RA. The treatment is longer because it's multi-domain. Remission or low disease activity take longer. And when do we start taper take longer? دائما نذكرهم بالآية الكريمة فصبرا جميلا. Thank you so much for your attention.
شكرا دكتورة بروفيسورة سوزان عطار. إلى الجلسة الثالثة يرأسها البروفيسور عبد الرحمن العرفج والدكتورة أديب الحرز. أدعوهم إلى منصة المؤتمر لبداية الجلسة.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's always a pleasure being with my colleagues in the Gulf region and especially in Saudi Arabia. I'd like to congratulate all the organizers in this superb meeting and the superb organization, and I'd like to congratulate all the people from Saudi Arabia for this successful meeting, and of course including Dr. Hanan Al-Rayes. We have a very interesting session for the commonest disease that we see in practice, rheumatoid arthritis. I'm going to co-chair the session with Dr. Professor Abdurrahman Al-Arfaj, and we have very eminent speakers and very interesting, actually, topics for today. So we're going to start with the first talk, which will be given by Professor Proton Rahman. He's already been introduced to you, and he's well known to all of you. And of course, he's a professor at Memorial University, and his special interest is in SPA. He's an associate editor of the Journal of Rheumatology, and he's going to talk about personalization in the management of rheumatic diseases. Professor Rahman.
Assalamu alaikum. Once again, I'd really like to thank the organizers for giving me a chance to present. I'm privileged to be here in front of you and to talk about something I'm really passionate about, and which is personalization in terms of treatment for inflammatory disease with a specific emphasis in terms of rheumatoid arthritis. When you talk about biomarkers, I could have easily talked about metabolomics or microbiome, but I'm going to choose genomics because to some extent this is what I do in my lab regarding psoriatic disease. Most of what I'm going to refer to is rheumatoid arthritis, but you'll see a little bit of psoriasis and psoriatic arthritis put in there because it's something that I'm really familiar with. So these are my relevant conflicts of interest. They're not really particularly important for this talk. So again, let's ground it by a case. It's basically a 52-year-old female with rheumatoid arthritis. She's failed triple therapy, started on adalimumab, had secondary failure. You're wondering, gosh, what do I do next? And the question that's really being proposed here is, can biomarkers in any way, and particularly genomics, help in guiding therapy? So what do we do when we're in a bit of a quandary? So someone older like me, we would go to a senior physician, and we would, about 20 years ago and say, well, doc, what would you do in this particular setting? In other words, the senior physician would say, in my experience, this is what I would do. Our younger physicians now are looking for a network meta-analysis. They're so used to looking at evidence-based medicine they're saying, what is the pooled experience from the clinical trials along with real-world studies? But where things are going potentially is with respect to personalized features. What are the characteristics of this particular individual? Based on the characteristics, can I choose the right therapy for the right person? So the benefit of looking at precision medicine is that we're going to go from an organ-based approach, in other words, to some extent the same disease entity in terms of pathophysiology, rather than the gastroenterologist, the dermatologist, and the rheumatologist looking at it, to a pathway-based approach. Unfortunately, and as you're aware, a lot of our diagnostic tests really have poor positive predictive values. We really need to think about doing some of these tests, because I don't think it actually helps in terms of elucidating what it is that we're trying to do, and it's actually creating some noise in the background. But specifically, are there any markers that will actually help us with respect to therapeutics? So why are we talking about this right now? Because this has been a dream for many years. Well, first of all, technology has driven costs down. With further investigations, and even in polygenic diseases, we realized that genetic determinants are important, even for multifactorial disorders. And there's been a huge explosion in terms of AI and analytic abilities, which are now accessible to a huge number of individuals. So, is this possible? Is it possible to actually have some sort of biomarker or an omic profile prior to you prescribing a drug? So one of the issues related to it, and it doesn't always have to be with response directly, is if I were to tell you that this patient's at risk for severe progression, in other words, they're in the top quartile of significant progression for rheumatoid arthritis, you may say, okay, maybe I'll use combination biologics. In other words, biologics with a concomitant DMARD, or maybe I'll start biologics earlier. And so it does make a difference if we can actually predict who's going to have more severe disease. So this is one particular study that actually shows that. And so what they've actually done here is looked at patients that had erosive disease, look at the upper quartile, and did a GWAS study. And so they used 43,000 markers, which seems like a lot of SNPs, but technologically, actually, that's not that difficult. And what they've actually found here is that in particularly people that are young, it's actually a better predictor in terms of disease progression than being ACPA positive or having the HLA-DR-beta1 allele as by the serine mutation. So it's possible to actually predict it's superior to the ACPA in terms of who's going to have disease progression. Can you pick it with one particular marker? You'd be very, very lucky if you actually found it. So the markers that we actually pick are ones that are strongly associated with our disease. So for instance, we have known for a long time that HLA-CW6 is associated with psoriasis. So that particular genotype actually does predict response to adalimumab it does predict response in terms of adalimumab versus ustekinumab. And how does it actually do it? It's in HLA-CW6 negative individuals. You can see the difference in the score to your left, a little bit more pronounced in terms of the skin improvement in patients that have psoriatic arthritis, oddly enough, than those that have psoriasis. And this finding has been validated subsequently. Is there anything specific in rheumatoid arthritis? Well, we know that IL-6 inhibition is very effective for rheumatoid arthritis, and so they subsequently have looked at SNPs related to IL-6, and there's one particular SNP, and when you have the G allele, it's actually a lower response. Fair enough. But are these clinically actionable? They're really not, in the sense that the positive predictive value for these are relatively poor, but they're certainly of interest and gives us some enthusiasm at looking at things further. This was a study that was noted before by Dr. Achara, and this is looking at psoriatic disease, where they just looked at cell types. And if you can identify through flow cytometry a Th1-dependent signature as compared to a Th17 signature versus neither or both, and give the subsequent therapy, what the Japanese colleagues have noted is a significant improvement for targeted therapy based on flow cytometry. This is very exciting if they could validate it further. And this is being moved forward by the British group in the OPTIMIZE study. There's a little bit of skepticism, to be honest, that just identifying the cell type will do it. So they have added another feature, and that's looking at the specific cell types and the RNA sequencing related to it. So we'll have to see what happens when this study comes out. To a certain extent, looking at CD4 transcriptome is something we've actually done in our lab. So we actually consecutively look at patients, isolate their CD4, CD8 cells, do expression. And so our first study was looking at comparing secukinumab versus TNF agents. And what we did report almost 2 years ago now in scientific reports is that we can distinguish response to secukinumab, but we had a harder time because the TNF agents are a bit more pleiotropic, determining a clear response to anti-TNF agents. The issue with this is that we actually look at thousands of transcripts, and you need to have this validated. Once you actually have to have it validated, you want to study it prospectively. So we're excited by it, but just cautiously optimistic because we still need to do a lot of work related to this. So now what's happening specifically in terms of rheumatoid arthritis? Again, it's the transcriptome that was used by Ann Barton's group. And what they're actually looking at is you're going to initiate adalimumab for patients that are bio-naive, and they're going to look at the change in transcripted profiling before starting adalimumab and afterwards in 70 patients. Okay? And so on the top is the baseline expression profiling. On the bottom is what happens at 3 months. And you can see that for adalimumab good responders, there's much more of a pattern than adalimumab non-responders. And this was based on about 114 transcripts that they actually looked at. So this is very, very interesting, but it's not validated. Again, they're looking at thousands of genes that have been expressed, and we really want to see this being confirmed before we can take it forward. A slightly more elegant study is the one that's presented here, and it's looking at early prediction response to anti-TNF, but this time they're using multiple omics, and they're bringing machine learning into the mix. Really cool design in a small number of patients initially, so they were all females. There were 39 females, and if you look at the volcano plot, and you look at the red versus the blue, you see that there's differential gene expressions that are being underexpressed or overexpressed, respectively. The more interesting finding is here, though, and that is if you compare the technologies, transcriptome versus identifying the cell in terms of flow cytometry versus proteomics, it's the transcriptome that actually gave you a better response. And then within the transcriptome, you look at non-response versus responders. The non-response actually has less variability. And we found this over and over again, that it's probably initially going to be easier to identify someone from a genomic perspective that is not responding as compared to a super responder. Okay? And that's certainly of interest and something to think about. So they identified one particular gene that's important in terms of cell adhesion, and they took 80 patients then, and they prospectively did that profiling, and the area under the curve was 0.81. That's pretty good. That is pretty good for one transcript and gives us some hope that maybe they are in the right area. Again, validation is important, particularly in a different setting. An even more intricate study is actually done by the Dutch group, again using multi-omics, and now using machine learning to look at whether you can predict adalimumab or etanercept therapy in rheumatoid arthritis. Once again, these patients were bio-naive, okay? And what they did is they looked at patients that are bio-naive, and they gave them either etanercept or adalimumab. Prior to getting the biologic agent, they isolated the CD4 cells, CD14 cells, and they did 2 tests. They looked at the transcripts, or RNA profiling, and they looked at the DNA specifically regarding DNA methylation. Okay? And then based on the responders versus non-responder analysis, they were able to determine a signature for etanercept, and they were able to determine a signature which was different for adalimumab. Now, if you happen to fail etanercept, they were going to give you adalimumab. If you happen to fail adalimumab, they were going to give you etanercept. But the question that they asked is, if you actually had failed and I was switching therapy, and we had developed this model with your initial biologic agent, how successful do you think we'll be in predicting response? So of the 80 patients that were in this study, 9 failed therapy. For those 9 that failed therapy, if you do it in terms of the transcript profiling, their accuracy rate in predicting response versus non-response was 90%. That is excellent. That is really, really good. I'm not sure if we could have predicted someone that has actually failed one biologic agent, their prediction 90% of the time. If you use DNA methylation, it was about 78%. Very, very established group with Tim Ratske. We'll have to see how this study rolls out, but again, quite exciting in terms of the development. This is the best study, however, because this is a randomized controlled trial. It was open label that used a stratified biopsy-driven, biopsy being the synovial biopsy, to look at whether after you fail a TNF, you should give rituximab or tocilizumab. Can you actually predict the response? So what did they do? So much of the basis of this work had to do with this synovial pathotype that was being championed by Dr. Constantino Pitsalis. And so as you're aware, he sort of looks at the histology and identifies this lymphoid myeloid aggregates, which he calls B-cell rich. And B-cell poor is defined as when you have very low amounts of lymphocyte, whether it's a diffuse myeloid or a quasi-immune, where you have a lot of mesenchymal and fibroblastic cells around. So in the histology diagnosis for this particular randomized trial, B-cell rich was lymphoid myeloid cells. B-cell poor was a combination of diffuse myeloid as well as this quasi-immune high fibroblast. So that was the histology type. He also did one other thing. He took the synovial biopsy. There are 79 transcripts that'll give you a B-cell signature, and he defined B-cell poor and B-cell rich based on RNA sequencing. So going into the study, he felt that if you were to be B-cell poor, the study was powered such that it showed a difference in terms of tocilizumab being superior to rituximab, because he felt that rituximab would help in a B-cell rich population. What did the histological classification show? A higher response rate, a response being a CDI of 50%, for the tocilizumab, but it was not statistically significant as compared to rituximab. If, on the other hand, you used RNA sequencing, that was quite significant. So the p-value was 0.035, with 63% reaching a CDI of 50% as compared to 36% for rituximab. The study goes beyond that. So this was published in the Lancet, and a further analysis was done, which was presented in Nature Medicine. When you actually look at the specific pathotypes for the B-cell poor, those with diffuse myeloid cells actually did much better with tocilizumab as compared to rituximab, and this is even more exaggerated if you were to look at the RNA sequencing. If you were to look at lymphoid cells, you may get a little bit disappointed in the sense of maybe you thought the Ritux should do better. When you actually look specifically at the molecular signatures for B cells, it is actually greater for rituximab responders, but not necessarily with the histology. In other words, histology is great, but it does not supersede the RNA sequencing. The final thing we actually learned from the study, and as we all know clinically, there's a subset of patients, no matter what we do with them, we can't make them better. They're failing all biologics. A very important story here, because you actually look at non-responders. It's right to the very last column there, to your left. These cells are enriched with mesenchymal and fibroblast signatures. Okay, and that's why they're not getting better. They're post-immune. They're actually failing tocilizumab. They're failing rituximab, because these are all responders versus non-responders, which kind of makes sense in terms of we need new therapeutics for these patients. It's also telling us that we probably need to start early before you get these changes. There's other things that you can do other than RNA sequencing. For instance, you can do single-cell sequencing. The single-cell sequencing in the subset showed that there are specific fibroblasts that are not responding well. You can also do something called spatial transcriptomics. You can look at the biopsy, and there's a very interesting sublining in super responders. What they have is TNF-soluble receptors in the sublining of the synovium. If you have that, the TNF antagonists bind, and you get a very good response. So I'm not saying that the transcriptome is the only answer, but in terms of single-cell sequencing and spatial transcriptomics, it's harder in terms of a clinical application, but still quite exciting in terms of how things are developing. It's also telling us, and this is a slide from York Shett, but others have thought about the same thing, and that's the initiating cytokines are different from chronification. You really want to get to the disease early, and at the early stage, molecular phenotyping may actually help as compared to when you get the mesenchymal or fibroblastic changes, it gets a lot harder to turn things around. Finally, it's hard to talk about genomics unless you talk about when to refer to a geneticist. Even for a polygenic disease and even for adult physicians, I think there are times when we need to think about it. That's when we see something that has a family history that happens early, and then all of a sudden, if the manifestation is rare, if it's super early or if it's difficult to treat, think about a monogenic cause, because there are still autoinflammatory sort of endophenotypes that sometimes mimic rheumatoid arthritis. And the reason why things aren't getting better is maybe a cytokine like IL-1 may actually significantly help that patient. You may be able to capture it using the genetic panels or even a whole exome scan. So if something is familial and early, or familial and rare, or familial and it's very difficult to treat, it's worthwhile thinking about that. So in summary, I really think there's a lot of excitement and a lot of exciting research that's being done, but unfortunately nothing is prime time. There's nothing I can tell you that you can take today and do and predictably say that you're going to respond or not respond. What we really need to do is use the multi-omic approach. I think machine analysis is very, very hard. So we really need bioinformaticians to actually help us analyze this and help model it. We also have to think about adding on to, especially for understanding the disease, spatial transcriptomics, as well as patient data and imaging. It just cannot be molecular data. And then hopefully we will lessen this ingenuity gap, or as John Isaac often says in terms of rheumatoid arthritis, this precision gap that actually exists in rheumatoid. And so can we actually help this lady? Not at the present time, but you could have potentially identified an adalimumab responder, and by a biopsy, we can potentially direct them towards tocilizumab versus rituximab, but it's not there at the present time. Part of the reason, and this is my last slide, that it's not there is I think we need community buy-in if we're actually going to do this. So what is it that we need? We need the patients on board, because to do a full exome, for instance, you're going to unmask other genes. Or even, there is insurance-related reasons as you're trying to help someone. You also need infrastructures in terms of informatics. You need buy-in in terms of the hospitals, because these are costly initially, and you need a lab to do it. So unless we have these peripheral things in place, we can't really think about offering this service specifically to our patients. Thank you so much for your time.
Assalamu alaikum wa rahmatullahi wa barakatuh. Now we'll have a dialogue or a debate or an argument between two of our known speakers. The first one is The argument will be about, is old still gold, or is the new JAK inhibitors better than the old biologics? Not really so old biologics, but the biologics in general. So we will have the elder of the two speakers speak first, which is Dr. Hussein Halabi, and he will try to convince us with his point of view. And then later on, we'll have the younger of the two speaking about the older of the biologics. Professor Professor Muhammad Umair. So we will come first, Dr. Hussein Halabi.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد. I'd like to thank the organizing committee, and I'd like to thank them actually for giving me the hard part of this debate. I'm glad you said the older, because old is gold. Is that right? So actually there is no winner or loser in this debate. The only winner is the patient. And we're gonna actually show you the evidence, and only the evidence, in my talk about the usefulness of JAK inhibitors over anti-TNF and maybe other biological DMARDs. So the first question is, do we need a new medication with different mode of action or mechanism of action to treat RA? Well, the short answer is yes, because it's not always successful to achieve low disease activity or remission with current treatment options, and this is what we call it difficult to treat rheumatoid arthritis. We have a problem with drug survival. Patient preferences. Some patients, they prefer oral versus subcut injection or IV. And of course, we have always an issue with availability of the drug and some regulatory constraints that they favor, or they push you actually to use one mode of action before the other. So let's briefly go through this actual definition of difficult to treat. So the EULAR defined difficult to treat rheumatoid arthritis as patients whom have failed at least 2 or more biological or targeted synthetic DMARDs, in addition to conventional synthetic DMARDs who have actually active disease. And actually, several studies have addressed this prevalence, and the prevalence actually in several studies varies between 5 to 10%. So 10% of your patients with rheumatoid arthritis are difficult to treat and already have failed 2 biologic or targeted synthetic DMARDs. This is a systematic review and meta-analysis of drug registries and healthcare database to assess the proportion of RA patients actually who discontinue biologic, and here it's anti-TNF, in a world registries and healthcare databases. And they have actually included more than 200,000 patients. And look here, if your patient, 52% of your patients on anti-TNF, they will actually discontinue the treatment at 4 years. So that means 52% of your patients have failed anti-TNF for whatever reason. So that's why we actually, we are blessed to have more mode of action. So we were happy in 1998 when etanercept was FDA approved. And now actually in 2012, we have the first JAK inhibitors approved by the FDA, and followed by parasitinib and then upadacitinib. And as you're aware that tofacitinib actually targets JAK1 and JAK3, and to a little extent JAK2. Parasitinib target JAK1 and JAK2, and upadacitinib is mainly JAK1 inhibitor. So what is the role of JAK inhibitors in achieving clinical remission? Well, all these clinical trials, no matter what RA patient's profile you have, whether the patient is treatment naive, methotrexate inadequate responders, biologic inadequate responders, or failure, then all these clinical trials actually have shown efficacy, even superiority over anti-TNF alpha. And let me take you to the first study actually, where they compared tofacitinib monotherapy 5 milligram twice daily with methotrexate. And here, no matter what, no matter how early or late your patients with early or established RA, actually 5 milligram twice a day of tofacitinib was equally effective. And that's actually different than what have been published with anti-TNF, especially with very early RA, the response is better than early RA. But actually, tofacitinib here showed that there is no difference and superiority over methotrexate, and that was not actually proven to be that anti-TNF is superior to monotherapy, superior to methotrexate monotherapy. Now let's talk about those patients who have inadequate response to methotrexate, and this is the oral strategy for tofacitinib. Clearly, the primary endpoint was met, where tofacitinib 5 milligram twice a day plus methotrexate versus adalimumab plus methotrexate showed non-inferiority. Okay. Now, in terms of remission, actually there was equal outcome or equal effect between the tofa 5 milligram twice daily plus methotrexate and adalimumab plus methotrexate. When we come to the parasitinib, this is the RA BEAM clinical trial, again in patients with methotrexate inadequate responders. The primary endpoint was achieved, and the predefined endpoints for bari versus adalimumab in terms of ACR20 change and the change in DCR and change in DAS28 CRP at week 12 showed superiority as well. But again, when it comes to remission, bari was equal to adalimumab. The story was a little bit different when they used upadacitinib, and upadacitinib actually plus methotrexate was superior to adalimumab plus methotrexate in all remission outcomes, as you can clearly see here. Do we have a pointer on this one? Huh? في pointer? ما في pointer? طيب يا جماعة, this is very important والله. طيب, the effect of upadacitinib versus anti-TNF was actually extended beyond that, and it shown superiority over abatacept plus methotrexate in those who have no response or inadequate response or intolerant to biological DMARDs. So you can see here that the clinical remission at 12 weeks or at 24 weeks, there is a superiority of upadacitinib plus methotrexate over abatacetinib plus methotrexate. So JAK inhibitors clearly have shown us that use tofa or other JAK inhibitors plus methotrexate at least as equal as anti-TNF, if not superior to it, and to other non-anti-TNF biological DMARDs. Now, what about the effect of patients' reported outcome? Now, remember that what patients care about is pain, and pain drives 80 to 90% of their decision when you ask him how much would you give, how much you rate yourself out of 10. Pain contribute to 80 to 90% of their decision. So, what is the effect of JAK on patient-reported outcome? Clearly, baricitinib, how can I go back? Okay, baricitinib and upadacitinib clearly have shown a significant greater reduction in pain versus adalimumab with methotrexate at 4 weeks and up to 52 weeks. So, what about compliance? Is compliance of patients different between JAK inhibitors because it's an oral agent and other biological therapy? Thank you, Dr. Amer, for this publication. So this publication was done by Dr. Amer, and clearly for 1,300 patients, more than 1,300 patients, clearly there was no difference between JAK inhibitors and biological DMARDs. And at here, I'd like to stop, and I will ask my colleague, Dr. Amer, to come and enlighten us about other biologics, and then I will continue.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I would like to thank the scientific committee for putting me in front of one of our eminent rheumatologists on this topic. قبل ما أبدأ أحب أبارك لجميع مشجعي الهلال والمنتخب السعودي على منجزاتهم. وانا دائما اشوف انه فريق الهلال طبعا يعني ايش يمكن افضل فريق يمثل المملكه. Please remember this at the end of the talk. طيب. Okay, so this is my disclosure. So I have worked with all pharmaceutical companies that produce biologics and small molecules. And I regard Dr. Hussein Halabi as a role model rheumatologist in the region. So I'm gonna go really soft on him. Okay, so this is gonna be my agenda. So because I see Dr. Hussein Halabi as a great rheumatologist, so I thought to embody biologics and small molecules. And clearly, biologics are large molecules and small molecules are small. Biologics have a clear position in treatment algorithm. So Dr. Hussein Halabi has a very clear career path as an academic affairs director for years in King Faisal. I've been roaming around in multiple hospitals. Safety and efficacy were established. He does not have any conflict with anybody. He's a very respected person by everyone. I'm a little bit reckless. This is why you see some safety issues when you work with me. He is very traditional. I'm very innovative. And he has great success with other disease areas while I have an evolving role in other disease areas. Now, he cannot really hide the love because in a large multi-center Arab study, of course, he represented Saudi Arabia with the majority of patients that was led by our colleagues from Qatar. They have exposed or looked at the use of medications in patients with rheumatoid arthritis. And if you can see, the Saudi Arabia bar is the largest, and this is the percentage of patients on biologics compared to other countries. Now, when we talk about adverse events, it's important to differentiate between association and causality. And in JAKs, the adverse events that we're going to talk about have been clearly associated, but there is also a causality, because when you look at the inhibition of the JAK-STAT pathway, which is a really risky game to play with, you have multiple JAK-STAT receptors or JAK receptors or combinations that whenever you block any one of them, you're going to see specific adverse events. So for example, if you block the interferon pathway, you're going to see more of viral infections like herpes zoster. If you look the GM-CSF and erythropoietin pathway, you're going to see more pancytopenia and thromboembolic disease, and vice versa. Now, this is the only study I know in rheumatology where the FDA has mandated a phase 4 study just to look at safety of medications. And this is the oral surveillance study, which has clearly shown the failure of showing non-inferiority in view of development of malignancy or cardiovascular disease and thromboembolic disease. And this has been translated also in registries, where you can see in the Swedish registry an overall increased risk of thromboembolic disease. Here with multiple registries from mainly Europe, but also from the US, showing an increased risk of VTE with baricitinib as a specific drug. And when we talk about compliance, of course, I cannot break down the study we have performed, but you could see here in one of the Canadian studies, the compliance to medications is higher with a biologic with less frequency, namely golimumab and to some extent other ones. Here, another study showing that if you're using an oral medication that's used daily, you have a higher rate of non-adherence of like 30% compared to 10 to 15% of patients. Now, to leave the pill, you must switch the pill. No. So, for example, if you have pregnant ladies or ladies who want to get pregnant, and this contributes to a significant high population in our RA cohorts, these patients cannot use JAKs, so anti-TNFs would be a better choice. Now, biosimilars now are the big savers of money. If you assume that Saudi Arabia's economics is like 20% of the US economics, you're talking about more than 25 billion of savings. And now we have biosimilars of different companies, and the competition is really getting harder and harder. Now, is tofacitinib losing its patent? Yes and no. There are many lawsuits, like what happened with adalimumab. So we don't know where we're going to have the first JAK as a generic. It is true. And I really conclude with my colleague on the superiority data of baricitinib and upadacitinib against adalimumab and even on abatacept. So, are JAKs superior to anti-TNFs and abatacept? Yes, in clinical trials. The ACR guidelines put them in the same position. The EULAR, because it was published after the oral surveillance, gives them cautionary advice when using JAKs, but they're still in a quite similar position. ولكن أبغى أقول حاجة، حتى لو جاكس نتائجهم أفضل، البيولوجي يبقى عميد الأدوية. Thank you.
ما في فرق بين الزعيم والعميد دكتور محمد. Okay. So let me take you through the safety. Thank you for addressing all these issues, and I will answer, and I will try to answer those, concerns in the coming 10 minutes or so. So we're going to talk about herpes zoster infection, MACE, major adverse cardiac events, malignancy, and VTA, and I think these are the questions, or these are the concerns that we all have after the oral surveillance. So in terms of herpes zoster, this is actually a systemic review of all clinical trials and real world studies that included actually 54 studies with tons of patients. And clearly, there is actually an increased risk of herpes zoster with all JAK inhibitors, and the incidence, cumulative incidence between 0 to 7.5%. And in Japanese population, actually, it reached up to 12%. So with all JAK inhibitors, there is an increased risk of herpes zoster, and I cannot argue with that. Now, this is the oral surveillance, and this is what created actually more questions than answers. Now, it's a randomized open label, non-inferiority safety trial to assess the risk of MACE and malignancy for a combined dose of 5 and 10 milligram. And honestly speaking, who cares about 10 milligram twice daily for rheumatoid arthritis? This is not the FDA-approved dose or EMA-approved dose. And that actually, they have compared that with anti-TNF-alpha, and they have included patients who are 50 years of age or older and should have at least one cardiovascular risk factor. Now, this is the interesting part. Now, non-inferiority would be shown if the upper limit of the two-sided 95% confidence interval for the hazard ratio was less than 1.8 for the combined tofacitinib compared with TNF. Now, let's look at here at the incidence. The incidence for combined tofa doses is 3.4% versus 2.5% with TNF inhibitor. Non-inferiority was not met for the combined tofacitinib doses as compared with TNF because the confidence interval actually, the upper boundary of the 95 confidence interval was above 1.8. It was 1.94. Having said that, look at the confidence interval and its relation to the hazard ratio at 1. It actually, it does crosses the other side. So numerically, it's higher. But because they have predefined the non-inferiority to 1.8, the outcome was non-inferiority was not met. Same thing actually with malignancy. And actually one more thing. If you look at the number you need to harm for using 5 milligram twice a day, it's 567, which means you need to treat 567 patients with tofacitinib 5 milligram twice a day to have one MACE event compared to anti-TNF. This is a huge number. This is a huge number of patients. Now, the same thing actually happened with the malignancy. There was actually, the non-inferiority was not met because the upper limit of the 95 confidence interval actually exceeded 1.8. Now, let's look at the other important adverse event. Now, again, herpes zoster clearly showing that there is an increased risk. Now, for VTE, the 5 milligram twice daily did not show any risk, but the 10 milligram did. And we don't use 10 milligram twice a day in patients with rheumatoid arthritis. Also, in terms of comparing the phase 3 and 4 clinical trials with the oral surveillance in terms of the patients with history of cardiovascular disease or patients with high-risk cardiac disease, you can see that in the phase 3, 4, and long-term extension, the total number or the percentage of patients with history of cardiovascular disease and those with high risk accounts for maximum 10 to 11%, versus almost 30% in the oral surveillance study. So 1/3 of the patients in the oral surveillance already have a history of cardiovascular disease or a high-risk population. And this is actually a post-hoc analysis from the oral surveillance when they segregated patients whether they have history of cardiovascular disease and those with no history of cardiovascular disease. This is the overall surveillance on the extreme left side of this frame here. The incidence rate of 0.9 for the TOFA versus 0.73 for the anti-TNF. And actually, for those who have no history of cardiovascular disease, there was no difference between TOFA 5 milligram and anti-TNF. However, in patients with history of atherosclerotic cardiovascular disease, the risk is increased. That means you have to select your patients based on their cardiovascular risk stratification. Another study that was actually conducted earlier comparing tocilizumab versus etanercept in terms of major cardiac event. And this is a copy-paste of the oral surveillance. It's very interesting to see that the incident rate of MACE in the etanercept group is 1.7, and this is even higher than the incidence rate in the oral surveillance, which was 0.7. In fact, it's even higher than the incidence rate of MACE in patients who were on combined tofacitinib drugs. Another actually large safety data is the STAR-RA study, where they have included 2 cohorts of patients with RA. The first cohort include patients with real-world evidence, and the second cohort is actually a duplicate of the oral surveillance study. And they have included over 100,000 patients. 12,000 of those, they were on TOFA. And they look at MACE and major and malignancy. Again, in the real-world evidence, there was no increased risk of major cardiac event. Looking at a 5-year long-term extension or 5-year data from the paracetamol, there was no increased risk of malignancy, MACE, DVT, PE. However, herpes zoster was clearly higher in the pari group. And this actually just published a few days ago, looking at 5 years data from the upadacitinib. And again, there was no signal for increasing MACE, DVT, or malignancy, but there was an increased risk of herpes zoster because the confidence interval actually do overlap in the herpes zoster group. What about DVT or venous thromboembolism? This is the Swedish registry, and they looked actually at the cumulative incidence rate among patients who were on several biological treatment versus overall RA cohort. and general population, and clearly there is an increased VTE risk with the JAK inhibitors compared to the rest of biologic, including anti-TNF and non-anti-TNF. What about drug retention? This is the Swiss registry. And here they have looked at drug retention based on the mode of action. So TNF and non-TNF biologic and the tofacitinib. I just want to get your attention to the red circle here, comparing TNF with tofacitinib. If you look at the number of patients who have failed 2 or 3 biological DMARDs, clearly you can see that 53% or 52% of patients in the TOFA have previously failed 2 or 3 biological DMARDs versus only 20% of the patient in the anti-TNF group. And if you look at the overall drug discontinuation, the highest discontinuation rate was in the anti-TNF in red, and the lowest overall discontinuation is with TOFA with the black curve over there. And if you look at drug discontinuation due to ineffectiveness, again, TOFA was the lowest in terms of discontinuation, and anti-TNF were higher or the highest among the rest. And no matter what, whether you combine anti-TNF or you don't combine them, they are the lowest or the highest in terms of discontinuation rate, and JAK inhibitors were the lowest in terms of discontinuation rate. Other important benefits of JAK inhibitors, they have a very short half-life, very rapid, and efficacy actually can start as early as 2 to 4 weeks. It's oral administration. People, they have problems with injectable medications, and no immunogenicity as has been demonstrated in several studies with use of anti-TNF alpha. So in summary, due to treatment failure and difficult to treat RA, there is a continuous need for more treatment options with different mechanisms of actions. And JAK inhibitors are excellent and effective alternative choice to existing biological DMARDs with better retention rate. Despite the confirmed efficacy of JAK inhibitors and potential superiority over several biological DMARDs, we have to admit that there are red flags concerning safety, and that is mainly with herpes zoster and to a little bit extent with DVT. So patient risk stratification should take place prior to initiating such therapy. Now, the oral surveillance study reflects only comparison of TNF inhibitors relative to JAK inhibitors in a very specific population of patients with RA with high cardiac risk factors. And that both treatment might be protective against many of the outcomes under study if compared with no therapy or with non-biological DMARDs or even other biological DMARDs. And finally, if you look at this picture, putting the red color in the middle will make you focus on that paint and forget all about the rest of the paint. And this is exactly what's happening with the JAK inhibitors. We are looking at the oral surveillance and forgetting all about the good thing about JAK inhibitors. Thank you very much for your attention.
تسمعون صوتي. نشكر الدكتور حسين والبروف محمد. Please come and join us. طبعا أنت تدعي الظلم على جاك، تقول هذا الخط الأحمر هذا إلى آخره، هي إشارة حمراء، وقف عندها دائما حتى في المرور ولا يعاقبونك ب5000. نريد الدكتور محمد الحين بروف محمد defend his case before we receive questions. Defend.
What is the question? Sorry, we didn't hear you.
We need Prof. Muhammad Umar to defend his argument that all this gold. Why is he still believing that anti-TNF is the one to have first?
Well, in our hospital, we introduce new medications on refractory patients. So when you get one of the JAKs or one of the biologics, you have to have failed all of the medication in our hospital. So the major experience, of course, with biologics, but really JAKs are important additional tools in controlling the disease in our patients. Now, the EULAR, after the oral surveillance, have given cautionary advices on risk stratification prior to JAK use, but I think that it's a very complex process in which medication we choose in our patients. So some patients, Dr. Hussein mentioned, are afraid of needles, and you might go with a JAK. Some patients have comorbidities that will drive you away from the JAKs. But I think one of the things that maybe will reduce the use of JAK is the increasing elderly patients who are in our cohorts who have multiple risk factors, especially cardiovascular and herpes zoster. Maybe with the shingles vaccine, these things might be more controllable over time.
Listen, let's do something. Like after listening to this amazing debate, let's see what the audience thinks. So if you are on the side of Dr. Mohammed Umair, please raise your hand. If you are on the side of Dr. Hussein Halabi, raise your hand. 50-50, ها؟
لا، بعض الناس صوتوا يمين وصوتوا يسار وناس قاعدين على الجدار. Anyway, what we are trying to
and I think first of all, thank you Dr. Umair for sharing with me this beautiful session. I really admire your slides. I liked it. I think at the end we are all physicians, and what we care about is our patient safety. I'm one of the people who use anti-TNF alpha as a first choice. Okay, I use anti-TNF alpha as a first choice. But if it's my second choice, I would definitely go with JAK inhibitors, providing that I do risk stratifying my patients for cardiovascular events and for the risk of DVT. So I think it's very important to share the decision with your patients as well, because you have to explain to your patients the pros and cons of having this over one drug over the other. Thank you.
Can we have the opinion of Professor Rahman?
Thank you. I totally agree that it's great having choice. I think all drugs have a place because we don't quite understand the exact mechanism for a given patient. And it's also nice having a choice for a drug that is pleiotropic in the sense of the ability to inhibit multiple cytokine pathways. So sometimes when we're lost, I would pull out a JAK inhibition, particularly a pan-JAK, and to my surprise, this worked really wonderfully. But if I have a good sense that this is just the classic rheumatoid, very much like others, I would go with an anti-TNF first.
Any questions in general?
Professor Suzanne, please.
Just have a quick comment. أنا لا رفعت يدي لا معاك ولا معاك. وقبل ما الدكتور حسين يقول الجملة, I said I'm with the patient. It's a patient shared decision. If the RA, let's say a patient or any patient with immunological disorder, rheumatological, refuse to take any of the biologic, for example, for a needle phobia reason, I would go ahead with a JAK, and I would still risk stratify the patient into mild, moderate, and severe and decide. So it's a patient shared decision. There's no right answer. That's me. Thank you.
Any more questions? Yes.
Yes. Can I speak? Thanks for both speakers for the excellent debate. We enjoyed it actually too much.
Can I say something?
Yeah.
The quality of sound is not good. It resonates all over. So I'm saying like this. Anyway,
Carry on.
Do your best.
Is that better? Okay, thanks for both speakers for the excellent debate. We enjoyed it too much. Congratulations, Professor Omer, for your new chair. My question is about those at risk, the 65 years and above, are risk for everything, including sepsis. And you're trying to scare us from the risk of MACE and malignancy. But the same thing, one of the biggest mortality and morbidity in rheumatoid is sepsis, and anti-TNF are not necessarily better, and at times might be even worse, because if you give somebody a golimumab and got sepsis, then you have to wait a long time and they might die from it. Like if you got a JAK, you kind of stop it next day and that's done. So are we just focusing on that red wire and forgetting about the other risk factors, which we need always and also to stratify and probably get worried about?
So is your question the risk of sepsis with the use of JAK inhibitors, is that right?
Anti-TNF might be worse.
And anti-TNF?
Might be worse.
Might be worse.
Yeah.
Well, let me tell you, from a couple of safety trials, there was definitely an increased risk of sepsis and major infection rate because they have included also the risk of herpes zoster in those population. Now, statistically, there was no difference between adalimumab versus tofacitinib, and same thing actually with upadacitinib and adalimumab. So the risk is there, but it's not actually increased with one mode of action over the other.
Yes, Prof. Muhammad, please.
So one important point is that we look at data to really make the best decision possible. But at the end, till we have personalized medicine, you're always in a chance or risk of drug failure or development for adverse events. Now, there is also an important point is informing the patients about the risk and the medico-legal aspect. So I have a patient who actually had 2 times herpes zoster. One of them is facial, okay, in the trigeminal distribution, and she's on her second JAK. But unfortunately, this lady has failed every single medication. She has a lot of deformities. So she's accepting the risk and of using the JAKs. Of course, she got her vaccine. So I think one of the aspects that are important is really informing the patient, engaging the patient into the decision, because if the patient develops, for example, herpes zoster or pulmonary embolism, and then he Googles it and he will say, oh, you gave me a medication that will cause a thrombus, and you have other options that have not been associated with the increase of thrombus, because RA itself is associated with increased risk of thrombus. I think there are many aspects that need to be taken with cautious, not only the availability of data, because at the end you try to personalize your medication with the patient as much as you can.
Can I ask a final question to Prof. Rahman? Are you Abdurrahman anyway? Is there any recent or upcoming research into this area? Which one, basically, which may help simplify the choice between those 2 JAKs and the other biologics? Yani anything to say, go left or go right, similar to your example of rituximab and tocilizumab in that patient who failed the first one?
Yeah, so JAKs, because they're pleiotropic and they're inhibiting multiple cytokines, are actually somewhat harder to study. So I know for psoriatic arthritis, when I look at it, it is just not as easy to identify a response versus non-response, because so many things are changing at once. And so I've found that the cytokines that are upstream, so for instance, if the TNF or an effector cytokine, the IL-17s, give you a cleaner signature in terms of response versus non-response. because it's a little bit more specific in terms of what it actually targets. The more cytokines that a particular molecule can target, the more noise that you actually have in trying to decipher or deconvolute the signature.
السلام عليكم. نشكر الحضور والمتكلمين. We'd like to thank the audience and the speakers for their participation in this session, and we adjourn both for the next session and for Salat. Thank you.
Thank you very much.
شكرا بروف عبد الرحمن العرفج. استاذنكم في البقاء على المنصة. Please stay on stage for the arts. الدكتورة حنان ستكرم في البداية البروفيسور عبد الرحمن العرفج. بروفيسور عبد الرحمن أبو محمد. بروفيسور عبد الرحمن، إذا تكرمت بس العودة إلى المنصة من أجل التكريم. ثم الدكتورة أديبة. الدكتور حسين حلبي. والدكتور محمد عمير. And thank you, Dr. Brot الرحمن. صورة جماعية. قبل أن ننتقل مباشرة إلى الجلسة التالية، هناك كلمة للدكتور إبراهيم المغلوث. دكتور إبراهيم المغلوث. Yeah. طيب. اوكي. تمام. السادة والسيدات، نجدد الترحيب بكم في المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم، مباشرة إلى الجلسة الرابعة في يومنا الأول من المؤتمر. يرأس هذه الجلسة كل من الدكتورة سلطانة بنت عبد العزيز والدكتور عبد العزيز الخلف. ادعوهم إلى المنصة لبداية الجلسة.
Good afternoon, everybody. The next session is very interesting, which is lung manifestations in rheumatic disease. Our first speaker is Dr. Mohammed Al-Ghamdi. He's a consultant pulmonologist from King Fahd Medical City.
Is Dr. Mohammed here?
Welcome, Dr. Mohammed.
الأخضر يقدم. السلام عليكم. يعطيكم العافية جميعا. I'm pleased to be with everyone and thank you for the invitation.
Muhammad, we are vaccinated all. You feel comfortable?
Yeah.
عشان المايك.
You will hear me, don't worry about that. So can I just have the presentation there?
The IT, please.
Yeah.
Okay, so our main objective is to give a brief overview of the rheumatoid arthritis interstitial lung disease and its management. I just want to give you some statistics about the connective tissue disease ILD in the kingdom. We are lucky to be the referral center for the MOH when it comes to ILD at King Fahd Medical City. 2/3 of our patients comes from outside Riyadh, and they are actually coming from all the regions and all the provinces. So I would fairly say that our cohort is representative of what's happening in the kingdom. Connective tissue disease ILD account for 25% of the cohort of ILD patients in our clinic, followed closely by IPF at 20%. When we look at the CTD ILD, rheumatoid arthritis account for 47%, scleroderma 22%, and Sjogren at 14%, then the others, of course. We have 60 patients. 2/3 of them are female. The mean age is 53. Most of the patients are on anti-inflammatory medications or immunosuppressive medications, with 10% of them are also on anti-fibrotic medications. 22% of the patients are receiving oxygen at rest, and 10% of the patients are already following King Faisal Specialty Hospital for lung transplant assessment. In the literature, the usual causes for or subtypes of RA-ILD are the UIP, the NSIP, and organizing pneumonia, and the same applies to our clinic. NSIP is 41%, UIP 37%, and organizing pneumonia at 15%. The RA-ILD can be classified also into a fibrotic type and a non-fibrotic type, and what we mean by fibrosis is that there is fibrotic changes on the CT scan, namely the honeycomb changes, reticulations, and traction bronchiectasis that accounts for at least 10% of the lung field on the CT scan. These fibrotic changes can be progressive, meaning that they are getting worse over time in either the physiologic parameters, so the FVC is decreasing more than 5% over time, the DLCO is decreasing more than 10% over time, or there is increase in the symptoms, so the symptoms are getting worse, namely shortness of breath and cough, or the radiological changes, the extent of fibrosis is actually progressing. The other type of fibrotic disease is the non-progressive type that stabilizes over time. When we look at the estimated proportions of patients with rheumatoid arthritis ILD that manifest progressive pulmonary fibrosis, they are close to 40%. And it is actually the second highest among the CTD-ILD, right after the scleroderma, where the progressive pulmonary fibrosis goes up to 50%. The progressive pulmonary fibrosis concept is very important. The disease or the syndrome itself manifests like IBF in terms of the prognosis. So these patients actually they don't do very well. Similar to IBF, the survival is reduced, the prognosis is poor, the burden of the disease is high, the disability is common, etc. And there is also a therapeutic implication, and that's the reason why I gave you the short overview. In the INBUILD trial, 600 patients with progressive pulmonary fibrosis were randomized to receive either placebo or nintedanib, and they were followed over a 52 weeks period. When we look at the arm that received nintedanib, the rate of decline in FVC was reduced by a relative reduction of 57%. So the patients who were on nintedanib only lost around 80 ml in their FVC, while the patients who were on placebo lost nearly 200 ml during the study period. So there was a significant reduction in the rate of decline in FVC among the patients who were on nintedanib treatment, and that's why in the latest American Thoracic Society guidelines in 2022, they recommended the use of nintedanib in such patients. When we look at the INBUILD cohort, it was consisted of patients with different subtypes of ILD. The CTD-ILD patients comprised 25% of the cohort, and nearly 13% of the cohort were related to rheumatoid arthritis ILD. So the result of this study is applicable to RA-ILD patients. Tikaya looked at the predictive factors for developing RA-ILD in patients with RA. I think we all know about it already. So smoking, positive anti-CCP, and high disease severity score are all important factors, especially smoking. In a systematic review reported by Frazili, he looked into the risk factors that are common in the published trials, and the most common ones were age, male sex, duration of disease, and positive anti-CCP. The management of RA-ILD is complex, and it requires a multidisciplinary approach, as we all know. Education is important, both to the patients and their families. Smoking cessation is key. Drug therapy, and we will discuss that in more details. Pulmonary rehabilitation is important for the rehabable patients. Surveillance and management of comorbidities is also important. In ILD patients, gastroesophageal reflux disease is common. Pulmonary hypertension is also common. The same applies to OSA, pulmonary hypertension, pneumonia, and cardiovascular disease. The vaccination status update is key. Infection is one of the worst outcomes or the worst comorbidities that may occur in RA-ILD patients, and determines the prognosis over time. Unfortunately, we are not doing very well when it comes to vaccination, and if we do not do it in our clinic, no one else will do it. So RA patients are compromised or immune compromised. What we do for them is we give them BCV13, and after 2 to 12 months, we give them PPSV23, that's to cover them against the bacterial pneumonia. We advocate for influenza vaccine on an annual basis, and we actually give it in our clinic. And we also recommend giving the COVID vaccination according to the MOH recommendation. Oxygen therapy is important whenever it is indicated, and lung transplantation referral is important. In my cohort, I have 10% of the patients with CTD-ILD that are already following King Faisal Specialty Hospital. The criteria to refer is easy. So if your patient has pulmonary hypertension and echo, it is time to refer the patient. If the patient is on oxygen, it is time to refer the patient to a transplant facility. The same applies to the patients who have significant reduction in their FVC. So the FVC is less than 50%. The DLCO is less than 40%. Palliative care is also indicated for the patients who require management for their disabling symptoms or who require hospice care when we think that they are not going to live for more than 3 to 6 months. So the first part of the management of RA-ILD applies to the patient who are coming with an acute to subacute presentation. We need to rule out extra parenchymal causes like effusions, pulmonary embolism, and pneumothorax, and then we need to also rule out heart failure and fluid overload. Once that has already been ruled out, we look at the X-ray or CT scan. We expect to see bilateral lung infiltrate in patients with RA-ILD, and at that point we have 4 main differential. Drug-induced pneumonitis is one of them, especially when there is like a recent or relatively recent methotrexate or leflunomide. In the CT scan or the X-ray, there is non-specific ground glass opacities bilaterally. Doesn't usually follow any specific pattern. In some cases, there is a picture of hypersensitivity pneumonitis radiologically. And again, what we do here is easy. We just stop the offending agent and watch the patient for recovery, as most of them do. Some patients with moderate to severe disease would require a short course of steroid treatment. The other differential include rheumatoid arthritis organizing pneumonia. Here there is bilateral, migratory, and peripheral opacities. These patients mostly will require a low to medium dose steroids, so something like 0.5 milligram per kg usually will be enough. Few patients will recover spontaneously without any specific treatment. Infection is important to cover, so we need to cover these patients empirically for community-acquired pneumonia, and we also cover for BJB. The fourth possibility there is acute exacerbation ILD. Under the microscope, the pattern is diffuse alveolar damage, where we see hyaline membrane. These patients do not usually get biopsied, as the mortality when we do biopsy for these patients with acute exacerbation is high, approaching 15% and even more. On the CT scan, what we see is bilateral ground glass opacities and consolidation in the dependent region of the lung, so the lower parts of the lung bilaterally. We do everything for these patients. We discontinue the offending agent, if any. We give high-dose steroid initially. We give empiric antibiotics, including covering for BJB. And this is the most feared, I would say, differential when it comes to the acute and subacute presentation. The mortality rate unfortunately goes up to 50%, which is not very different from the patients with acute exacerbation IPF. The incidence of acute exacerbation, RA-ILD, is around 20%. And as I mentioned before, the mortality is up to 50%. In one observational trial, they looked at the predictors of bad and good outcome in patients with acute exacerbation ILD, and they found that having a UIP pattern on the CT scan was associated with death, while being on methotrexate was protective. So if the patient was on methotrexate at the time of exacerbation, you would probably expect a better outcome based on this observational trial. I will just review recent literature about methotrexate used in ILD. It's controversial, as we all know. So in the European Respiratory Journal, almost 2 years ago now, a case control study designed to examine the association of methotrexate exposure with ILD was conducted. They had cases, like around 400 patients, and a control group. And they found that there was an inverse relationship between methotrexate exposure and the development of the RA-ILD. So the being exposed to methotrexate was actually protective. The other thing that they found was that the incidence of RA-ILD when it happens was delayed significantly in the patient that received methotrexate. So 11%. 11 years in the patient who received methotrexate versus 4 years in the patient who did not receive methotrexate. All in favor of methotrexate. In this nationwide population-based RA cohort in Denmark, a total number of patients of 30,000 were analyzed. And the authors found no increased risk for ILD or respiratory failure. This is the other part of the management. Here we are talking about the chronic presentation of patients with the RA-ILD. So the symptoms here are more of a chronic, lingering for like several months. If you believe that this diagram is complex, it is modified from a more complex diagram by Yamakawa. So I tried my best to make it a bit simple. The first thing that we look at is whether the arthritis is active or not active, as the key thing to do for these patients to improve the outcome is to control the arthritis itself. So the first thing we ask ourselves is if the arthritis is active, is the ILD itself is subclinical or clinical? Subclinical means that the disease itself is causing mild symptoms or zero symptoms, and the BFT changes are either mild or doesn't exist. If that is the case, we continue in our conventional treatment, so either conventional synthetic DMARD or biologic DMARD. We avoid leflunomide, and the reason behind that is that in studies they found that being on having pre-existing ILD was the most important factor in leflunomide-induced pneumonitis. So we don't advocate for leflunomide in patients with RA-ILD, even if the RA-ILD is subclinical. The other thing that we have to exert extreme caution with is TNF-alpha. So if you can avoid it, better to avoid it. If you have a stressing need for it, you would have to use it with extreme caution. The reason behind that is there was a recent report that showed increased mortality among patients with RA-ILD who were kept on TNF-alpha. If the ILD is clinical, so it is apparent, it's not just a mild disease, it's moderate to severe in the radiology or on the BFT or symptomatically, then you would use again your conventional synthetic DMARD or biologic targeted synthetic DMARD, but with a caveat. So we would suggest not to use methotrexate at this stage, and to use either rituximab or abatacept. Second to that will be the JAK inhibitor. Tocilizumab is less preferred because of the increased aggravation of the disease or exacerbation in patients with tocilizumab. It is still effective, it's a good option, but I would say that it is the fourth agent to pick, and I would prioritize the first three agents, rituximab, abatacept, followed by JAK inhibitor. If the arthritis is not active, then we would look into the lung disease itself, and we would assess the disease with help from our radiology and pulmonary side. If the disease is not showing any progression over time, then we can actually continue on whatever treatment we are giving to our patient with monitoring Q3 to 6 months, mainly with BFT, so FVC and DLCO. If the ILD is progressing over time, we usually take the case to the multidisciplinary discussion round alongside the radiologist and the pulmonologist, and we try to decide if the disease, the ILD itself, is mainly inflammatory or mainly fibrotic. If it is mainly fibrotic, we add nintedanib. We have proof that it works, and this will be consistent with the guidelines made by the American Thoracic Society and the European Respiratory Society. If the disease is mainly inflammatory, then we need to suppress that inflammation. And we have lots of options here. We can do the short-term high-dose corticosteroid followed by a low-dose maintenance corticosteroid. The other option is to add or switch to another DMARD. If we chose to do the short-term high-dose corticosteroid followed by a low-dose corticosteroid, adding the tacrolimus during the maintenance phase has been shown in one study to be efficacious. The other options are, for this specific indication, are the MMF and AZA, cyclophosphamide. Unfortunately, the agents like MMF and AZA are not very good or great when it comes to the arthritis, so we don't commonly use them. On treatment evolution has been evaluated by multiple authors. So we are going to review the main agents here. This is basically how the disease progressed, the RA-ILD over time. So for rituximab, in this one study by Tikaya in 2022, he found that 30% of the patient remained stable. Their RA-ILD was stable throughout the course of follow-up. 10% has worsening of their disease, and improvement was noticed in 35%, which is quite good. For tocilizumab, 33% of the patient had worsening of their RA-ILD while on treatment, and 17% of the patient had improvement. For TNF, 73% of the patient had worsening of their disease over time, while only 7% had improvement, and that's why we don't like to use TNF inhibitor in patients with RA-ILD. Among the conventional synthetic DMARDs, methotrexate showed sustainability in 26% of the patient, worsening of the disease in 16%, and improvement in 29%, and this is a good result and something that we would like to see in our patients. JAK inhibitors was evaluated by Venerito in 2023, a very recent study. His cohort was a group of patients from Italy recruited between the period of 2018 to 2022 in June. He looked at the FVC change over time, the DLCO change in the middle diagram over time, and the high-resolution CT scan change over time. And they found that the majority of the patient, more than 2/3 of the patient, has actually stabilized while on JAK inhibitor. Few patients either improved or worsened. Tardella also published a recent study last year looking into abatacept and the evolution of RA-ILD over time. And they found similar result to JAK inhibitor, except that the number of patients, or the proportion of patients with improvement was higher, and the number of patients with worsening was less. The stability was the same. 2/3 of the patients stabilized on the treatment. So basically, progression of RA in 11%, stabilization in 72%, and RA-ILD improvement in 16% of the patient.
Dr. Mohammed, you have 2 minutes, please.
Yeah. The current smoking habit and the concomitant methotrexate treatment were the two variables related to RA-ILD progression in multivariate regression analysis. I will just use the last 2 minutes describing the risk prediction model that was developed by Kim in 2020. They found 4 variables that help us to predict the prognosis of the RA-ILD and facilitate our discussion to the patients. The variables are age above 60, fibrosis score more than 20, UIP pattern, and emphysema. They developed a point system based on these 4 variables, and based on that, you will classify your patient into either stage 1, stage 2, or stage 3. And what this study found is that the predicted 1-year mortality for stage 1, 2, and 3 were 0, 5, and 24%. And they actually tested their prediction model in their derivation cohort and validation cohort, and their assumption or prediction stood true in both the derivation and the validation cohort. To my knowledge, this is the only risk model that is designed specifically to the RA-ILD patient. You can also use the risk prediction model that is used in IPF, and Normi and other investigators have found that the usual risk models that we use in patients with IPF are still applicable to patients with RA-ILD. The easiest one to use is the GAP. So the GAP has gender, age, and physiologic variable, FVC and DLCO. If we take an example, and that's going to be the last thing to discuss. This is one of my patients. His gender is male. His age is above 65. His FVC is less than 50. And his DLCO is between 36 to 55. These are the only 4 parameters that you need to enter to the system. And when you look at the 1-year mortality is 40% here, and the 3-year mortality is 76%. When the patients with the RA-ILD die, they usually die because of progression of their ILD. Second to that, will be, it will be the acute exacerbation ILD. This is the most common cause of death among patients with RA ILD. Next to that will be the chronic progression, then the pneumonia and lung cancer. And when you look at the pneumonia in the patients with IPF as a cause of death, it is up to 12%, while in patients with RA ILD, it goes up to 20%. That's because of the rheumatoid arthritis itself being immunocompromised. Is also another reason why pneumonia is high. That's why vaccination, as we mentioned before, is very important to take care of, and thank you very much.
Thank you, Dr. Mohammed.
Thank you, Dr. Mohammed. So our next speaker is Dr. Rajaji Namas. He's an associate professor from Michigan University, rheumatology consultant in Cleveland, Abu Dhabi, presenting about systemic sclerosis and ILD. Thank you.
Thank you, Chairman. Assalamu alaikum. Thanks for this invitation. This is my second year at the Saudi Rheumatology Conference. It really gives me truly the honor to be a speaker in this conference. As Dr. Umair tells me, marra mabsoot. Okay, so today I'll be talking about systemic sclerosis associated ILD. I know it's the end of the day, so I'll be a little bit fast. I have no financial disclosures. So today's agenda, I'll be sharing with you a case scenario. We'll be talking about risk stratification. I'm sure all of us, we know the management of how to treat, or what are the available medications to treat systemic sclerosis ILD. But the main question that we are challenged always with during clinics is whom to treat, when to stop. I think these are the main three questions that we face during our daily practice. I'll just share with you over the years, how do I read PFT. I think this should be part of our practice, especially residents and fellows with interest in rheumatology. They should have a look at the PFT each time they see patients with scleroderma. We'll elaborate more about who to treat for systemic sclerosis. I'll share with you some local data, and then we'll end up with what the recommended therapies. And we had a recent publication about consensus recommendations of scleroderma ILD. So this is a 36 years old Middle Eastern lady, presented to the clinic end of the day with a couple of months history of shortness of breath, coughing. She used an albuterol inhaler, not doing well. She had joint pain and puffiness of the digits since the age of 32. And for fellows, this should be documented in the history, because this is the duration that you count, the duration of the disease. I mean, when we ask about, is it early or late, I think this is the number that tell you exactly how long the disease is there. She had Raynaud's phenomenon, it was triphasic, and she had a positive ANA with nucleolar pathogen. She had a modified Rodnan skin score of 16, and she had abnormal nail fold capillaroscopy. She was on hydroxychloroquine, and I did the chest x-ray and an echo, and they were unremarkable. So seeing such a patient, I think the first thing to do is you need to stratify this patient. Is where are we? Should I proceed to the next step and do a high resolution CT or stop there? So these are a couple of red flags that you need to look into when stratifying such a patient. Is it a male or a female? We know that males have a higher risk of developing ILD. Older age is another risk that patients can have an earlier disease or a more aggressive ILD. I think we are fortunate with scleroderma that we have a lot of tools that we can stratify patients. And for a fact, we know that up to 50% with patients with diffuse cutaneous systemic sclerosis are at a risk of developing ILD versus 35% in patients with limited cutaneous systemic sclerosis. Disease duration is very important. I think this is one of the main important question that you need to ask during the history. Is it an early disease? Is it less than 5 years or more than 5 years? And we know that patients with less than 5 years are at a higher risk of developing ILD. And of course, the modified Rodnan skin score is a surrogate of internal organ involvement. The higher the skin score, the more chances that there will be either lung or a heart involvement. Serologies, we know that nucleolar pathogen is more seen in diffuse versus centromere more seen in limited. We know that patients with SCL70 are more prone developing lung disease, lung predominant disease versus anti-centromere antibody are more predominant heart disease. We know that UR3 RMP are more prone of developing a kind of cancer, so you should risk and stratify those patients according to their age for an underlying malignancy and, of course, renal cell crisis. And PFT, we'll talk about it in the next slide. And, of course, we know that the majority of patients with scleroderma have an NSIP pathogen, about 70%. Even having said that, UIP pathogen can be present in patients with systemic sclerosis, and I don't want to indulge too much in echo. I think this is a different talk. If we rely only on history, I think we'll miss most of our patients. Most of the signs that you see in a history are non-specific, such as fatigue, weight loss, shortness of breath. And if we just rely on physical exam also, we need to examine lungs very specifically, looking for valcro basilar crackles. Having said that, I think every patient with systemic sclerosis needs to have a high-resolution CT at during the initial evaluation to rule out an underlying subclinical, what we call subclinical ILD. And as I mentioned, about 78% of the patients can have an NSIP pathogen, and a small proportion can have a UIP pathogen. This is a very important graph that it's like a map where you can stratify patients during the course of their disease. And again, the disease starts from the first non-Raynaud's phenomena. Patients, if you see patients less than 5 years, I mean, you should be highly alerted that they may have an underlying occult or subclinical ILD, even though it will be missed by clinical history or exam. So you do a CT, and you got a couple of scenarios, and the question here arises: who do you treat? Do you treat the first one with mild disease? Do you treat the second CT? Do you treat the third? And I think this is one of the challenges I think we face when seeing such patients. Currently we have a good number of FDA approved and non-FDA approved medications, but still we are challenged. What's the best approach? When do we treat? Do we wait? Or do we just go ahead with starting a medication? And if we look here, if we CT every patient with scleroderma, about 70% of patients will have a type of an ILD. And the question comes again: do you treat everybody with ILD or not? And if we, in the room here, if we present a case, I think we will split into maybe 4 or 5 groups. Some of us will say wait, some of us will say treat. So I think we don't have strict guidelines on when to treat or when to initiate therapies. I think this is very important, so I want to just take a couple of minutes on how to interpret a PFT. Over the years, I think it became part of my practice. I think the first question is it an acceptable? I think you need to look into the height, weight, all these baseline characteristics, if they're smokers or not, and the race and gender is very important. I think the other most important point, if you inherit a patient from another institution, you need to make sure that the machines are similar or different, because you can see a variability in interpretation of a PFT. The second question you need to look into the spirometry and the gas exchange. The first part is the spirometry. If the FEV1 over FVC ratio is low, you are 100% sure that this is more an obstructive airway disease. You're more talking about asthma. And if it's normal or high, then here we're talking more about a restrictive lung disease. The next step to further stratify patients, you look at the predicted forced vital capacity. If it's less than 80, then you can stratify patients to mild, moderate, and severe. The next step that I look into is the DLCO, which is the gas exchange. If it's normal, you're talking about a non-pulmonary etiology, and if it's low, then you are talking more about pulmonary vascular disease. So I think this is just an ABC on how to quickly just, in our busy clinics, just to have a look at, interpret a PFT. I think this is a very important point. If you see a very low DLCO and a nearly normal forced vital capacity, predicted forced vital capacity, this makes you more think that maybe there's an underlying pulmonary arterial hypertension, and there's this calculation that you can divide FVC over DLCO. If it's more than 1.5, then also this gives you an indication that you may need to proceed with having an echo. Who should we treat? I think these are the things, the points that are important. If there's an FVC decline of more than 10% in 12 months, if there's a 5 to 9%, I don't memorize them. I think it's good to put them in front of you. But I think the most important one is in the box. And if you compare a PFT, if you do a PFT today and after 3 months you compare, you need to take into account the acceptable test variability. And if you look at FVC, you can see a variability up to 10%, whereas the DLCO, it goes up to 15%. So if you see that 10%, it doesn't mean that there's a major change in FVC or up to 15% in DLCO. A very old study, but it's a very crucial study that we learned a lot from. It was in '94, and the most, or what we call the window of opportunity. So this, when you apply the concept that we know from RA and other diseases and scleroderma, I think this is one of the lessons we learned, that the first 4 years of diagnosing a patient with systemic sclerosis from the first non-Raynaud's phenomena are the first 4 years. And those 4 years you should be cautious and be more aggressive with screening for ILD. If you pass those 4 years, the risk is still there, but it's not as common as the first 4 years. This is another way of stratification. I think this needs the help of pulmonary radiology colleagues, and then you can stratify according to the involvement, lung involvement on a high resolution CT, if it's less than 20%, more than 20%, and 10 to 20, and this tells you how often you need to repeat the pulmonary function test. So we go back to our case, as shown here. This is her nail fold capillaroscopy. You see dilated nail folds. There's some microhemorrhages. There's hemosiderin. And we did a CT, high resolution CT, and as you can see here, there's a ground glass opacity with dilated esophagus. So she had confirmed systemic sclerosis ILD. Let me share with you this. I think I presented this last year in the 8th SSRC, and at that time it was still under, we were working on publishing it, and it's honestly a piece of art that among all rheumatologists in the UAE, we worked together to publish this paper. And for the first time, we looked at the prevalence of ILD, and it's about 3.37 per 100,000. And patients with pulmonary hypertension at ILD was 1.2 among patients whom are from the UAE. I mean, we have the whole registry, and in my clinic, I see more than 100 patients with systemic sclerosis. What are the recommended therapies? I know all of us, we know just we'll briefly go over each one. The only FDA-approved medications were OFIV and nintedanib, which I think we have the next session. They will talk more about it, and we have recently tocilizumab. So this was a landmark study. This was a proof of concept study that was done in 2006, and they used IV cyclophosphamide. They gave 6 sessions versus placebo, and then after 6 months they switched all patients to AZA, and there was a modest improvement in the FVC over a 6 months period. And I think this was a very interesting study that made authors go further and look into this further. This is the SLS1, where they gave patients oral cyclophosphamide, 1 to 2 milligrams per kilograms per day for 12 months with a follow-up period versus placebo, I think what was standard of care at that time. And interestingly, it was a positive study. The primary endpoint was at 12 months, and as you can see here, there's a split in the curve. There was a significant change in the FVC over a 12 months period, and this was maintained up to 18 months, but then the benefit collapsed, and this was something that was depressing. And you can, I'm sure with cyclophosphamide, we are always concerned about the side effect profile of the medication. So we'll go historically. The second drug that they looked into was azathioprine versus oral cyclophosphamide. It was a negative study. Patients whom were commenced on cyclophosphamide did better than patients whom were on azathioprine, and this was, I think it's not one of the medications that we give for ILD. We give it for other manifestations of systemic sclerosis. Then came the SLS2, which is oral cyclophosphamide versus mycophenolate, 1.5 gram twice daily for 12 months, and it was maintained up to 24 months. The cyclophosphamide arm was switched to a placebo arm. And again, this was a non-inferiority study where they showed that the benefit of mycophenolate is as good as cyclophosphamide with less side effect profile. And this, I think, made a major change our practice. If we go 10 years back, I think I used to give a lot of cyclophosphamides. Over the last 10 years, I prefer mycophenolate due to the low side effect profile. SLS3, this is something new. This is patients, this was in Michigan, led by Professor Dinesh Khanna, where they gave mycophenolate, the maximum dose, 1.5 gram twice daily with placebo versus mycophenolate with pirfenidone, which is an antifibrotic approved for IPF, idiopathic pulmonary fibrosis. It downregulates TGF-beta and pro-collagen 1 and 2. And in the ACR last year, the data was presented, and they can see that there is an improvement in the decline in the FVC at 6 months in patients who were commenced on mycophenolate and pirfenidone versus pirfenidone. But again, this benefit collapsed after 6 months. So I think we need more studies. This was a phase 2 study. Rituximab, again, this was a proof of concept study, eight subjects, but I think we were waiting for such studies. We use it a lot in patients with ILD, and we are curious, does it work? Is it similar to the real world evidence that we know, or there's difference? And there was significant increase, and here they gave the dose of weekly dose of 375 milligrams per meter square over 4 weeks, and then repeated every 6 months. And again, there's a modest improvement in the FVC, and the DLCO increased significantly at 2 years, but it took a while to improve. With this concept, they gave another open label trial. They gave 18 patients where they combined rituximab and mycophenolate together. And again came a paper in 2021 where they combined. And I think that we do this during our clinical practice, but the message that we learned from these studies, that safety, I think we are always cautious about combining two therapies. If you give rituximab with mycophenolate, is there a risk of infection or neutropenia? What usually I do in my practice, when I give rituximab, I wait 4 weeks and I go down 50% reduction in the mycophenolate. I continue mycophenolate till the next infusion. But in this study, they didn't see any difference when they combined rituximab and mycophenolate. The only thing that they saw that there was a reduction in prednisone, but they didn't see any changes in the lung parameters. With this came this very interesting study from Japan, the DESIRE study, a very nice study. It made into 2 phases: the blinded treatment, where they gave placebo, which is background therapy with other immunosuppressive therapies, versus weekly dose of rituximab according to weight. And then they had 24 weeks, that's the primary endpoint, and then they switched everybody, the placebo arm and the treatment arm, they received the drug. And as shown here, it's very interesting that there was a split in the curve, both in the skin scores and in the lung parameters. When I hear from other speakers about the study, there's always concern about how the study was made, and the results are very impressive to believe. That's something, I think that raises a concern of rising questions. How do we get such a strong benefit? And the authors, if you read the limitations, that everyone receiving rituximab received a loading dose of steroids. And they conclude that maybe the benefit, that's robust benefit that you can see with the skin or the lungs, are from the steroids. And they concluded that maybe you need to run the study at a larger scale. This was also a phase 2 trial. OFIF, nintedanib, it's a tyrosine kinase inhibitor. This was the first FDA-approved medication for scleroderma. They had a placebo arm, or OFIF 150 twice daily. As shown previously also in the INBUILT trial, there was a significant decline delta change in the FVC over time in patients who receive the drug versus this drug is mainly given for lungs. There's no studies for the skin. And finally, we have the tocilizumab, which I was part of during the time I was in Michigan. And again, it's two studies. We have a blinded part and we have the open-labeled part at 24 weeks. And as you can see here, the primary outcome failed. However, if we look at the secondary outcome, there was a clinically meaningful improvement in the lung parameters in patients who were commenced on the treatment tocilizumab versus placebo. What if we reflect all these medications during our practice? This is from our registry in the UAE, and I think we are more in favor of mycophenolate. We did like a small subgroup analysis. I think it depends on the center, or sometimes maybe where you are trained or experienced maybe with treating such an orphan disease. In our center, we use more antifibrotic medications. We use more Celsep. I see in other maybe remote hospitals, they use cyclophosphamide, maybe because of insurance issues and other technical issues. This is a very nice algorithm that we recently submitted to the Lancet of Rheumatology. That's the one. And very easy to use. It's like the grappa during the clinical practice. And you can classify patients into subclinical ILD, and this in the small box tells you what's the meaning of subclinical ILD or clinical ILD. And then it gives you that high-risk population that you need to treat. High CRP, male, early disease, less than 5 years, and then it gives you this nice algorithm which medication to use. So it can help a little bit to tailor your options if you don't have that much support from a multidisciplinary meeting. This is a very simplified approach, and we recently published a paper stratifying the risk factors from a large cohort in Michigan, and these are the things that you need to be aware of, or the red flags that you need to be careful with in patients whom are at a higher risk of developing ILD, including males, early disease, high CRP, if there's an extent more than 20%, anti-topo isomerase positivity also were associated with a rapid decline in the positive predicted forced vital capacity. Finally, I think this is the most important point. I think this is not a one-man show. It's hard to treat a patient with ILD by yourself, with scleroderma ILD. You need this multidisciplinary approach. What we do on Tuesday, we send all the patients that we need to discuss. On Wednesday, we meet. As you can see, it's a very large team. We have 12 pulmonologists, we have pathologists, and then we formulate a note, even for legal purposes, and we keep it for our patients. And then we, again, re-evaluate patients in another couple of months. With this, I would like to thank you for your attention, and I'm happy to address any questions. Thank you very much.
We open the floor for questions.
I would like to thank both speakers for giving this review on ILD and CTD. My question for both speakers about the use of azathioprine in patients with ILD. Now, studies have not shown a clear efficacy either in induction compared to cyclophosphamide or even in maintenance. So how much do you advise the audience on using azathioprine in patients with ILD, CTD, regardless of the underlying disease? About the use of azathioprine in the treatment of ILD and CTD.
So, if maybe we go 15 years ago, maybe we had limited options. Currently, we have more options to offer to our patients. For ILD, I won't prefer it. I think, as you shown, this is one of the studies that shown actually a negative. There was even a modest improvement of the lung parameters. So It's like giving a placebo. So it won't be one of the options I offer to my patients with systemic sclerosis ILD. We have now tocilizumab, we have OFIV, combination therapy, CELSIP. I think we have other options that we can offer patients.
Any other question, Naif?
Yeah. I think the mic here doesn't work, but in any case, even in the non-CTD ILD cases, we have moved away from azathioprine to mycophenolate mofetil. The efficacy is a little bit better. The safety profile is better. I have rarely seen a patient who comes to me complaining of the side effects related to CELSIP. So I do have a success with it in CTD ILD and even non-CTD ILD when anti-inflammatory medications are needed.
Yes, I have a question for Dr. Al-Ghamdi. You showed us that interleukin-6 inhibitor worsen the lung disease. Sorry. You showed us that interleukin-6 inhibitor worsened ILD in patients with rheumatoid arthritis. Is there an explanation why it's worsened the lung disease in RA while it improved it in scleroderma?
So the question why an RA patient had worsening of ILD, so the 11%, the one that you showed us, so in comparison to the patient with systemic sclerosis and Actemra being used in that cases, why there is a flare in RA or progression in RA? Is there any explanation for that?
Yeah, you mean tocilizumab, right?
Tocilizumab,
yes.
Yeah, well, if you look at all the agents that are being used, whether it is rituximab or tocilizumab or abatacept, or JAK inhibitor, they all have a percentage of worsening of the ILD over time, but it is varies among the agents. Why it is that with tocilizumab, where it was better in scleroderma, I don't have the answer myself. I didn't dig and look into the details of that, to be honest with you, and I don't know if there is an answer really. I just need to look it up. I'm not sure.
I think we're talking about different diseases here. Even if you look at the CTs, it's a different pattern. So you're talking about an NSIP more predominant pattern versus a UIP pattern.
The question is that because when you look at the British Society of Rheumatology, they say that patients with rheumatoid disease and ILD, they recommend tocilizumab and rituximab. But Dr. showed us that no, in patients with RA, it's actually tocilizumab worsened the lung disease. This is why I was
maybe you got it. Maybe you got it mixed up. I didn't say you don't use tocilizumab. I said among the 4 agents that are biologic, rituximab, abatacept, and TNK inhibitor, and tocilizumab, and the JAK inhibitors, tocilizumab will be number 4 in your list. Rituximab and abatacept will be the first 2. And JAK inhibitor would be number 3. I didn't say don't use it, but the worsening of the disease over time was noted more on the tocilizumab group within these 4 agents or categories of agents. I'm not saying don't use it. It is there and listed and you are right, but it is not the most preferred agent. I would still go for rituximab or abatacept, then JAK inhibitor, then tocilizumab. And as Dr. mentioned here, the UIP frequency among RA ILD is higher than scleroderma, and that's probably a reason why there is a difference in the effect of tocilizumab between the 2 disorders.
Last question, please.
I would like to thank both speakers for their amazing talks. My question to Dr. Namaz regarding the use of low-dose steroid in patients with ILD and systemic sclerosis. We noticed some of our colleagues in pulmonology, they used to and still managing patients with NSIP pattern ILD with, in addition to the standard care of therapy, some with a lower dose of steroid. But with the concern in systemic sclerosis, the risk factor of renal crisis, use of a dose of steroid. What is your comment in using low-dose steroid in patients with scleroderma for the ILD?
So the question, sorry the noise, but the question is about using oral glucocorticoids in patients with ILD. of course, as you mentioned, you should be cautious with using steroids in patients with scleroderma, especially if they're high risk. They're also a high risk of developing renal crisis. The preferred dose, is, as you know, it's less than 20 milligrams. Now, it's sometimes, so in the beginning we start steroids if they're in an acute exacerbation, and then by time, we can wean them off. Now, most of the trials, they pulse patients with steroids, whether with rituximab or the other, so they give like a pre-treatment. So they give either 125 or, there's a couple of case reports that patients develop renal crisis with pre-treatment, so you should be cautious with that. Do we prefer to keep it for a long period? No. However, still sometimes we are challenged that patients are still on a low dose of 5 to 7 milligrams. I have a couple of patients, I could not go below 5 milligrams. Even though, the target of using such medications is to wean them off prednisone, but I think there's a couple of cases that you'll be challenged that you'll keep them on a long-term steroids.
By the way, even for RA-ILD, we don't like to keep the patient on high dose of, on maintenance dose of steroid above 10 for a long time because of the infection. And when it happens, it's usually serious.
Okay, I think we don't have any more questions. We'd like to thank our speaker. We are supposed to have a satellite symposium now by... Okay.
ثم الدكتور محمد الغامدي. والدكتور راجي. شكرا جزيلا. الأخوة المتحدثين في الجلسة السابقة في أحد ناسي جواله آيفون. اللي ناسي جواله على الطاولة من المتحدثين ارجع يسلمه أو الله يجزاه خير. دكتورة أبو جمل. أيوة والثاني سادة والسيدات، يسر المؤتمر أن يكرم كل من البروفيسورة بسنت ندي والبروفيسور أحمد أبو جمل على مشاركتهم بورش عمل في هذا المؤتمر. Ladies and gentlemen, let's move to a satellite symposium sponsored by Puringer. Please join me welcoming Dr. Walid Hafez. أعتذر منكم في تكريم لدكتور عطلة العنزي. اي نعم، دكتور عطلة العنزي. نعود مجددا إلى الدكتور وليد حافظ for satellite symposium sponsored by Puringer.
كذلك التكريم للدكتور يوسف العماري.
السلام عليكم. So زملائنا في ال IT, can you please put up the slides? IT colleagues, can you please display the slides? Yes, thank you. طيب, بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It's a pleasure and an honor to stand here before you to present a few slides on nintedanib in the management of systemic sclerosis associated interstitial lung disease and other connective tissue diseases. I would like to thank colleagues in Boehringer Ingelheim for this kind invitation to present this satellite symposium. I would like to thank colleagues at the Saudi Society for Rheumatology for inviting me and giving me the opportunity to stand here in front of you. So we all heard in the previous presentations on the two landmark studies that were presented or conducted in patients with connective tissue disease associated interstitial lung disease, which are both the census as well as the EMBOLD trial. So in this 10 to 15 minute talk, I'll be uncovering and providing you with some of the subgroup analysis that was conducted in these patients post studies. These are my disclosures, and so I will just quickly remind you with the census trial. So basically, census trial was a study that was done on nintedanib for patients with systemic sclerosis associated interstitial lung disease. And as you can see that the primary objectives for this study were to investigate the efficacy and safety of nintedanib in patients with ILD that is associated with systemic sclerosis. Now, patients in this study were randomized either to nintedanib arm, receiving a dose of nintedanib 150 milligram BID, or to placebo group. And patients who were included in this study were to be 18 years of age and older, having a systemic sclerosis that is diagnosed based on the 2013 ACR-ULR classification criteria. And they were also supposed to have like an extent of fibrotic lung disease on HRCT of more than 10%, which means that they were having intermediate to extensive lung involvement. Patients were excluded if they were having an elevations in their ALT and AST, and we know that because of the hepatotoxic side effect of the nintedanib. Patients who were actually showing active disease or other comorbidities that will not keep them in the stable phase, they were also excluded from this study. Medications were allowed, so prednisone at a dose of 10 milligram or less, or the patient medications that were on when patients were recruited in the study, provided that they were on the same medicine for at least 6 months or more. Any other medication was excluded from the study, especially if patients were taking medications within 2 to 3 months of the study. Now, the primary endpoint was the decline in forced vital capacity over 52 weeks. And what was noted, as you can see here in the bar chart on the left side of the screen, that nintedanib was able to preserve lung function in patients with systemic sclerosis in more significant way compared to placebo, with a relative risk reduction of 44%. Now, if you look at the curve on the right side of the screen, there was also a significant change in the both study groups when it was compared to the baseline, where nintedanib was also able to preserve lung function in better percentages and in more significant way compared to placebo. Now, the secondary endpoint of this study was to assess the effect of nintedanib on skin, thickening, and unfortunately, the secondary objectives or the secondary endpoints of this study were not met, which resulted in the approval of nintedanib to be the first, antifibrotic medications that is approved by the FDA for the management of systemic sclerosis-associated interstitial lung disease, with no much impact on the skin sclerosis. Now, I'll present one sub-analysis or subgroup analysis of this study. So as you remember from the inclusion criteria and the medications that were permitted in these patients, there were patients who were on mycophenolate. So there was an interesting idea to see whether or not patients who were on mycophenolate baseline and they were, started also on nintedanib. So did the combination of nintedanib and mycophenolate do better compared to nintedanib alone? And as you can see here that the rate of decline in patients who were on nintedanib plus mycophenolate was numerically better in comparison to patients who were on nintedanib alone and they were not taking mycophenolate. However, this was not statistically significant. On the other hand, if you look at the bar chart again, that is represented in light blue, at the left side of the screen, you see that patients who were on placebo, but they were taking a baseline treatment of mycophenolate, they were able to preserve their lung capacity in much significant fashion compared to patients who were not receiving mycophenolate. So the bottom line or the summary of the study, that if you have a patient who is receiving nintedanib as well as mycophenolate, so this combination is safe. However, if a patient develops GI-related side effects and you have to discontinue one medication, discontinuing mycophenolate will not result in significant decline in patients who are on nintedanib alone. This was like the first study. The second study was the INBOLD trial. So the INBOLD trial was conducted in patients who have connective or interstitial lung disease of the progressive fibrosing phenotype. The primary or the objective of this study was to investigate the efficacy and safety of nintedanib in patients with fibrosing interstitial lung disease with progressive phenotype. And again, patients in this study were either randomized into a nintedanib arm, and they were receiving nintedanib 150 milligram BID, or placebo arm. The inclusion criteria were again patients who are 18 years of age and older who are actually having interstitial lung disease other than the IPF, and these patients were to be showing the progressive fibrosing phenotype, which means that they were having like more than 10% fibrosis in their reduction in their forced vital capacity, along with either, worsening respiratory symptoms or worsening, fibrosis on HRCT. Now, if you look into the patients that were recruited in this study, and if you pay attention to the ones that are highlighted in red, these are the patients who were having autoimmune disease that resulted in interstitial lung disease. So we had patients with rheumatoid arthritis, we have patients with systemic sclerosis, we also had patients with mixed connective tissue disease, as well as we had some other fibrosing interstitial lung diseases in which we had patients who had underlying systemic lupus erythematosus as well as Sjogren's syndrome. Now, the same thing, that so medications that were allowed to be continued in these patients are the medications that were being taken by the patients at least for more than 6 weeks prior to randomizations. Any other medication that was introduced within like 4, 6, or 8 weeks into the or prior to randomization, those patients were excluded from the study. The primary endpoint was the annual rate of decline in forced vital capacity that was assessed over 52 weeks, so 1 year. Now there were like two important like population in the study. So the overall population in one side, and in the other side the population who were having the fibrotic or the UIP like fibrotic pattern on interstitial lung disease, or sorry, in HRCT. So as you can see here, that nintedanib, that is represented in dark blue here in these bar charts, was able to preserve lung function in the overall population, as well as in patients who were showing fibrotic patterns, such as which was like UIP-like, as well as the non-UIP-like pattern, compared to placebo in significant percentages, and this result actually provided us with the evidence of extrapolation of the nintedanib indication to other rheumatic diseases other than systemic sclerosis. One of the subgroup analyses that was conducted in patients who were recruited in this study was looking into the effect of nintedanib on a forced vital capacity decline and its safety profile in the different subgroups that were presented in this study. For the sake of for the purpose of this presentation, I'll be focusing on the CTDs, or the autoimmune diseases. So you can see that we had approximately 13% of patients were RA. We had approximately 18% of patients, or 19% of patients who were having NSIP pattern, and you can see that 6% of patients were systemic sclerosis. So approximately we had 20 to 25% of the population in this study were having interstitial lung disease secondary to an underlying connective tissue disease or an autoimmune disease. Now, taking you to the results, immediately. So if you look at the forest, plot here, and if you look at the line of no effect, that is, represented by 0 here, you will be noticing that the autoimmune population in this study were showing, lines that were towards the right side of the curve or the line, which represents or which favors the positive effect of nintedanib in preserving lung function in these patients. And the results that are, presented in, blue circles show you the percentage, or the preservation of lung function in these patients compared to placebo. Now, so that was for the overall population, and the same thing actually applies on, populations when they were, either stratified into UIP-like pattern or the other pattern. So you can see that all these, lines are moving towards the right side of the line of no effect in this forest plot, which means that patients were having, significantly preservation of their lung function compared to placebo. Safety and tolerability, again, this was another subgroup analysis in which they were looking into the safety, and I'll take you immediately to the result slide. So if you see that patients on nintedanib arm, when they were compared to placebo, if you look at the rectangles and that are highlighted here in red, you see that there was no statistically significant difference between both groups when it comes to any adverse events or severe adverse events or serious or fatal adverse events. The only side effects that were seen more in patients with nintedanib compared to placebo were actually 2 side effects: GI-related side effects, so more of nausea, more of a diarrhea, more of vomiting, decreased appetite, as well as weight loss. And the second side effect profile that was noted in patients with nintedanib compared to placebo is the increase in the transaminases, so high ALT and high AST. However, it was evident in the study and again in the real world practice that proactive management of these GI-related side effects can definitely decrease the side effects in patients with nintedanib. That's number one. Number two, interruption of nintedanib treatment resulted in the improvement in these patients without actually worsening of the pulmonary function or the forced vital capacity in these patients. Number three, that decreasing the dose of nintedanib from 150 BID to 150 daily also helped improve these side effects without decreasing or showing further decline in the forced vital capacity. So to summarize the subgroup analyses that were conducted on the INBOLD study, we can see that there is a group of patients with progressive fibrosing interstitial lung disease other than IPF who exhibit a disease course which is similar to IPF. Nintedanib had a consistent effect on reducing the rate of forced vital capacity decline across subgroups, including those who were patients with autoimmune related interstitial lung disease, both in the UIP and the other fibrotic patterns on HRCT. The safety profile of nintedanib in subgroups by ILD diagnosis was consistent with overall population. And with that, I would like to thank you for your kind attention and listening, and thank you. Any questions? I'll be more than happy to address. Thank you.
شكرا للدكتور وليد حافظ. السادة والسيدات، ستكون هناك 3 ورش عمل. ورشة العمل الأولى هنا في هذه القاعة الرئيسية، وورشة عمل في قاعة الرياض، وورشة العمل الثالثة في قاعة جدة. نلقاكم بمشيئة الله تعالى في ورش العمل، وغدا بمشيئة الله تعالى في تمام 8 صباحا لاستكمال جدول أعمال المؤتمر السنوي التاسع للجمعية السعودية لأمراض الروماتيزم. إلى ذلك الحين نستودعكم الله والسلام عليكم. شكرا.